sir, faculty members, Dr. Samir Bhargava, Dr. Gaurav Medikari, Dr. Anaga Joshi, Dr. Kshitish Shah. Myself, Rakesh Mehta, on the behalf of entire ADEPT family, I welcome you all to the most prestigious scientific feast of Swiss CV ADEPT IRIS. We at ALChem are extremely honored and feel privileged to have you as our guests. At the outset, let me thank each one of
Recording in progress.
Each one of you from the around 10 different locations online for being in this, taking your time in the busy schedule to attend the scientific feast. As which CV ADEPT IRIS was initiated last 3 years ago with an objective to update you with the recent techniques. IRIS itself stands for improving results in surgeries. With each of the year content has become richer with all the relevance to your clinical practice. This year, ADEPT IRIS become most sought after event in the phygital model, where a day one program at Bombay and physical event is happening, followed by the surgery demonstration, which can be seen across India. On day two, there will be a cadaveric dissection, a demonstration by Dr. Reda Kamel, which will be streamed live location from Egypt, and this can be seen via link. Science is the fulcrum of all our endeavor, what we do at ALChem. The Swiss CV ADEPT IRIS is one of the such initiatives from the house of ALChem, and ALChem, since its inception since 1973, we grown leaps and bounds with the scientific events moving forward. As we look forward in the illustrious journey of ALChem, 5 decades, ALChem has come into the rank of 4th rank as India's fastest growing organization, with the rank of 4th in the Indian pharmaceutical industry. And ALChem also has a global presence of over across 50 countries. ALChem has globally approved manufacturing facilities and is backed by the cutting edge R&D with almost 500 scientists working from the basic research to the getting the product in the market. We have our brand exclusive portfolio of iconic brands like Pan, Pandi, Zone, Switch CV, Pibzo, which made ALChem strong with your strong support. And our dominance in anti-infective segment has remained unchallenged for last decade or so. Now let's have a look forward the journey of ALChem and our corporate achievements so far, all because of all of your continuous support. May I request for a EV, please?
Doctors to date.
The world over, businesses
brands,
exist to solve people's problems.
in
And when a business is
in
about
India
providing
and have
healthcare,
also been
we
witnessing
need to be
constant
responsive
growth
and
in other
adaptive to
therapeutic
changing
areas
needs of the
such as
society, providing the
gastrointestinal,
right drugs
pain
and the most
analgesics,
effective treatment.
vitamins,
minerals and nutrients,
changing lifestyles,
neuropsychiatry,
changes in food
dermatology,
supply chain,
and
overall
cardiodiabetology.
changes in
We
the
are making
environment,
steady
all
inroads
of
into
which
the
are reflected
the
in
world
society's health. Businesses
and
exist
will
to
be
solve
bombarded.
people's problems.
Pregnancy
And
test
when a
kits
business is
and
about
and
providing
condoms was
healthcare,
born in
we need to be
1970s.
responsive at a time when adaptive to the changing needs of the society, providing the right drugs
prominent brands of marketing effectives to the market.
We have continued to change lifestyles, changes in food supply chain, and overall changes
We
in
are
the
number
environment,
one
all of which are reflected
in
in
India.
society's
And
health.
have also
And
been witnessing constant growth
We
in
have
other therapeutic areas
ideas
such
such
as
was born in
gastrointestinal, pain
1973,
and analgesics,
a time when infections were the biggest
minerals
threat
and
to humanity.
nutrients.
We brought several
Neuropsychiatry,
prominent brands of
dermatology,
anti-infectives
and
to the market,
cardiodiabetology,
which continue to
We
be
are
popular
making
with
steady
doctors
inroads into the
today.
exciting
With
OTC
over
products
700 brands,
we are number one in anti-infectives in India
and condoms, and have also been witnessing constant innovation has ensured therapeutic areas such as gastrointestinal, today,
and
our markets
analgesics extend to
vitamins,
more than 50
minerals and
countries
nutrients,
worldwide.
neuropsychiatry,
growing rapidly
dermatology,
in majority
and
of the markets through our
cardiodiabetology.
subsidiaries
We
and
are making
strategic
steady
acquisitions
inroads
into the exciting
to
OTC
constantly
products
meet
market
the
demands of the
with
global
pain relief
population.
balms,
We have 20
pregnancy test
manufacturing
kits,
units in India
and
and
condoms
in the United States.
Constant innovation
Since
has
inception,
ensured that our
Alchem
products
has maintained
succeed
a
at
strong
a global
level.
research. Today,
We believe
our
that
markets
there is
extend to more
always
than
a better
50
solution.
countries worldwide. Today, we
Over
are growing
500
rapidly
scientists
in
are
majority
working
of the
actively
markets
to
through our
create more
subsidiaries
efficient
and
formulations
strategic
across
acquisitions.
various therapeutic areas.
To constantly meet
Through
the
its
demands of
journey
the
of
global
4
population, we
Alchem
have
has
20
deeply
manufacturing
risen to
units in
become
India
the
and in the
largest
United
pharmaceutical
States.
company in India.
Since inception,
The thrust of the
Alchem
company's
has maintained a
success
strong
comes from the
focus on
vision
research,
and direction
for
of
we
our
believe
legendary
that there
founders,
is always
Mr.
a better
Sampada Singh
solution.
and
Today,
Mr. Vasudev
over
Narayan
500
Singh,
scientists
who are among the
working
most
actively to
respected
create
personalities
more
in
efficient
the pharma
formulations
industry
across
various
serving
therapeutic
humanity areas.
involves serving people
Through
in
its journey
different
of 4
ways.
decades,
And our CSR
Alchem has
initiatives
deeply
have
risen
impacted
to become the
communities in
5th
myriad
largest
ways.
myriad
From providing
ways,
healthcare
from providing
to
healthcare
encouraging sports,
to encouraging
Alchem
sports.
undertakes
Alchem
diverse
undertakes
community
diverse community initiatives to uplift the
disadvantaged
disadvantaged sections of the society.
We will always
We
be
will
committed
always
to
be
provide
committed
people
to provide people with
health,
smiles
and
health,
unlimited
and
opportunities
unlimited
to
opportunities
achieve their
to
dreams.
achieve their dreams.
Alchem Laboratory,
Alchem Laboratory,
extending life care,
extending life care
boundaries.
beyond boundaries. The world over,
Thank you. My sincere gratitude to all the panelists and our esteemed delegates for being the part of Switch CV ADEPT IRIS, and I look forward for mutually beneficial relationship in times to come. With this, I would request Dr. Renika Bradu, ma'am, to take the scientific session ahead. Over to ma'am.
Good af- Good afternoon, ladies and gentlemen. It is my privilege to convene this meeting. It has been a very difficult and challenging process to get this meeting to its fruition because of various reasons that we know. And I'm truly grateful to those who are attending, especially because we have such a fantastic scientific lineup for all of you. We begin today's meeting with a panel discussion on complications in endoscopic sinus surgery. And we have a very esteemed panel to discuss and to address any questions that you may have across the country on this particular topic. let me invite Dr. Samir Bhargav onto the podium. Dr. Samir Bhargav is the professor at the HBT Medical College and the Dr. R.N. Cooper Hospital. He has been the president of the AOI national body a year ago. He is been Mumbai nominated by India Today as the Mumbai's top doctor for 3 consecutive years. He is also a very active Rotarian, and I know that he follows in the footsteps of his father, Professor Dr. K.B. Bhargav, who was my teacher as well, who did a lot of work for polio eradication in India. And I'm sure Samir is equally active in the Rotary. May I request Dr. Gaurav Medikeri to please come to the stage. Dr. Medikeri is the rising star in the ENT firmament, especially in rhinology. Dr. Medikeri has done a fellowship in rhinology and skull-based surgery from UK, Liverpool, and has done a rhinoplasty fellowship from Seoul, Korea. He is very active with the academic programs as of now, and will continue to, I'm sure, grow from strength to strength. May I request Dr. Anagha Joshi? She is the professor of the department, ENT department and head and neck surgery department of Lokmanya Tilak Municipal Medical College, Sion Hospital. She surgically wears many hats, and I don't know of any surgery that she doesn't do with confidence. And she is specializes, besides in rhinology, also in the field of laryngology. And she is a dear friend. May I request Dr. Kshitij Shah to join us on the podium? Dr. Kshitij Shah is the associate professor at Lokmanya Tilak Municipal Medical College and General Hospital. He specializes in head and neck surgery and has been instrumental in putting the head and neck surgery oncology program, oncosurgery program, into giving it its present face at the Sion Hospital. May I now request Professor Emeritus Padma Shri, Dr. M.V. Kirtane, to please come and moderate this session on complications. Anything I might say about Dr. Kirtane falls short of the great deal of respect and admiration he commands throughout the world. Sir, I'm very grateful for you. You are a guru to almost the entire nation as well as internationally. May I request you, sir, to please take over.
Thank you, Renuka. It's a privilege to be here for this program, and thanks to the team Alchem. They've been conducting these academic programs for the past many years. And what I would really add here is that is literally, or what they call an unrestricted educational grant. They do not interfere in any way in the scientific program, which is organized by her or by me. They give us the total freedom to do it exactly as we want. They just stand behind us in support for this educational activity. So a really very big thank you to Team Alchem. Usually one is asked to speak on or conduct something that he is good at. So I've been asked to talk on complications. So Renuka, I hope that was not the...
Sir, we can always count on your mischievous sense of humor.
Okay. You know, breast surgery, can I have the thing? You'll have to connect my laptop to... I don't think this is necessary. I've got 100% charge there, so just keep it. Yeah. बट कुछ कनेक्शन डाला ही नहीं ना।
ऑलरेडी जूम कनेक्टेड।
अच्छा।
Say you have any video?
Hmm?
Have any video?
Yeah. वीडियो में आवाज नहीं है, volume नहीं है, आवाज नहीं है। मैन्युअली करें। अच्छा, दिस इज फॉर पॉइंट। मैं पॉइंटर नंबर बहुत
From this year? Yeah.
Yeah. Okay. So doing sinus surgery is something like overcoming these obstacles as you go along, starting with the various partitions that you encounter, and a good knowledge of the various partitions and their attachments is extremely important in doing the surgery adequately and avoiding complications, because complications can occur when you least expect them to happen. And for preventing complications, which is better than actually treating them, prevention is better than cure, preparation is the key. As a matter of fact, Ben Franklin said, by failing to prepare, you're preparing to fail. Now, complications can be classified according to anesthesia related, during the operation or post-operative, or you could classify them as intranasal, orbital, intracranial, or you can temporary, permanent, or even as major and minor. So I think for our clinical purposes, we would say major and minor classification is the important one for us. And there is a huge number of complications that can occur with this surgery, as you can see. So we'll try to see some of the more important ones as we go along. Major ones first, maybe minor later. So as Benjamin Franklin said, by failing to prepare, you're preparing to fail. So let me start with Kshitij. How do you prepare? You're planning surgery for a patient. What is the preparation that you would want to go through to make sure that everything is set for the surgery?
Thank you for the question, sir. The arrow is quite strategically posed. It's as if you're going to enter his nose with an endoscope. So I think the preparation starts off with right from deciding which kind of case do you want to operate.
I don't know what arrow this is. My arrow is here somewhere.
Anyway, the preparation is going to begin in the OPD. When you start first consulting the patient to look at what kind of diagnosis you've come to, you would obviously want a CT scan to reach appropriate diagnosis. And depending on that, you're going to decide on a surgical step and a surgical plan. So preparation begins. So for example, if you're looking at a case of a sinusitis versus a case of a polyposis, the preparation would vary. And as I said, the first decision you take is whether the patient needs surgery or not. That's the first.
So you've decided this patient
decided.
has to go for surgery.
Okay.
So
we would always, I would always look to first medically prepare the patient, because you do not want to be operating unless really there's an indication in an acute sinusitis scenario.
So let me then rephrase the question. What is the medical treatment that you give, for example, in a patient with sinusitis before you decide? Something they call the maximal medical therapy. So just define your maximal medical therapy.
Correct. So my maximal medical therapy would be a course of antibiotics. I would prefer either amoxiclav or a levofloxacin as the first line treatment, at least for 5 to 7 to 10 days. Along with that, I would give decongestants and some mucolytic. And I do depend a lot on steam inhalation, because I want the patient feeling almost asymptomatic when I'm going to take him up for surgery.
He may not come for surgery, he's really asymptomatic. Gaurav, anything to add to that?
I think we also need to document if the patient's got any comorbidities, because we're also dealing with the anesthetic complications. So if the patients are hypertensive or very high blood sugars, HbA1c is super high, then you want to take your time, bring those parameters down, and then probably take him
Do
up.
you include steroids as a part of your pre-op therapy?
I do. I think the only point where I differ with Dr. Kshitij is if the patient does not have an active infection, I probably might exclude the antibiotic and in fact give a probiotic because there is evidence that there is some amount of nasal dysbiosis which actually leads to this problem. So I would not, unless there is frank purulent discharge, may not give antibiotic. But yeah, I would like to give steroid for the two reasons for that. One is I want to know if the surgery is going to work. If the patient has got a good response to oral steroids, that means the surgery is actually going to work for him, because post-operatively we're going to do a steroid rinsing for the patient. And second thing is I want to test how good his sense of smell is going to be once we give the steroid, because I don't want to be labeled as the person who took away his sense of smell. So we want to know that before surgery.
You want to document that as well?
Yes, yes.
Okay, Samir, anything to add?
No, absolutely. In fact, this point regarding whether the smell
No,
came
this
back.
Already talked about the therapy, but
Yeah.
any other investigations you want to do as
So I
preparation?
also asked the patient if the patient is on any blood thinner, aspirin. So that is something that I deliberately asked, because a lot of time they've been taking it for so long that they forget to actually tell you that they're
Mention
on
it,
that
yeah.
medication.
Yeah, and today a lot of patients are getting it even without having actual cardiac disease as a prophylaxis. So very, very good point there. Yeah.
So yeah, more or less rest whatever they've covered.
Anaga, anything to add? What else do you want to do before you take the patient on the table?
As regards medical treatment, I think we have covered that.
Mhm.
We need to, apart from the blood thinners, we also need to know there are certain naturopathies that the patient may be on, like ginkgo biloba or something, or aspirin, which needs to be stopped before the surgery. And I think we'll be talking on the CT scans later, right?
So you will be
medicine.
doing the imaging. So that's why we'll come to that in a minute. Just one question, Renuka, how much do you talk to your patient in counseling about possible complications?
So it depends. First of all, I do the counseling only after I've done the CT scan, because then with information of the CT scan, I will be able to counsel better. And what I do usually is put up a coronal scan so that the patient can identify the eyes and the nose. And then I use that while explaining different points. Now, it depends on how much to tell the patient, depends on a couple of things. One is, what is the pathology? So, for example, if it's an antrochoanal polyp, then I will not be talking to him about vision or CSF leaks. I will talk to him exactly about the choanal polyp, and I will not mention those other complications at all. But if I'm dealing with something where the skull base is eroded, or where the orbit is extensively involved, then I will take consent for vision, impairment of vision.
So related to the
Yes,
pathology is what
related
you would
to the
talk about.
pathology.
Okay.
And the other thing is that the other place where I will go into details is when the patient has Googled and come. So if he has Googled and come with a lot of queries, or I get the feeling that he has, has significant questions, I will then address all the complications, even if it's for an antrochoanal polyp.
Yeah, because if you leave it out, he'll tell you, but you didn't mention this.
Yes,
Okay.
yes, absolutely.
What about
document,
recurrence?
I also document it written.
What about
Patient counseled about the different points.
What about recurrence? How many of you tell the patient about the possibility of recurrence? So that is
Always,
something
sir.
which is upfront, you should be able to tell them.
Always.
Okay. So I think those points are more or less what we talked about are covered here.
So, but regarding recurrence, we must always mention that, give them a number which is more kind of, something that will not scare them away, because otherwise they will never land up for surgery. But definitely make it a point to say that, yes, that it can recur, and give some percentages.
Can
Okay,
I
yeah,
can I add to this? So when I talk about recurrence, I explain to the patient that this is not something like a tumor, it's an inflammatory disease, and that inflammatory pathology is within the patient, and that needs to be taken care of by regular treatment, regular follow-up, and the control of the allergy. So we will remove the disease. I'll remove the disease completely and make the sinuses clear. But henceforth, the patient has to take care and take medicines regularly or nasal douches regularly to prevent the
But
recurrence.
even if they take anti-allergic treatment and
Yes.
douches, the possibility of a recurrence is always there. So, okay, so we're talking about imaging, right? So what are the, so let's start with Renuka, we'll go in reverse order. What is the imaging that you ask for usually?
So, sir, first of all, the timing of the scan.
That's very good, yes.
So if it is sinusitis or polyposis, then I will take, we've already mentioned maximum medical therapy. I will do all of that before I do the CT scan. And I always tell the patient that we must do it as when you're feeling the best that you can. So you pick up irreversible disease. If on the other hand, it's a tumor, then I would not wait. I would do a scan immediately, irrespective of medical preparation. I ask for both bony and soft tissue cuts, but the roadmap is decided on the bony cuts and the soft tissue pathology on the, like double densities or something on the soft tissue cuts. Anything which has gone outside the sinuses, into the orbit, into the infratemporal fossa and intracranial, especially orbit and intracranial, I will also ask for an MRI.
When
And-
would you ask for contrast enhanced?
So contrast enhanced, I will always ask for a contrast enhanced MRI for the pathologies in the orbit and intracranial, but specifically because if something is in the cavernous sinus, a CT with contrast will make the artery enhance as well as the tumor. Whereas in an MRI with contrast, the tumor will enhance, but the artery will look black because of the signal void, because of the high flow of blood. And therefore, you can make out the interaction between the tumor and the carotid much better on an MRI with contrast rather than a CT with contrast.
Yeah, Anaga, anything to add to that?
So for any unilateral nasal pathologies, I would always like to ask for a CT scan with contrast. And also for the residents, I would like to emphasize that should not ever mention that just limited PNS cuts, because it is not just the presence of the pathology that you want to see. You want to make it as a roadmap. So it has to be, you have to visualize these scans serially to look for the details of the anatomy as well as the variants in the anatomy.
Okay, anything to add to that?
Probably if I'm suspecting an inverted papilloma on the CT, then in some cases I would ask for an MRI that will give me a little more idea about the attachment.
So she said if there's a tumor suspected or if there is an extra sinus spread which is suspected,
Right.
the question is, a lot of patients will come to you with reports. Scan to lion is up, but report hai. So how much do you depend, Gaurav, on the report given by the...
Sir, actually, I think in 90% of the cases, I don't really look at the report before I read the scan. And it is just for me to check whether I've missed something. One point that I would like to add is I usually prefer them getting their DICOM images. I don't want them to get a film. I tell them to get a DICOM image and I make a copy of that and I keep it on my hard drive. Because 7 years down the line or 5 years down the line, if there's a medical legal issue, I need to be able to go back and pull out that record and check for myself.
Is it only from the medical legal or you prefer to scroll up and down as your...
Yeah, I do that as well. So the continuity in the images is much better. And the DICOM images usually have more than thousands of images. If you have got a 0.625 mm cut, and you can also do a 3D reconstruction.
While the printed will only have limited images. But even then, at least I would like to have the images hanging in the
OR.
Yeah. Because sometimes you find yourself a little lost and you want to go back and refer to it. And I also prefer to have them in all the 3 planes.
Yes, yes.
Right. Okay, so we will not go into this now. Let's start about at the table, operation table. Any instructions for the anesthetist, Kshitish? What do you expect from your anesthetist?
So you've nicely actually put up everything out here. So yes, we want controlled hypotensive anesthesia. Have discussed with the anesthetist, don't have a documentation, but you've taught us the mean product of the mean arterial pressure and the pulse rate to be about 6,000. And yeah, so that is, that's right over there. So that's
so
what
mean pressure is not just systolic plus diastolic divided by 2. That's the formula. And you multiply that by the pulse rate and the product if it's less than 6,000. So sometimes you may not be able to bring the blood pressure down, but you could bring the heart rate now.
And just a point, and that is very often you've got a field which is saying 100 systolic also. So good BP, but the pulse could be about 100, 110.
So
And
they
then
bleed.
that's when you struggle. So this formula is
So you
really-
just have to know this so that you can tell the anesthetist that something needs to be done. But I think we'll leave this out for the time being. The other thing that you should do is take away the mobile phone from the anesthetist.
So we sometimes give them our mobile phone.
No, because they're all the time, you know.
So if I can add one point, which the anesthetists have got across, is they very often also look at the ETCO2 levels, because a hypercarbia or a CO2 retention
also
gives a
lead to
diffuse bleed. So that's one thing which
Okay,
is
so
not.
now let's come down to the meat of it. You have a field that just keeps on oozing. Every time you put in the scope, just having oozing from all round. Does that happen to you anytime, Samir? And if that happens, what do you do?
Yeah, so if there is a diffuse ooze, the first thing I will recheck whether the positioning of the patient is fine. So make
Head
sure that the
elevation?
head elevation.
Hmm.
If there is a diffuse ooze, I will pack that side, take out the pack after a minute or so and recheck that. And if it is still continuing to bleed, maybe then I will go on to the other side, let that work. And use a little more concentrated adrenaline at certain areas if I find that it
I'm
is,
going to ask you to define a little more concentrated.
So the concentration of adrenaline that I use is what Sir taught me many years ago, which is 6 ampules in 30 cc's. That is the
So 1 in 5.
concentration. Pardon?
1 in 5.
Yeah. Although the anesthetists now with better monitoring are not so uncomfortable with more and more use of adrenaline, I must add, because maybe 15 years ago they would absolutely.
But
I mean,
I think you also have to draw the line somewhere. I was talking to Janki. He's going to be demonstrating something. One day he told me 29 ampules of adrenaline in one case. I think we have to be reasonable. And I think if you apply it for some time and be a little patient, then it works. You don't pull and, you know.
Yeah.
Also, the other thing is be gentle with the tissues. Yeah.
So I use a lot of warm saline washes if there's a general ooze. So that helps. And about adrenaline, I may have one patty of 1 in 1,000 adrenaline, which I may put in the frontal recess or just at the ooze, but very sparingly and very rarely. Frontal recess because you want it to decongest so you can see better and you don't get mucosal tears.
So this is something which, yeah, you wanted to say something, Gaurav. Go ahead.
So we can supplement that with 1 gram of tranexamic acid. You just tell your anesthetist that. There is also evidence to prove that when you do give that, within about 5 to 7 minutes,
The oozing will
come
less.
down.
Yeah. So that's given IV.
Yes, sir. Yes.
Right. But if you do run into a situation where you're just not able to get that thing off, would you agree that the best thing to do at that time would be to stop? You know, you've gone to the other nostril, come back to this nostril. Very often you can do that. But there is no harm in stopping, because whenever we've had a patient with a complication who's referred to us and the surgeon comes and says, you know what, there was so much bleeding, I couldn't see where I was going. That's a standard thing that we get. So there is no harm in stopping. The patient may get upset with you that you were not able to complete the operation, but not as upset if you gave him a CSF leak or an orbital swelling. So don't hesitate to wait if something is not quite right.
So Wormold has also given different stages of bleeding, and maybe the people in the audience can look it up. It's quite well defined.
So in short, what I was trying to say also is that no pulling, tugging, be gentle with the tissues. As you can see the dissection here, the bone is being separated. And this dissection was done before the days of the microdebriders. Okay. So as you can see, you remove the bone and then you take a little through cut forceps. Don't pull. When you pull, you cause so much of a raw area that's what starts to ooze then. Okay. Now, this is one artery that can give you problems, can squirt and put a lot of blood in your field. That's the sphenopalatine foramen area. So when you go towards the posterior end of the middle turbinate, and sometimes you may want to resect that if you're going into surgery, into the lateral recess of the sphenoid or whatever it is, or even while dissecting polyps in that area, you may have bleeding. That's the area from where you can bleed. What is your preference, Kshitij?
The sphenopalatine, in my opinion, is one area where you can use the monopolar cautery quite freely and aggressively, as long as you're not near the orbit or into the inferior orbital fissure area. Usually you'll encounter that one of two places, the branches of it, that is not the main artery. One is while widening the maxilla posteriorly, and that's the lateral nasal wall branch, which you need to identify with a monopolar cautery. You can. If you have a bipolar, nothing like it. But if you have a monopolar, you can. And
But
the
use a
other-
regular monopolar or use it with a suction?
and insulated monopolar cautery is what I use, with or without a suction. If I have an assistant who can put a suction, that's great. The
Or
second-
do you have an insulated suction?
insulated suction monopolar, yes,
That would be-
that can be. The second area is when you're actually widening the sphenoid sinus inferiorly, and that's when you come across the septal branch that's going across to the septal branch of sphenopalatine going across. And again, there, because you've got bone below it, you can use a monopolar
So
cautery insulated.
This is what you were saying. This is
Yes.
the insulated suction.
Yes,
And normally, you know, in the nose, we like to use bipolar, but this is one area where you can use.
absolutely.
And if you are wanting to do surgery in that area and initially want to tackle it, you could also sort of define the artery and then you can put a clip on it or
Yes.
or a bipolar, as you can see in this. So this is not a scary artery. You can get control of it quite easily.
So just one comment
Now,
is that I would
You're talking about
nowadays,
this posterior septal artery you were talking about.
yes, I would refrain from bipolarizing or taking off the main trunk, because with the kind of surgeries now we do, I mean, you're then taking off a potential Hadad if ever required. So I would always go to the end of the artery that's bleeding and take that off and not go to the main trunk.
Actually, I prefer to use the bipolar. If it's medial, then maybe, and I always will tell my assistant then after I've used a unipolar to give a little wash, so that otherwise when you're trying to remove that, it's stuck and again some other areas.
You
start
pull at it
bleeding.
and it
Yes.
starts bleeding. So this is the other one that we were talking about, Gaurav. This is the posterior septal branch of the sphenopalatine. And I'll just halt it here. Any particular step that you advise when you want to widen the sphenoid in that area?
Yes, so one of the important things to do is if you want to widen the sphenoid, it's better to separate the mucosa from that bone. That is the basic sphenoid first. So one simple technique that I do is basically it's called soft dissection. I put a piece of merocell between the mucosa and the bone so that there is a very good clear separation. And then either you can use a punch or you can drill out that wall to bring it all the way down. So that will preserve that artery very nicely in that mucosal
Yeah,
flap.
so as you can see, the mucosa is being pushed
Yeah.
down.
Yeah.
But even if it bleeds, I think just the cautery, like you said. So here you're quite secured in using a monopolar cautery. Now the anterior and the posterior ethmoidal artery, usually the posterior ethmoidal artery doesn't give you much trouble. It's the anterior ethmoidal artery that has a problem, because at times it can be hanging down in the cavity. It may have a little cell above it, as you see over here, the AE, or you could have a little mesentery to it. And in trying to dissect in the skull base area, especially in cases where you've removed the bulla, you can damage it. So this is a microdebrider being used. The surgeon appears to be very, very conservative, but what he's not taken into consideration is that the artery doesn't have a bony covering on it. The surgeon being me. And there it goes. Okay, so if this happens, Renuka?
Yeah, so there are two scenarios in this. We are talking about intraoperative bleeding. One is that it bleeds into the nose, which is good news. And if it bleeds and stops bleeding, then you're worried that it has retracted into the orbit. So for the first scenario, if it is bleeding, you have to remember it's not the carotid. It's not going to exsanguinate the patient or his BP is going to drop. So there's no panic. So you can take your time. This time you need a assistant who's with you. And the assistant will do the suction. And you need to use a bipolar only for the anti-ethmoidal artery or the posterior ethmoidal artery, because otherwise you can start a CSF leak there, because the dura is very adherent to the cribriform plate at that point. So therefore, always a bipolar. and another surgeon to help you with it so that they can suck while you bipolar. And yes, as Dr. Samir said, either you need to irrigate with saline as your thing so that it doesn't cause a char to be removed along with the artery. So do you want me to talk about?
No, the orbit part will come to a
Okay,
little
yeah,
later.
right.
Any comments about the bipolar cautery?
So we can also use a coablator in the coagulation mode. That makes your life very easy because it's got a very nice angle. The problem sometimes what happens is if you've got a very low axilla, it might be a little difficult to reach that area with an angle bipolar, and sometimes they don't open very well, even the Wormald's forceps bipolar. So in those situations, just if you have a coablator handy in your OR, then it would make sense to
use the coablator in the
coagulation mode only.
Stop it, yeah. Yeah.
Actually come up with a slimmer wand, easy one, which is the one that we can use in the nose for the coablation. And in the scenarios that sir you showed in your case, so if you have a kind of a low hanging anti-ethmoidal
Then
and
it's
you know there
not
is
difficult, yeah.
and there is disease around that which you need to clear, I will go ahead and bipolarize that and then proceed with clearance of the disease.
But the bipolar that I used was an ordinary bipolar forceps, which is not always easy to use inside the nose. And therefore, this spot is shown in the picture.
Yeah. So and the
that's it.
trick that you only taught us that
Put your finger.
put a finger between the two so that it doesn't close completely, or use an infant feeding tube at the tip so that
It
doesn't.
remains
Yeah.
open. Monopolar cautery is to be avoided because you might start off a CSF leak. Now, if the artery starts bleeding and before you can do anything, it stops bleeding, should you be happy or should you be worried? Anaga?
Yeah. So on table, you're saying, sir, that the artery has stopped bleeding.
You know that you cut it and suddenly it stops bleeding.
Okay. So that is the most dangerous thing to happen. The likelihood of the fact that the artery has retracted into the orbit is it's very likely that is the scenario. And so you have to immediately check the orbit for any proptosis, palpate for any increase in the tension of the orbit. And if you observe that there is proptosis, there is developing chemosis, ecchymosis, and edema, you have to act immediately. Initially, the first thing that you would want to do is try to dissipate the pressure which would be exerted on the optic nerve. So you give a gentle massage to the orbit. Immediately also simultaneously tell someone to call your ophthalmology colleague. Look for the pupils, any change in the pupillary reaction. And while you're it's within in the operation theater, while you are seeing that there is developing proptosis, you have to immediately decompress the orbit. That is, you can do a medial orbital decompression as well as you can do an inferior decompression. If that is also not sufficient and you are observing that the orbital tension is increasing, then you may also want to do a lateral canthotomy. So that lateral canthotomy substantially decreases the orbital pressure by almost more than 30 millimeters of mercury. So that is something which all of us should need to know how that is done.
Anything? Would you agree with that? Kshitij, what do you want to add to that?
No,
Unless
sir,
you have different views.
I wouldn't agree with the canthotomy part if you're intraoperative.
No, let's talk about a situation. You're operating in the middle of the surgery. You saw the artery bleeding and then it stops. And then you go with all that. You try to palpate, etc., etc., etc. And if at that time you feel, do you have to do, when would you decide to do an orbital decompression? I think lateral canthotomy is a step we do when we want to save time in the ward in the post-operative period. A lateral canthotomy here would not be of much value if you've already decompressed the orbit and let the fat come out.
Yes, as I told you, if even after decompressing the medial and
you have, once you've
decompression,
decompressed the
still,
orbit and allowed the fat to prolapse, then the lateral canthotomy is not, because you've already given egress to the fat. The lateral canthotomy we feel is more likely to help if it's in the ward and post-operatively you discover
You want to
that.
buy time.
Yeah.
So one more thing, when I feel that it has retracted in the orbit, the first thing I would tell assistant to do is actually take the palm of his hand,
Give pressure.
and press on the eyeball, pushing it back so that it does not allow, so the clot will form around that area, but the eyeball will not come out.
So you prevent the
That is the
proptosis
thing.
manually.
Yes, manually.
And then
Then
some
by
point
that
of
time,
time, the
yeah.
artery has to stop bleeding.
And so by the time you do the decompression, orbital decompression, there is someone with active pressure on the eyeball, preventing it from coming out. And then once you've done an orbital decompression, you've created another expansile wall other than the globe, and then it should stop.
See, the whole point here is the artery is so small that normally it shouldn't cause you concern. But the reason why it keeps on bleeding, it doesn't stop, is because it's got a bony canal around it at points. So it's attached to the bony canal, so artery cannot retract and close. So even your pressure doesn't seem to stop the bleeding. That's why you need to cauterize it. However, if it's retracted into the orbit, now there is no bony canal. So with a little bit of pressure, it's going to stop bleeding. As Dr. Bradu said, you would want to keep pressure on to see that you don't allow the clot to push the eyeball out. The clot will dissipate within the fat. The question is now at this point, there is a little proptosis, there is tension, but the bleeding has stopped. Do you want to do a decompression, or would you say only if the pupil is showing any problems would you do a decompression? Otherwise, wait and watch.
So you can also start the patient on mannitol, given your situation. And if even with that, if you're developing an RAPD or a sluggish pupillary reaction, then you should go ahead and do it.
So if the pupil keeps on reacting good, and you're talking about an ipsilateral response, not a contralateral response. Ipsilaterally, if the pupil keeps on reacting briskly, then you could perhaps not do a decompression, but keep on following that.
Yeah.
And if you have the slightest suspicion that the response is becoming sluggish, you would decompress. But one very important point that Anaga made, call your ophthalmology colleague and document that the ophthalmologist has been called in and seen, medical legal aspects.
So can I add just one point?
Sure,
There was
please
this
go
really
ahead.
nice paper that I read about the American Association of Ophthalmologists. They had a separate session only on RAPD itself.
Mhm.
And one of the topics in the video that they showed was, an ENT surgeon causing an anterior point bleed. And the standard guideline that they mention is that every 3 minutes, apparently, we have to write what the pupillary response is, because you don't want to have a medical legal issue.
To show that you're actually been
documenting
documenting.
it. So we're supposed to do it every 3 minutes and write it on the.
So the afferent pupillary reflex, you got to document it. Okay. Now, decrease the blood collection in the orbit by compression, as she said, massage, as Dr. Anaga said, to dissipate the clot into smaller bits. And you can give IV mannitol or IV steroids to decrease the pressure. Everything that we've done. The canthotomy is usually done, and cantholysis, not sufficient to do a canthotomy, but also to cut the, so you cut the lateral canthus in a lateral direction and then vertically cut the lateral canthus, so it opens up the preseptal space. The septum is nothing but the fascia around where the attachment of the 4 recti muscles, there is almost a ring of fascia that separates the anterior from the posterior compartment. So when you, and the 2 ligaments are actually condensation of this fascia. So when you cut the lateral canthal ligament, you're opening up that space and the orbital fat can come forward. The only thing is, if you're going to do a decompression, as she said, don't do it on the equator of the globe, because that's where the medial rectus muscle is and you might damage the muscle. So you do it either above or below the equator of the eyeball, so that you leave a strip of periosteum protecting the medial rectus muscle. And after you do the decompression, what you have to do is actually press on the eyeball, press actively, so that the blood clot and the fat prolapses out. So see, one cut has been made below the equator, one cut above the equator, and you can see the fat prolapsing out now. If these knives are too big to use inside, you can use, now the pressure is being given, so you can see how the fat is prolapsing out. So that is important, and that periosteum over the medial rectus is sort of protecting the medial rectus muscle. So to avoid injury to the anterior ethmoidal artery, studying the CT scan before to see whether it's hanging or it's in the skull base area is important. Now we come to the big daddy of it all. Usually not expected to happen in routine sinus surgery unless you're going for surgery within the sphenoid sinus or beyond the sphenoid sinus. And Gaurav, let's have something from you on this.
I just wanted to make a point regarding the lateral canthal tendon, because it's very simple to demonstrate that. So once you've just done the cantholysis, then just retract the lower lid down and then you can see the tendon. So it's easier to see,
Identify it
demonstrate
and cut
then
it.
do.
Yeah. But you have to go right up to the bone,
Yes.
to cut it. Now, if you by any chance or somebody does encounter a carotid bleed, what can you do besides praying?
So, okay, so like you mentioned, just one point I want to add in your preoperative thing is, one is the septum going on it and whether the bone is dehiscent or not. Other than that, the intercarotid distance also makes a lot of difference. Where you open your sphenoid sinus decides that. Now, suppose you've had a bleed, and the first thing that you need to do is actually pack with whatever is available, whether it is gauze or Merocell or Surgicel or whatever. We have to pack because we need to reduce the amount of blood loss that's happening. And we should not ask our anesthetist to actually drop the blood pressure in this situation, because there's going to be cerebral hypoperfusion that can happen. Once we've done that, if we have limited options after that. So the problem is not the bleeding once it comes into control. The problem is going to be the pseudoaneurysm that's going to form after. So very rarely you might be able to use a bipolar or something like that to stop the bleed. But all the references which have which we have read have shown that the chance of post-operative bleed later in the ward is very high, because it is only scar tissue at the end of it, and it is very easy for it to rupture. The second best option that you have is you take a piece of muscle, either sternomastoid or the thigh muscle, and then you can actually plug with that. But even that has a pseudoaneurysm rate of about 60%. The other problem with the muscle is you have to hold it in for about 10 minutes because the myosin has to get released, and that is what is going to cause contraction. And the chances of immediate blowout is very high. So you have to keep the patient in the OR for about 45 minutes, even after the bleeding has stopped, so that if there's a blowout, you need to go back in and set that right. The only option which is actually proven to prevent a pseudoaneurysm formation is actually occlusion. But you cannot do that if the patient has failed the balloon occlusion test, in which case you'll have to do a flow diverter, which is an open surgery, a very big surgery, very complicated procedure. And the chances of success are also very low in the long run. And it's very expensive, not to mention. So these are the options which we usually have.
Renuka, anything to add?
Yeah, one thing is, if you're going to operate around the carotid, ideally you should do a balloon occlusion test pre-operatively to demonstrate or to document what is the circle of Willis and what is the contralateral supply like.
So in the event.
Yes, in the event of that. Second thing is you have to have an interventional radiology unit on standby. So anytime when we are going to operate around the carotid, we let them know beforehand, and we let them know when we are actually dealing with that we, they need to
So
be
they
on
are
standby.
ready.
They are ready. And the third thing is, what happens is when the carotid starts bleeding, there's a instinctive thing to pull instruments out of the nostril. If you do that, then the blood will just pour out and you'll not be able to see anything. So the first thing you do is, when you have a suction there, you keep the suction there and drain the blood, and you get an assistant. So this is again a four-handed technique. A lone surgeon can't do it. So the assistant will have to bring in a wide bore suction and put it there so that it drains the blood. Now, we used to talk about that Swiss roll technique of putting pack, but we find that it can be very cumbersome getting that pack in quickly. So what we do is, we have these laddus made on the trolley. It's betadine applied to the roller gauze, and you take off the excess betadine, and then you roll it into a ball and keep. So with them various sizes. So it's very easy to pick up one with the Blakesley and stick it there, so that it takes a matter of 2-3 seconds to get it there. And because it has a sticky betadine thing, and plus it's the right size, you can get immediate stoppage of the bleeding without having to worry about putting a pack. And then someone holds it there while you harvest muscle, etc. And of course, like he said, you'll have to go in later on to coil that carotid.
Okay.
One thing which Dr. Renuka just mentioned, that do not remove your suction when there is bleeding. instinctively people have the tendency to remove the scope. So that scope needs to be parked in there. So that, otherwise if the scope comes out, it will be very difficult
To
for
get
you
it
to
back in
get
again.
in.
Yeah. So I think we've got the thing more or less packed, resuscitate, hemodynamic control, arrange for blood, and get the neuroradiologist or the neurosurgeon to come in. How to avoid, I think we will not go into that here at the moment. One simple thing when you're doing for sinus surgery, avoid avulsing at intrasphenoid septa, which might be going to the vital structures. Orbital complications, I think we already talked about the bleeding inside. Let's talk about orbital fat prolapse when you're, say, operating for polyps or for sinusitis. Samir? When is it likely to happen? What do you do if it happens?
So it can happen right in the beginning of the procedure when you're doing an uncinectomy. So you need to study your scan and anticipate that if the uncinate is very close to the lamina over there. And if you get a small little prolapse, there is no point in trying to remove that fat and trying to proceed. So take a cotton pledget, the patties, and try to just push it out of the way and proceed with your surgery and complete the whole process. But it's very important that even if you've had a very, very tiny prolapse, inform the patient that this has happened and not to blow the nose later on, so that you would not want the patient to come and tell you the next day, oh, doc, see, I've got a little ecchymosis or a black eye. You'd rather tell the patient in advance that please don't do this. This has happened, but it's already been taken care of.
Yeah, Kshitij.
When you have an orbital fat prolapse, first thing is keep your suction away. It's a tendency sometimes to look and suck, and the suction is going to pull out more fat. So keep the suction away. I would also at that point keep the debrider away for a few minutes till I've bypassed that area. And once I'm beyond that fat area, I can use the debrider freely again. If it's a very small globule and if it's a chunk in the way, you could bipolarize it within the nose, but don't enter the orbit to bipolarize it.
So whatever is prolapsing out, you would bipolar.
That could be bipolarized to shrink it.
Anything to add to that?
We should also not ask the patient to do a sinus rinse in the immediate post-operative period for about a week's time, because that fluid under pressure can
Get
actually
into
enter
the
the
orbit.
orbit and problems.
Okay, so
So can I add one
yes,
thing?
please.
Yeah. So as to prevent entry into the orbit and injury to the orbital periosteum, I think you have to review your scans very well to see if the uncinate is very laterally rotated or a patient has a hypoplastic maxillary sinus. In those cases, avoid using a sickle to do the uncinectomy. I think a backbiting forceps or a small ostomus forceps will be the ideal thing to do an uncinectomy. So this will protect the.
I think if you identify the uncinate margin, put a little ball probe to get a space, and then use the reverse cutting forceps, then the chances of entering the orbit become almost nil. If you take a sickle knife and take an incision, you could land up doing that. So I think most of us are now using that technique to, yeah. Renuka, please go ahead.
Also, I would use something that I call targeted suctioning, which means that when you're going in and out with the suction, you kink the tube so that the suction is not working. Then you get it to the point where you actually want to suck, and then open the tube and suck so that you're not going across that fat while you're suctioning. The same thing that we would use if you're doing a CSF repair in that case, so that you are able to suck, but you don't accidentally suck on the fat or the repair.
So this sign, the Ballotment, Stankovic sign, is important because at times when you're dissecting, you may expose the orbital periosteum without realizing that you've done that. So asking the assistant when you're working in that area to keep on balloting from time to time becomes important. And if he does that and a tiny bit of fat comes, you know that you don't start widening that area at all. So what to do next, we talked about it. And as you rightly pointed out, ask the patient not to blow his nose because he might land up with an emphysema. Now, we go to a slightly more serious problem. Ocular muscles, the extraocular muscles getting damaged. So, Anaga, which muscle is most likely to get damaged and what would you do to make sure that that doesn't happen?
Yeah. So most likely to get damaged would be the medial rectus because it is closer to the area where you're operating, and it is more likely to be encountered farther posteriorly, that is in the posterior ethmoids, that it is closer to the orbital periosteum than anteriorly. So I think most of the time it is when you're doing a orbital decompression for a fractured orbital hematoma, or of where there is a fractured lamina praepatia, it is most likely to be entangled within the bony fragments. So that is where you have to be careful, especially when you're doing an orbital decompression, as sir rightly pointed out, that you have to take the incisions on the orbital periosteum inferiorly and superiorly, leaving a strip of the orbital periosteum in the midline so as to protect the medial rectus muscle. Also, sometimes if you're removing a tumor within the orbit, especially if you're doing some orbital clearance for mucormycosis or some tumor, you have to call your ophthalmology colleague to hook the medial rectus, so it's easier to recognize intraoperatively within the field.
I think this is something which is vitally important. If you are going to open the orbit, you ask them to take a stitch. They take a blunt needle and they take a stitch around it. So you can tug on it and you can identify it as you go along. And over a period of time, I think we've learned to do it ourselves. We don't require the ophthalmologist. They have that little forceps with that angle. You can just go and grasp it and take a round body needle, take a stitch, and you can do that. If you do have a transection, then I think you have a problem. But sometimes you may have some injury to it. You don't have to worry about it. Leave it in place, and I think it will work out just fine.
So there are these corridors now that you can operate on in the orbit above and below the medial rectus.
Yes.
So therefore, you need to be careful. Of course, it's there's also still a controversy as to whether you can use a debrider in the orbit or not. So I am very much against putting a debrider in the orbit, though I've seen surgeries being done like that. But those kind of advanced surgeries, the medial rectus is at very, very high risk.
So if you have some damage, you may have a transient palsy, but if you've transected it or very badly damaged it, then the ophthalmologist will have to come and do surgery to collect the strabismus. This is a very interesting case presented with an orbital abscess. So my lecturer phoned up and said, I'll have to do it at night. Did the case. Next day he said medial rectus. I said, have you damaged it? He says, I am 100% sure I have not damaged it. So we were wondering what had happened. So we found that medial rectus was not working. What actually he had done was made the mistake of taking the incision at the equator. See that, Anaga? He's taken the incision at the equator to drain the abscess. So the whole medial rectus with the fat got prolapsed into the orbit. Now, can you very clearly see how the medial rectus is
Bowing.
Like this? So we waited for a week thinking that it might correct itself because you know that the medial rectus is intact. Then my ophthalmologist said, sorry, if you leave it like this, it will fibrose in this position. This guy will never get his. So I had to go in, and then tagging the medial rectus, I went deeper to it and we debrided all the inflamed fat, pushed the medial rectus back and put a proline mesh over there, kept it pressed in, and the child recovered completely. The medial rectus came back completely, but we had to actively push it back. So even though it was not transected or damaged, it gave a problem. So that was the problem. When you make your incision, don't make it on the equator, make it above or below so that you don't directly damage it. Right. Now, Kitish, optic nerve injury. When is it likely to occur? And how do you make sure that it does not occur?
Preoperatively read your CT scan well. If you have a large Onodi cell, or if you have a Delanose type 3 or type 4, that's where when the optic is projecting a lot into the sphenoid or the posterior ethmoid, the chances of damaging it are much higher. Also see carefully whether the bone over the optic is intact or dehiscent, and whether there's a septa, as you mentioned, the intrasphenoidal septa connecting to the optic nerve. It would depend a lot on the pathology that you're tackling. Sometimes it's scary to see an AFRS where the entire sphenoid is destroyed. But it's one of the better pathologies to handle because once you clear the disease, you're far off from the nerve. Whereas if you're dealing with a tumor like an angiofibroma, and if it's gone through superior orbital fissure sphenoid, you've got to be careful. If you're expecting that there could be any chance of even a slight damage to the optic, at that point, you'd always keep the eye of the patient open. And the first sensitive thing is to start seeing the pupillary reaction. The minute you have a dilatation of the pupil or early dilatation, that would be an indicator that there's some kind of a stress on the optic nerve, either a stretch or some kind of a pressure.
So one of the areas where your chances of damaging the optic nerve unknowingly, like you may not even realize that you've damaged it very high, is at the sphenoethmoid junction. That is when you're crossing from the posteroethmoid to the sphenoid. At that segment, we have the canalicular segment of the optic nerve. Now we know that the optic nerve is actually a continuation of the brain. So if you actually fracture the bone laterally in the wall of the sphenoid, you might actually shear the pile vessels which are actually accompanying.
So vascular injury. That's right.
So
Okay.
there is no space for the blood to accumulate because it's a bony canal, and that can cause indirect injury to the optic nerve. We may not even realize it until it's
And I think the supply is also segmental. So even if one segment gets affected, the nerve
the
is
rest of the, and the problem over there is you might not see anything on the fundus for the first week or so until the whole fundus actually gets devascularized.
So reading your CT scans carefully, not using instruments blindly in the sphenoid, never use a debrider inside the sphenoid sinus, especially blindly, the tip of the instrument. I think this is one simple principle of surgery. The tip of your instrument always has to be in view. I have had two cases. Once when the microdebriders had just come in, I got a call from somebody that I went into the maxillary sinus and I debrided, not realizing that I'd actually gone into the orbit. And the second is a well-known case where somebody thought he was in the frontal sinus when he was actually intracranial and debrided the frontal lobe. So unless you have the tip of the instrument under vision in any surgery, and especially if it's a cutting or a sharp instrument, I don't think you should venture. So in the sphenoid, going superolaterally out of the question. And as a matter of fact, using the debrider inside the sphenoid should also be looked at with great caution. I only had one case referred to me for optic nerve injury after a septoplasty. And it's a very funny thing. I'm just digressing a little bit here. I presented this case at one of the conferences, not mentioning where it had come from, which center it had come from, which state, which whatever. And after this, one man came up to me and said, "Sir, I'm very upset with you. You should not have shown that case. It is not fair." I said, "Why? What happened?" He says, "I did that case." I said, "I didn't mention your name. I didn't mention your institute. I didn't even mention which part of India it came from. But tell me how you managed it." So he said, "The spur at the back was so tough that even with my Lux forceps, I could not take it out. So I used a gouge and hammer right there. And it must have been a very small sphenoid sinus or whatever it is. And the crack, like you said, it must have interrupted the blood supply. And that's how the nerve got damaged." No. Because by the time the patient came to us from that place to us, it was already weeks gone. So there was no question.
If there is any injury that you're suspecting in interop, so a mega dose of 1 gram of methyl.
Steroids is the only thing. Steroids and just spray, that's all, because I don't think there is anything else that you can do.
And yeah, and definitely an MRI post thing as soon as possible, because you need to know how much of the injury is there. Sometimes you can have a transaction of the optic nerve, especially in post-traumatic, not iatrogenic,
Just
post-traumatic.
Yeah, but just one word of caution here. When you're working in the orbit and if you get a dilated pupil, look for contralateral also. Because if you have interrupted the fibers of the third nerve, you could still get a dilated pupil without any damage to the optic nerve. So if you shine the light on that dilated pupil and the opposite pupil contracts, then you know it's not an optic nerve injury, but a third nerve injury. Okay. Similarly, if you were to shine the light on the healthy side, you will not get a pupillary reflex here. While if it's an optic nerve injury, you will get a pupillary reflex if you shine it on the contralateral side. So this has happened with people that the third nerve fibers were interrupted, leading to panic, but it was not an optic nerve injury. You were saying something, Renuka?
I was just wanting to recount one case
Hmm.
where we were operating on an osteoma near the orbital apex, and we had an oculoplastic surgeon with us, and the pupil dilated. So the moment that happened, I said, pack up, you're not going to do anything further. But she said, no, this can happen. And she said, wait. So we waited about 15 minutes, and the pupil came back to normal. And she said, no, this can happen. But that we were able to do because she was there, oculoplastic. On our own, we definitely not have gone ahead. So there is this sometimes temporary dilatation, which will save you a lot of panic if you have an oculoplastic surgeon along with you.
Yeah, but
when you're
otherwise
doing
just do this, no? See whether you're getting a contralateral reflex or not.
Yes,
Yeah.
absolutely.
It's because of the compression on the ciliary ganglion, which creates a parasympathetic response, basically. So sometimes if we wait, then it might improve.
No, I have had this happen to me in the initial days when we were trying to do this surgery under local anesthesia. And when I injected xylocaine and I got a dilated pupil, yeah. So the one thing that I would like to say here, as far as possible, always try to identify the ostium of the sphenoid and enter the sphenoid through the ostium. The old teaching, identify the choana, go 1 centimeter above, 1 centimeter lateral and poke. Just forget about it. You sometimes might have such a small sphenoid sinus. I want to tell you one case. I had a CSF rhinorrhea from the right nostril coming from the left middle fossa. The sphenoid sinus on the left was so small, the right sphenoid had actually gone across and over, and it was leaking into and leaking out from the right. I've got the CT scan of this patient. So sometimes the sphenoid might be very, very small. So always identify the ostium and widen it. And if you're finding it difficult, for example, in the revision, and it's a small sinus, open the healthy sinus and then come along the floor through the intersphenoidal septum into this sinus so that you don't accidentally cause any problems. Okay. If you open a cell, just want to ask them, how do you know whether you're in the sphenoid or you're in an onodi? Anaga?
Yeah. So if you're in a sphenoid, basically it's like a pot. You won't be able to see the floor of that sinus. Okay. Even if it's a large onodi, you will be able to see the floor of that sinus. So that is one distinguishing, like the sphenoid will have a very low, it will be like a pot and you won't be able to see the floor. So that is more of a distinguishing. And of course, it'll be, if you are seeing two sinuses, the medial one and the inferior one would be the sphenoid.
Chitesh, you wanted to add something?
A very easy way to also see is the roof of the maxilla. When you have the roof of the maxilla, what we call a maxillary ridge, that's a surgical landmark created. Anything that's above it is the ethmoids. Anything that's below it is the sphenoid. And if you really still have a doubt, it is worthwhile resecting the superior turbinate. And as you just mentioned, go to the normal ostium of the sphenoid, identify that in the sphenoid recess. So then there'd be really no doubt because you can check both ways.
Yeah, but as she said, when you look at an onodi cell, it will be like a cone. It's broader towards you, but as it goes away from you, it becomes narrower. It's like an inverted cone. While in the sphenoid, you would have a narrower opening and then a bigger cavity, and especially going down towards the floor. If you still have a doubt, you can go medial to the middle turbinate and follow the nasal septum, and you know whether it's a sphenoid or not. But as you see in this picture over there, the sphenoid is going to be somewhere here. This is the onodi because it's an opening and then it's going away, and you can see the optic nerve running through that. This we talked about. CSF leak. Has any of you, in doing routine surgery for polyps or for sinusitis, had a CSF leak? Those of you, please raise your hands. These two have it.
For polyposis, no, sir. But for other surgeries, yes, sir.
Such as?
So tumor through the going through the cribriform plate, a JNA going from the lateral recess out, and
I think that's
Yeah,
about
I
it.
think in our initial days, working towards the roof, at least I have had it. And what happens is the commonest site, one is near the cribriform plate when you're working towards the frontal sinus and not realizing. The second area is here. When from the posterior ethmoids, you're going into the sphenoids because you're going in a posterior-superior direction. But when you go to the sphenoid, you have to go down a little bit. So these are two common areas. And this is what happens. Suddenly, you're operating and a stream of clear fluid seems to come in that field. This is what it may look like. It's called a washout sign. Suddenly, the blood in that area is starting to get washed out. So at this time, don't be an ostrich. Don't pretend that you haven't seen it, that it hasn't occurred, and God, it will go away. Samir, if this happens when you're operating, what would you do?
So you need to fix that leak and not hope that it will settle down on its own. And now with the experience of having treated CSF rhinorrhea, so many cases, so we know what we need to do for that. So most of the time, what I would do is take a little fascia and fat from the thigh, fascia lata, although I have also used temporalis fascia and it works very well. And try and plug that leak. And after that, if you have tissue glue available, you can use that as well. But we've done enough cases even without any glue, and you're able to sort it out with that.
As a matter of fact, whether you use fascia, fat, nasal mucosa, septal mucosa, turbinate, anything that you use, because it's a traumatic leak, and if you cover it and stop the flow, it's likely to heal. But you have to seal it. You could also finish the surgery. You don't have to abandon the surgery at that point of time. Finish it and then prepare the area nicely and put some kind of a graft, but put it because that's the best chance. And I would tell the patient that this has happened. I need to leave the pack in for a little longer. And I think I would not sweep it under the carpet or hide it from the patient.
So also the Merocell pack, I would actually put a lot of gel foam and then between, so that pack of mine is going to be more along the floor of the nose and not trying to push it out, because the problem would happen when you remove the pack, all whatever you put in to seal may come out. And regarding packing the nose, so I remove my pack after 48 hours in case there is a CSF. We don't keep it for 3 or 5 days as we used to earlier.
I would keep it longer in a large spontaneous leak, but in a traumatic leak, you could remove it earlier. But I have a packing of gel foam and Surgicel both. And glue, if it's there, then I think your pack is more secure. If the pressure is not high, you don't have to go for lumbar puncture or lumbar drainage. Post-operative, would you give them antibiotics? I would, because the nasal cavity is open to the outside. We don't put a lumbar drain unless there is high pressure leak. Non-absorbable packing removed after 1 week. No, I think we would remove it on the 4th or the 5th day. Or if you have an absorbable packing, then that part, the gel foam, etc., you leave it inside. Don't try to suck it out. Let it come out by itself. To avoid CSF leak, what will you do? Gaurav, what certain rules that you would follow to avoid a CSF leak?
So the areas which are at risk, one of the things that you've mentioned is the attachment of the middle turbinate. Never, if at all you have a concha bullosa or you need to resect the lower end of the middle turbinate, stay as low as possible and do resect only whatever is required rather than going all the way up and
chopping it.
And second thing is never use a lux forceps or anything to fracture it, because when you do, then you're actually causing a defect there. Third point is area of importance is at the insertion of the anterethmoid artery, because that is the weakest area of the whole skull base. In fact, it's about 10 times weaker than the posterethmoidal skull base. So there is a very high chance that you might injure that area, especially if it's in a mesentery. And fourth point is at the area of the frontal recess. I've had a resident of ours who actually managed to create a posterior table CSF leak while doing a frontal sinusotomy. So if that happens, it makes it very difficult to repair as well. So we had to actually create a window in the, taking an eyebrow incision and then closing it from that portal. So be very careful in that area as well.
And when you're going into the sphenoid, remember that the sphenoid, you don't continue in the same
Same
angle.
plane. Go
You
down.
Go
Lower
down.
down.
Inframedial to the sphenoid.
Couple of points to add over here, and maybe that's how it happened, the posterior table. So when you're operating the frontal recess, the direction of the instrument is extremely crucial, and the size of the suction of the instrument too. We've had a case where a patient was referred by a senior surgeon the right direction, but the instrument is larger, the suction was larger in size, and the side of the suction had hit the entry of the anterior ethmoidal artery. So that could crack, and the direction is possibly what had happened, and maybe that's why you had a posterior table break happening there.
Samir, you want
have a
to?
good direction.
Same point that Kshitij made, that if you're using an upturned Blakeslee, make sure that it's not directed medially, so that you don't go and enter over there. Also, so a lot of people have this habit of using a curved probe to try and sound the frontal sinus. And sometimes if done blindly, you can actually walk into the
You can walk into the cranial cavity, or you can walk into the orbit. And if you are plucking out at things, no undue force. If you have loose mucosa and you try to pull it and you're getting resistant, just leave it. You shouldn't be plucking it with force.
So the frontal beak becomes a very good landmark. If you just follow that frontal beak, and if you find something, kind of dipping in, that would be the frontal recess and going towards the frontal side.
Yeah. In revision cases and problem cases, if you have image guided, nothing like it. But it's not something that you rely on solely. Your knowledge of anatomy is also important. So as you said, don't let the forces point upward. You can point it a little. These slides are from 1986, 87. We didn't have through cuts. We didn't have microdebriders, and we had only a 0 and 30 at that time. Post-operative complications, epistaxis. Madam, have you had patients who come on the 4th, 5th day with sudden bleeding coming in?
Yes, had that. One is when you use extensive monopolar and the char separates. Second, we've had when you do sometimes, turbinectomy in the posterior end of the inferior turbinate and cauterization of that. So those kind of things bleed. And we had one case of a DCR, which bled post-operatively because branch of the anti-ethmoidal artery gave way. So it didn't happen intraoperatively, but it happened post-operatively.
So I've had one patient, one only, where on the 4th day, the patient came with bleeding, and for a regular FES case, you wouldn't expect it to be that way. Packed the nose for 24 hours, remove the pack, and he just continued to bleed. And that is when he gave me the history that there was a bleeding disorder in the family.
Very
so
good.
I think it's
Very
very
good.
important that we do a PT
Take a history.
INR. in
No, and
most
ask
of
for
our
a
cases.
history as a routine. Do you take aspirin? Do you take blood thinners? Do you have any bleeding disorders? I think these should become routine questions. But I think in these cases, once you pack, you move the pack, it bleeds. Best is to take the patient on the table under anesthesia, do a scopy, and see where he's bleeding from and stop the bleeding.
So
Yeah.
one point I just want to add is if you're doing an endoscopic sphenopalatine or an IMAX ligation using clips, then the chance of the clip slipping is very, very high. So you have to clip it in at least 3 different places to have, a backup for your backup as well.
And tell the patients not to do that. Okay, these are the various. I think if it bleeds more than once, I would take the patient and see if I can cauterize. Sinusitis, they say more sinusitis in the frontal sinus is created by the surgeon than by the disease. And I think for that, gentle dissection and no stripping. But otherwise, avoiding mucosal trauma would be the thing. I think synechia. Are they troublesome? How do you prevent synechia? Anybody would like to take that question? Anaga?
Yes, this is the most bothersome complication. Sometimes you have done the surgery well, and your whole result will get disrupted with these synechia. So as is seen in this picture, you can have synecdoche between the nasal septum and the inferior turbinate. That happens when there is a little bit of deviation. At that point of time, you may not feel that a septoplasty is necessary. But many a times a septoplasty does help, because then it will improve your access to the sinuses, as well as will help irrigation and prevention of these synecdoche. The second site where there will be a development of synecdoche is when the middle turbinate sticks to the lateral wall of the nose. That is the worst kind of scenario that you could have. So this can be prevented by preventing damage or mucosal damage on the arch of the middle turbinate, so that there is no, the middle turbinate does not stick to the lateral nasal wall. This can also be prevented by using an axillary flap technique. The second thing is that you have to lateralize or sort of stabilize the middle turbinate post-operatively, which I always do, is to take a stitch. If you have done a bilateral dissection, you take the middle turbinate stitch from one side through the other middle turbinate, from this middle turbinate to the other middle turbinate, and stitch the middle turbinate.
So do you also bulgarize? Do you create a raw area or no?
I just take a stitch.
Okay.
And
so if you bulgarize, this is what you will get, a small 1 point addition. So the argument which was held against bulgarization, you're blocking the channel to the olfactory area, doesn't hold true. Because if you have a single point like this, then you still have the channel open. I do this quite regularly, and I don't think I have had patients coming with anosmia afterwards. So even if I take a stitch, I just do a little tiny scratch, and this is the kind of addition that you get to prevent this from occurring.
So another thing that I do is I keep a middle meatal spacer, like an absorbable foam, which can be kept within the sinus cavity, and a little bit of it protrudes out through the arch, so that the arch of the middle turbinate doesn't get stuck to the lateral nasal wall.
So last complication we're talking about, not related to your surgery, but if you're not careful with your instruments coming in and out, corneal aberration. Now we always like to keep the eyes exposed to the surgeon to see ballotment, etc. But then it's a good idea to sort of keep a tape half closed or put ointment and keep the eyelids closed. I think we will stop here because this is, I think, the last one. Epiphora, don't widen anteriorly, especially if you come to hard bone. And this would occur only if you're really, really strongly breaking the bone. Otherwise, so the moment you feel the hard bone, stop. But if you've done a proper uncinectomy, you don't really need to widen the ostium anteriorly anymore. Yes, Renuka, you wanted to say something.
Yeah, this is my favorite hobby also, I must say. Basically, everyone is doing extended modified Denkers for various tumors. Now, it makes very much sense. Literature mentions this primarily for inverted papilloma, and it makes a lot of sense there. But when you do it for an angiofibroma, the tumor does not attach to the anterior skeleton of the face ever. It never involves the lacrimal system. And therefore, I don't like doing modified endoscopic Denkers and cutting the nasolacrimal duct, because you have a lot of raw area. Then though you have made a sharp cut, later on with fibrosis, this can happen. So I prefer to leave the pyriform aperture and the lacrimal system intact and do what I call a 4-port technique. So that is one place where I don't, I'm very worried about the nasolacrimal system in a young boy. And also there is flattening of the face after 3-4 years.
So I want to close now because I've been told 3 o'clock we have to stop. This is a slide which was prepared for me by Hetal, who's now the professor, head of department of ENT at KEM. So side tips for the endoscopist: know the anatomy, anatomical variations, study the pathophysiology of what's happening, practice with cadaver dissection, observe, assist in endoscopy before you start doing it, and begin with diagnostic endoscopy, then move to simpler cases, study the CT scan well, minor surgical procedures, then only go to the complicated. Start with virgin cases rather than revision cases. So before you enter somebody's nose and start causing damage, cadaver dissection, attending workshops. And I would like to add one more slide here, which I'll try and get. That's me with Dr. Ingle, who was my boss. And behind him is Dr. KL Shah, who was his teacher. And now we could have me watching somebody like Kshitij or Gaurav operating. it's never too late to learn. And we have the possibility of doing cadaver dissections. So don't complain that, oh, it's not easily available. There are ways and means to do it. Make friends with the anatomy department in your area. That's how we learned. And I would very strongly recommend that before you start doing it on somebody's nose, get yourself to a certain level of expertise by attending workshops and doing cadaver dissections. Dr. Bradu conducts a fantastic cadaver dissection workshop with hands-on dissections. I'm sure you can join that and train yourself. So first of all, thank you to all the panelists for their wonderful input, for the wonderful audience. I didn't realize slowly so many people had come in. That's good to know. And once again, thank you, Alchem, for helping us always with academic activities. Thank you very much.
Thank you, sir, and amazing panel discussion, sir. Thank you so much, and so much to learn, and amazing slides for each of the complications. Truly benefit from your experience every time, sir. And with this, we will now, I'd like to thank all the panelists, Dr. Kshitij, Dr. Gaurav, Dr. Sameer, Dr. Anagha, for taking time out to be here for this panel discussion. I would invite you to stay till the end of the session and the live surgery session if possible. And once again, because when we'll be now breaking late in the evening, I'd like to thank Alchem and Mr. Mehta, Mr. Shashi, Mr. Vivek. Thank you so much for organizing this at such a short notice in such a wonderful way. Thank you so much.
They have one Q&A.
Oh,
And then after Q&A, you will have
Q&A कितने समय के लिए? Okay, I think we'll get started at least. Pack it again.
थोड़ा ऊपर नहीं है बॉस, नीचे
थोड़ा नीचे, थोड़ा नीचे,
टेबल लिटिल डाउन,
थोड़ा नीचे.
Light source for the brightness.
Light
बस
source.
बस
Enough.
रिकॉर्डिंग ऑन कर दो.
नहीं आप नहीं. और चार दो. Boss, I will be very, very calm. I will not talk because I don't want anybody to feel that I shout.
Just one more thing, sir. If you could wait for a few minutes, sir. They would like to present the mementos just now.
सर्जरी के बीच में ये ट्रिप्स है. ये क्या है? ये you can be ready with the other. सलाइन फोड़ो. ये सब सलाइन.
I'm live.
Dr. Janki Ram, we are able to hear you in the OT. Give us a few minutes so that we can finish with the panel discussion formalities, and we'll be with you in another 5 minutes.
Okay.
Can I talk?
Yes, you can talk.
Am I audible?
Yes, you are.
Yes, Janki, Dr. Janki Ram, we can hear you. Can you give us just 5 minutes before we start?
Madam, please, madam. Please.
Okay, thank you.
Camera band.
May I request the Alchem team to please come and present the mementos to the panelists. May I request Sir Dr. Kirtane to please accept this token on behalf of Alchem. Dr. Anagha Joshi. Dr. Sameer Bhargav. Dr. Gaurav Medicari. Dr. Kshitij Shah.
And I think put a big round of applause, because I know what it's taken in the last few days. Dr. Renuka Bradu, you've got a feast in front of you coming on today and tomorrow. Ma'am.
Hello, Dr. Jankiram. Can you hear me? Dr. Jankiram, can you hear me?
Good afternoon, madam. Can you hear me, madam?
Yes. So we are all eagerly waiting for you to start. And I'm going to ask Dr. Anaga Joshi to join me. So both of us together will be conducting the panel. I mean, or moderating the surgical session. And look forward to an absolute feast from you. As you had mentioned to me, you have 3 cases. The first one is an angiofibroma. The second is extensive nasal polyposis. And the third is the CSF leak repair. So over to you.
So first of all, I thank Professor Renuka Bradu, madam, for giving me this opportunity. And I'm a little nervous to do a JNA in front of madam, because I know that madam is the person who actually led the whole country to do this tumor. So first of all, a big thanks to you. I can't call you father, so you're mother of JNA in India. Thank you, madam. And I really love your classification also. I have learned a lot from you. As a junior, I worked with Professor Kirtane sir. I don't know if he's there, but I saw his panel, which was extraordinary, excellent. And thank you, Professor Kirtane sir, for imparting your knowledge so that we could learn. The third person I want to thank is Professor Sethi sir, and my teacher, and who actually imparted the knowledge which I have right now. So without much ado, we will go on to the case. We have 3 cases lined up, and the first case is angiofibroma. As we all know, for the sake of, I also thank Alchem for this wonderful opportunity, and Dinesh, who is a professional now in transmission. Thank you. So about the case, we all know that now we never call it as a JNAF. It's actually a JA, juvenile angiofibroma, because you see the recent papers, it's all about not the nasopharynx alone, but can occur without involvement of the nasopharynx. Well, this tumor is a tumor of a young adolescent male presenting with nasal obstruction. This patient is a 15-year-old male presenting with nasal obstruction for the past few years, and also epistaxis. So a classical diagnosis of JNA will be made if the patient like this comes to you. I've not seen a single female developing a angiofibroma. I don't have much experience on that. Now, let us go on to the CT and MRI. So what do we order for a case of angiofibroma? What do we order? We never take a biopsy. This is a very important thing which I want to tell the juniors. Never take a biopsy, because the patient can bleed to death. So then how do we diagnose it? So the best method of diagnosis is a CECT, contrast enhanced computerized tomography. So I always believe that I think that if you are given a choice of various investigations, and if there is a constraint with respect to money or whatever, just take a single investigation. Always, I ask this to my residents as well. So single investigation of choice means I would go for a CECT. But if you're given a choice, well, then I have a battery of investigations, then I would go in for a CECT, an MR, DSA, and so many other things. So what information do you get in a CECT? Why is CECT more important than an MR? This is what we're going to discuss now. So please come, I'll show you the CECT in this case. You will have to take the camera in your hand and come. You can, because it will be a side focusing. Give me a. Okay. No, but she's holding it. Okay. Okay, so let us see what the CECT has got to say. This is a sort of a big JNA. So I always say there's nothing like a small, there was one talk by Professor Karao, a small, big, and the ugly JNAs. And we always conclude by saying there's nothing which is small in JNA. Every JNA has to be treated with due respect, because small JNAs can actually cause googlies. And I'm sure Madam will agree with me on this point. So let us go on to the scans. This is the gantry view. And you can see here that this is the nasal cavity. And this scan was done, I think, 6 months back. The patient is a camp patient. I'm doing it in Hyderabad, which is a new center for me. And I have now migrated to Hyderabad. So I didn't repeat the scan because the patient is not affordable. But now it's different. The whole scenario for this patient is different. I'm going to show you that. Okay, well, this is the frontal sinus. You don't see tumor here. So what do you look for when you see a JNA? The first thing you have to look for is whether the JNA is occupying the vestibule or coming out of the vestibule. That actually gives a lot of problems because if you have some space between the anterior nares and the JNA, then you can do something different. But if you're having a JNA protruding out of the nostril, then it's going to be a challenge. And this case right now, you can see that the JNA is going to protrude out of the nostril on the right side. Well, seeing this, you can see that there's haziness in the frontal sinus. This is where MRI comes into place. But in a CECT, of course, we can make it out. You can see here that this is actually fluid and it is not tumor. Usually, I've seen very rarely. In fact, I've never seen a JNA involving the frontal sinus till date. So, of course, the frontal recess, yes, but not the frontal sinus as such. It's never gone inside the frontal sinus. So here you can see that there is, again, a soft tissue mass. But if you look at it very carefully, there are areas of hyperintensity. You can see here that's hyperintense with hyperintensity. So this is something like, fluid inside area which is enhancing. So this, first of all, arises a suspicion of what is it? Is it a JNA? Can JNA present with so much of, loculated fluid masses? So if you look at it, this is the ethmoids, this is the maxilla, and then here you can't differentiate actually from the fluid and the tumor. Of course, if it enhances nicely on contrast, yes, but that is where the MRI comes into play. Here, if you look at it, there is a lot of lobulated areas of hemorrhage or fluid, whatever filled, and you can see that this is completely occupying the whole of the nasal cavity. I presume the septum is pushed towards the opposite side. It doesn't look as if it's still gone to the other side. The septum pushed towards the opposite side, which is causing retained secretions, causing ethmoid problem here. But if you look at it carefully here, there is an erosion of the skull base. You can see that's the erosion of the skull base. The bone is not there, but let us understand that this tumor is purely extradural. I mean, not in all cases, but mostly 99% or maybe 98%, it's extradural intracranial. This is intracranial extradural. So you can see that this is, but if you look at it carefully, you see this is more of, loculated, containing fluid rather than enhancing mass, which is actually very, not very common. Of course, you've seen it, but not very common of a JNA. And you can see here, that's the maxilla, the posterior wall. And here you can see the widening of the sphenopark. This is the inferior orbital fissure. You can see the inferior orbital fissure. So I love the classification of Dr. Bradu, where she says it just touches the inferior orbital fissure or it widens and it goes inside. So I love that. Actually, that is a really, a person having that amount of experience can only talk about such statements, which I really appreciate. And you can see that this is the widening of the sphenopalatine foramen. It goes into the pterygopalatine and the infratemporal fossa here. Of course, you can see that the sphenoid is completely widened. So can I make a diagnosis of JNA, or what is the DD seeing this? I would say maybe there are a few DDs which I can think about if I see something like this. Of course, I don't think the contrast has also been given properly. But then seeing the scan, I would have a lot of DDs. Let us read the scan, then I will tell you. This is the infratemporal fossa, completely gone. And you can see here that this is actually the pterygoid wedge. And we made a sign called the Ramharan sign. And this is almost pathognomonic of JNA. I've never seen a Ramharan sign in any other tumor, at least in my practice so far. So this is maybe a Vidian schwannoma, something like that can produce this. But other than that, it's very rare to see Ramharan sign seen in other tumors. So this is nasopharynx never produces. So you can see the nasopharynx also filled by the tumor, but there is no clival erosion here. So let us go on with this background of CT. What is the differential diagnosis we will think about? The first, of course, since the Ramharan sign is positive, then I would think of a JNA. Apart from that, if I don't see this cut, then I would say it might be a schwannoma. So one could be, it could be a schwannoma. The second, it could be a pseudomonas meningioma. I have seen pseudomonas meningiomas present exactly like this. You can find tumors like, aneurysmal bone cysts, which can present like this. You have multiple loculated, areas of blood. So a number of DDs come into my mind, but then for this, you have to differentiate this from other diseases. So we'll have to go in for an MRI. So let's go in an MRI and see a post-contrast MRI. And basically, I agree that we should have DICOMs. But to me, I think I want a hard copy on this board. Always, always, always. Because whenever I operate, I keep seeing all the cuts. So it's just in my theater, it's just in front of my operating table. And my eyes, when I operate, I don't have navigations every time when I operate, but when I see all the cuts. I can't do that with a DICOM. I'll have to move that slice by slice. You can have 10 dimensions, but believe me, all the 10 dimensions are created only by your brain. Please understand that. So your brain can reconstruct. Your brain is the best to reconstruct more than any machine on Earth, on this planet, on this universe. This is very clear. Now, having said that, when you have that hard copy right on your friend, you can actually visualize it in all the dimensions. This is the beauty of our brain. So I always like to have a hard copy, though, okay, DICOM, nowadays, my residents use it a lot, but I generally don't use it a lot. So you can see here, this was a recent MRI, and you can see that the vestibule is already involved completely, markedly enhancing tumor. And you can see a lot of fluid void here. And you can see that is fluid, just fluid in the frontal sinus. The septum is pushed towards the opposite side. You can see the maxilla is not involved. This is fluid, and that's tumor, which is pushing the. And I also want to present, I think one of my projects I was telling that, you see, in a hypoplastic maxillary sinus, what happens is that there is indrawing of the maxillary sinus wall. So I see that in JNAs also, and also I've seen that in some of the tumors which push. Is there any study, I don't know, where there is lateralization of medial wall of the maxillary sinus? That I don't know, but there is definitely a study where they have shown anterior pushing of the. It is not diagnostic, you see. Hallman-Muller sign is any tumor in the infratemporal fossa is going to push it forward. So any tumor in the nasal cavity which expands can push the medial wall laterally. This is also one sign. I don't know whether it's been published. I'm not sure. So here we are. You can see that this is actually the tumor having fluid voids. It's really vascular. And you can see that's actually the level of the cribriform area. And you can see that this tumor is a huge tumor, and it's going inside the maxillary sinus. You can see that's the maxillary sinus going inside the maxillary sinus. And then what you have to see in a contrast CT scan, I always say this again and again, you have to see or locate where your IMAX is entering into the tumor. So this is where you can see beautifully the tumor. You can see the IMAX entering there. And when you trace it below, backwards, so actually you can trace it with the DICOM, but you can also trace it with your mind. That is actually the IMAX, and you can see that this is actually the, it comes like this and then comes like this and this way. So that's my mental, reformatting of this. So you can see that that's the IMAX. I can clip that there. And then you can see so much of fluid void. You can see so much of fluid void, everything fully vascular tumor here. And there are a lot of locules. You can see a lot of locules here filled with either, suppose it's going to be something serous fluid. I've seen locules having serous fluid and blood. So if you have serous fluid, then again, you have to rethink about the diagnosis of a JNA. I have to ask Professor Renuka, if Bradu Madam, if she has seen serous fluid, because serous fluid I've seen more in schwannomas or in bone cysts or some matters meningiomas.
Dr.
In JNA,
Jankiram,
yeah.
Dr. Jankiram, you're right. I've seen a fair number, it's not very common, but it's not very, very rare also. You see these fluid loculations especially in large angiofibromas, and it's always serous fluid. It's never, pus or mucus. It's always serous fluid. And my feeling is that when the tumor starts outrunning its supply, when the blood, the tumor,
there's a lot of necrosis.
Yeah. So then when it outruns its blood supply, that's when these serous fluid loculations come up.
Absolutely,
but you're right.
Fully agree.
You're right. It's serous.
So actually, when it it outwits its own blood supply, there are two things which can happen. One is necrotic degeneration. Second is fibrotic changes. So these two can happen, as Madam says very clearly. And here you can see that locules of maybe serous fluids, maybe blood, whatever. But more important, I want to locate the carotid artery. So this is the carotid artery. And this is going to be the cavernous sinus region. So that's going to be, see, cavernous shows an enhancement always. And you can see that is the cavernous which is not involved. So in my classification, if you have this involved, then it goes to stage 3. So till it gets involved, it's stage 2C. So you find that, you see, this is not involved. That means it's good. It's easy. It's not great. It's not very difficult. As long as the cavernous or the carotid is engulfed, it is not very difficult to operate on this. Even if it is involved, then we can, depends on which compartment of the cavernous sinus. But then here you can see that this is not involved clearly. So that is a good sign for us. So now, seeing this JNA, what are the difficulties which we are going to encounter? This is what we'll have to think about. And how much of blood loss do we expect in a non-embolized JNA? Number one, the difficulty, most important difficulty I might face is the anterior protrusion. It's come out of the nostril. I'm going to reduce it with a coblation or, go cross-coat and things like that. So that is one difficulty. Second is, as I told you, there's erosion of the skull base. So the dura will be exposed. Be very careful. Don't create a CSF leak there. So this is second. And third, you can see here, as it goes here towards the greater wing of sphenoid. This is the area where you will have a lot of venous bleed. You also have a little pterygoid fossa involvement. It's called the transpterygoid space. And of course, that is easy. But then here you might have a little pterygoid venous bleeding, which you have to think about, and you have to have Surgicel during that part of the surgery. Now, what are the steps which I'm going to follow in this case? So I have to form my steps before I start. I should have a mental idea of what I'm going to do. I try to reduce this with a coblation. Let me try to, shrink it. But if it doesn't shrink, I'm not bothered. So I might actually go for the opposite side. So I will go for an opposite side. I will try to do a small septectomy and then push the tumor towards the opposite side, do a modified endoscopic Denkers. Here is where, Madam and I have been actually a little different. Of course, every surgeon has his own beautiful thought process, and I appreciate Madam for that. The push-pull technique, definitely. But then, I follow the modified endoscopic Denkers technique, and then I will try to go and ligate this IMAX. And once I do that, I might either do a segmental dissection, or I might actually try to push that JNA backwards. And the most important point here is that let us understand that JNA tumors actually work by expansion. So they work by expansion, and then they find an orifice, they go inside and slightly widen that orifice and then go inside that area. So we are now trying to actually widen all those orifices so that we can actually, so the more important thing is to do the proper bone work. If you do a proper bone work, so what is the, if a postgraduate had asked, what is the most important step you will do to remove a JNA? My answer will be exposure. So if I have a good exposure, then I think JNA is not a big deal. So having said that, I think you'll have to get trained by experts like Madam and then start your JNA career. So you've got any comments to add, Madam?
Dr. Jankiram, Dr. Anaga here.
Yeah.
Can we get a view of the axial scans if you have?
Madam, actually what we did, they're all there in the ward.
Okay,
Get
no
the
issues.
axial. Yeah. Let me start and we will discuss that. If you don't mind.
Of course.
Yeah. If you don't mind, can I
Yes,
start?
yes, you
and
go ahead. Go
Yeah,
ahead,
yeah.
please.
It's okay. So here is the endoscopic view. You can see that this is the, can you see the endoscopic view, please?
We are not yet seeing the, yeah, now we get it.
So you can see that the JNA is coming out of the nasal vestibule. So I also want to thank a few people here before I start. I want to thank Dr. Sri Harsha, who is my fellow, and also Dr. Uday Chanukya, because I am operating in their hospital, government hospital, which is a hospital where they practice in Hyderabad. Thank you very much, Dr. Harsha and Uday Chanukya, and also the anesthetic team. Let's get started. Now, the first, so it was actually grossly deviated. I tried to pack. So I use 1 in 1,000 adrenaline. So this is what we use in nasal packing. I've been telling this for long now. I learned this from Professor Stamberger, elevator. And he always used to say, unquantified, undiluted adrenaline is what is to be used. So here we are. I'm starting from the opposite side of the JNA. It is not the side of the JNA, but the opposite side. You can see the middle turbinate. Can you all see the middle turbinate there? And as I told you, there's a little bit of sinusitis there. Can you see that? That's very clear. Of course, what I have to do is see that I'm trying to push that and see that middle turbinate there. So what I'm trying to do now is I might get a cross-code access because so that's actually the middle meatus. Can you all see the middle meatus, all of you? Yeah, that's very clear. So basically, I always approach a tumor or a disease from the normal side. So basically, if you do a drop 3, you're approaching a disease frontal sinus backbiter. Approach it from the normal frontal sinus. This is something which I always practice. And this is a thing which I've got into my bloodstream. Of course, a little bit of collateral damage, but then this will give you a lot of anatomical advantages. So here is where I'm doing an uncinect process removal. See, I'm just doing an uncinectomy for a case of a JNA, something like doing fist surgery. Yeah, debrider.
Ready.
So why do I do that? Because I need more space. I'm going to get some anatomical landmarks, which you're going to see right now. And here we are. That is the middle turbinate. Now I'm being assisted by my favorite resident Shilpi and also.
Right side foot.
Hey, do you have a good suction, please? Okay. That's a bulla. Okay. You can, if you have the axials, actually you can bring that and we can discuss. Dr. Anaga wanted to see the axial cuts. Hey, you have a little powerful suction. Oh, yeah. Okay. Happy over to you.
Put the axial cut.
No, this is not.
How to change the debrider blade?
Debrider blade is not working.
Change.
What is happening? So, pardon me for my shortcomings. I'm totally in a new environment. I'm sorry. So, okay, now what I'm going to do is to pack the ethmoids. That's the ethmoids which I'm packing. So you might ask me, how is this step going to help you in JNA, which is on the right side? This is completely on the right side. Why do you want to do it on the left side? You will see that very soon. You will see that very soon. The answer to that question in your mind will come very shortly. Now give me the debrider. So this is all part of my planning. Why is it making funny sounds? Who's debrider? Why is it like this? Oh, debrider. Can you bring the handpiece? Yeah, just change it now, please. So here, what we do, what Shilpi is doing right now is actually trying to irrigate with warm saline. So that's what she's doing. I never come out generally in fest or in skull base to defog. This is something which I have been practicing for long now. Not happy about it.
Debrider ready? Second, sir. Harsha, sir.
Back. Okay, now what I'm trying to do is to get towards the sphenoid sinus. So that's what I'm trying to get at. So basically what I will do is to go around the tumor. So the idea is to go centripetal, not centrifugal. So that's the lamina papyracia. Okay, so here we are. There's a little
Axial we have put.
suction. No, no. Now, can you all see the tumor there? All of you, please. So that's the lamina papyracia. The tumor, according to the scan, is filling the sphenoid sinus. There's a small area of the sphenoid sinus not involved by the tumor. So I'm trying to get that area. Debrider, please. So that's the area, according to the MRI, not involved by the tumor. Can you see that's the tumor? Can you all appreciate that? I don't know if they can hear me. Debrider, please.
Yes, we can hear you, Dr. Jankiram.
Yeah.
It's a good picture. We can see very well also.
Back, please.
Can you hear me, Dr. Jankiram?
Madam, yes, madam.
Yeah, it's going well. We can hear you properly and we can see the picture also very well.
Oh, thank you, ma'am. Debrider, please. Suction. Okay, so that's a 4K camera of Sri Harsha. And you can see here that this is the sphenoid sinus I've opened. And you can see that there's a little bit of space there. Debrider, please. Debrider. Okay, now having done that, so basically, why did I do this step? This is very, very important. You will see that I will be placing a pack on that area. So what do you mean by getting controls in JNA? So this is something which we always constantly tell in JNA. Getting controls means you have to get controls. No, the problem is, I think, in the suction. Suction may problem. Okay, that's skull base.
Yes, that's well seen.
Now I'm going to press that JNA.
Yeah, you can see the cystic component of the JNN.
Exactly. So that's actually the a polypoidal change which I saw in the MRI in one area. I can show you that right away right now. So that's a JNA here.
Yeah, you can see the
That's a JNA, and that's the MRI showing that the area was not involved by the JNA. Very, very clear. So I'm just searching for that area. You know why? To get a view of the carotid and the optics. So this is the idea. The idea was to get the, see that. Now, what did I get through this? I'm getting a view of the, see the dura. Can you see the dura above?
Yes, we can see it pulsate.
Above. See that? 12
Yes,
o'clock
seen,
position,
yes,
you can
seen.
see the dura. So I
Seen,
wanted to
seen.
get the dura behind rather than to get it in a place where the JNA was there. That was the reason why I planned for this step at all. So that's part of my planning. Okay, right. Now I'm going to pack this. So I got this. So what I will do right now, you can call it something like the vegan technique or whatever. I mean, it's a modified vegan or whatever. So now, see that now. So give me a long pack. I'm going to place that pack so that I have this control over the left side of the tumor. I'm going to show exactly with the, I put the coronal MRI. I will show them exactly what I did. So that was the first part of my planning. Now hold this, Shilpi. I'll show them. Coronal MRI, please. I'm going to show them what I did because every step has got a rationale. Yeah. Now, my dear friend, can you show that? Yeah. So you can see here. Can you focus on the scan here? So what actually happened was, see, this is the left side, right? The left side was not involved by the tumor.
No, we can't see that.
Oh. Hello? Can you see that now?
No, not yet. We still have the endoscopy picture. We don't
Can you
have
give
the.
the scan picture, please? External camera, please. Okay, now, madam.
Yes, it's seen.
Okay, now you see what happened was, so that is the tumor coming till the nasal, hey, the other way, man. Swipe it. So I think the most important part of any surgery is the planning. I'm sure Professor Bradu madam would agree with me. You can see here, that is the maxillary sinus. I didn't open the maxillary sinus. That is just fluid. I knew that was fluid. And I went inside. You can see one elliptical area. Can you see this elliptical area here?
Yes.
That elliptical area is what is close to the dura. Can you see that dura? So I knew exactly that I have to get that before I get the tumor. So I wanted to have a control here, getting that the anatomy of the sphenoid sinus here, and then I am sure that I am at the level of the dura. So this is my first step. So I'm explaining you step by step what I'm planning, my brain, how I am planning the surgery. So the first step is to get this area. I found that that was not JNA at all. That was just polypoidal tissue, and I got that first. Now this is the first part of the surgery. Right. Now the second part of my surgery. What happened? Now what's happening now is coagulation. Now I'm going to shrink that tumor.
Right.
Okay, blue.
Yeah, blue.
So here, this is all coming till the vestibule here. Hey, irrigate please. Irrigation. This pink color, I hate this pink color. I don't know why. Can you hold, my dear friend? So I'm going for 400 straight away. I'm going to ask Shilpi to hold. Yeah. Okay, I'm using the Bonds coagulator because I found that was more powerful than our normal coagulator. So now can you see that? I can see the inferior turbinate, please.
Yes, it's seen.
So what am I trying to do? I'm trying to push that JNA behind so that I can perform the modified endoscopic Denker surgery. So you can see that I'm using both my hands. Give me a pack.
Pack ready. Start pack.
So, madam,
Yes.
have you tried this Bonds, this one, blade?
Yes. Yes, I have. It works
It's good,
very
no?
well. Yes. It's
What is your
good,
comment?
It's good. Very, it works very well.
Slightly more powerful than the.
And also, it coags very well. So when you're cutting the tumor,
Yeah. Correct,
when you
correct,
cut
correct.
the tumor, if you're doing segmental resection, it works very well.
Exactly. Yeah, so what I'm trying to do here is actually try to coagulate that a little bit, but the tumor is actually okay. Now what I will do is try to press that back and give me a pack, please.
Long pack ready.
Long pack, please. See that necrotic areas, the necrotic areas. So you found 2 locules there. So this is where I want my scan. I want to see where the locules are, and I can actually open the locules so that I'll get more space for the JNA to go back. So that's where your hard copy comes in. So I can exactly see the locules. It's like navigating through that tumor. Now I'm just going to place this pack so that I'm just not going to allow this tumor to come out of the vestibule, so that I can do a modified endoscopic Denker's surgery. Okay, that's good. Thank you, Shilpi. Wonderful. Okay, now here we are. Cut it. So the idea was to see the inferior turbinate. Okay, right. Now give me the cobblator, quick. Now I'm going for two-handed again. How the tumor is pushing the. So that's a problem, actually. Okay, right. Here we are. Hey, don't press too much, man. Don't press too much, man. No, you're pressing too much. Wait. Suction is not working. Suction is not working. Hold. I'm not able to do it two-handed. Suction is not working. This camera gives a pinkish hue. Yeah. No, suction is not working. Yeah. Okay. Now let me go ahead with is it blue? Is it blue, Shilpi? Just check. What we can do sometimes is that we can use our unipolar and actually cut the tumor. But there's a small risk in that. The tumor can start bleeding badly, and then it becomes a big mess. So
You can give her the elevator, she can push this too much.
sure. Yellow. Come. Why is it not cutting? Hey, what is this one? Power? Power என்னமா வச்சிருக்க? Huh? What is the So what I'm trying to do now is to get the anterior piriform aperture.
Dr. Jankiram,
Okay.
are you palpating or do you go by the feel?
Madam, you're not audible. You're not audible.
Do you go by the feel or is there some landmark which you can tell the delegates as to how to identify
Actually, what I'm seeing is the anterior piriform aperture.
that?
Okay. Can you hold this with the suction? So the question was, show the landmarks, is it? So you can see here,
Yes.
that's the inferior turbinate here. Hold this. Yeah. Give me elevator. Now that's the inferior turbinate. And this is not this bigger elevator. That is only for the septum. Okay, suction, please. Remove. Okay, can you see the anterolateral wall?
Yes.
That's the anterolateral wall of the maxillary sinus.
Yes, we can see that very well.
See the pus coming out of the maxillary sinus. So the most important thing here is to go down. The most important thing in the modified endoscopic Denker is to go down. Don't go up. You don't have to go up, especially when the tumor is not involving the superior orbital fissure, the cavernous sinus. You don't have to go up at all. Okay, now what I will do now is to take the drill and I will drill this off.
Drill more.
So here, what is the, see, that's the intraorbital nerve. Can you see the intraorbital nerve, all of you? Here. Yeah, so that's it. We have done the dissection. Now I'm going to start my drilling here. Yeah, Shilpi is going to hold the scope. Wait, give me the coagulation. I have a small trick here. So what I will do is do what is called the flow release.
You have to hold the head also.
Never put the coagulation on the side of the soft tissue because you have two nerves. One is the anterior superior alveolar nerve and the Masan and Asan. So you don't want to injure both of them. So don't do that. Yeah. Now give me the drill. Hold. Now I'm going to start drilling. I create 3 osteotomies. This is all standard procedure of Denkers. So I enter the maxillary sinus and I hang on that to create that superior osteotomy. And then I go for the lateral osteotomy here. And then the inferior osteotomy. Okay, having done that now, I'm going to elevate. So what you will do by doing this is that you will be irrigation. Madam, any questions? I'm ready to answer. You can.
Yes, I'll let you know by and by. At the
Yeah,
moment,
yeah, ma'am.
Anyone who has a question, just write it on the paper and just send it
So
forward.
here I'm just trying to take off this bone, which is the anterior piriform aperture. You can see that very clearly. Give me a Blexley or Takahashi, whatever.
So
Okay,
your
that's
inferior
Takahashi.
osteotomy. Hello.
Hello?
So your inferior osteotomy would be at the level of the nasal floor, or would it be a little
Yeah, it
lower
depends.
than?
It depends. See, I have a certain formula for this. My superior osteotomy depends on the involvement of the superior orbital fissure and the cavernous sinus. So I go very high. It's a high osteotomy. The lateral osteotomy depends upon the involvement of the cheek, the temporal fossa. These two are the main criteria. I'll go far lateral. And if the parapharyngeal space is involved, I will go very low, but till the level of the root of the teeth. So I can even see the root of the teeth and go right till that. But that depends upon whether the parapharyngeal space is involved or not. Of course, in this case, it's not involved, so I'm not going very low. But of course, I will go just below the level of the nasal cavity. But there are some cases hold where the anterior recess, alveolar recess, is very deep. And in those cases, what I will do is to try to marsupialize that recess. Because this exposure is going to actually affect your instrumentation when you're going towards the lower part of the infratemporal fossa. So always Kasam says proximal bone removal is important for distal vascular control. So don't be stingy in your bone removal. And if you're doing that, then what happens is that when you're going for distal vascular control, you will have problems. That's why we should make it as adequate as possible, but not too much. But if the parapharyngeal space is involved, the upper parapharyngeal space, definitely I'll go far lower than this. So that's my level for the lower osteotomy. Okay, so that's it. I've done my osteotomies.
Irrigation.
Now irrigate,
Suction.
irrigate, and then suction. Yeah, here we are. Okay, having done that, now what I will, that's it. I told you the tumor is involving the maxillary sinus, didn't I? So here we are, the tumor involving the maxillary sinus, again, another problem because you cannot, but there is a space there. I can see the space, of course, to locate the IMAX. Let's see what we can do about it. Now, before that, what I will try to do, give me the coblation now. Now, the thing is, I have to take the coblation and take off all this.
Yellow.
Yellow?
Yellow.
Tanni podu.
Dr. Jankiram, there's a question from Dr. Anil Kumar Roy from Pune.
From what?
Dr.
Question
Anil
from?
Kumar Roy from Pune.
Roy.
Yeah, please, please.
He wants to know which drill, what drill are you using?
Drill. What drill you are using?
I'm using now the Medtronic drill, and that is the Midas drill.
Right. And what burr? I think it's a 5 millimeter
Burr is
close
a
diamond.
4 mm diamond burr.
Right. Okay. And it's
I can see that
angulated
the
about
floor-
30 degrees, right?
What, sir, madam?
It's angulated about 30 degrees, right?
Yeah. Hey,
Okay.
leave, don't do it. Now, can you see the floor there very clearly now?
Yes. Yes.
Very nicely, you can see the floor. So I'm happy about the bone removal anteriorly. So the anterior bone removal is sufficient for me to visualize and actually elevate this JNA from the maxillary sinus. Very nicely seen there. So this is actually, see that. So that's it.
Is there any secret to prevent clogging of your coblator blade?
Is there any secret of working with the coblation blade?
Is there any secret? I think any secret, I don't think there's any secret.
Clogging, or do you don't face that problem?
Madam?
No, the coablator tends to clog quite often.
This bonds doesn't, madam. It does less. I think Professor Renuka Bradu madam has used it.
Yeah,
And,
there's also sometimes there's a cross hatching over there. You can remove that cross hatching so that opening opens up a little more. That is also what one can do. Yeah.
Yeah, I fully agree. Now, can you see that I've actually removed that mucosa from the posterior wall? Can you all appreciate that very clearly?
Yes.
Beautifully seen. Now, see that JNA entering into the infratemporal fossa. And you can see already the blood vessel. You're going to see that very shortly. Oh, it's a beautiful view. I'm very happy. So once I do that, believe me, this JNA is dead. That's it. Okay, right. Now it's again. So that's going to be my medial limit. That's a medial limit. So if I release this medial limit,
So this, what you're removing is the lateral nasal wall, right?
absolutely, absolutely.
What about the nasolacrimal duct?
No, I have not yet seen it because I have not gone till that at all. So I'm working inferior. I will show you that later. I have not even gone above. Because the tumor was filling that area, right? So I didn't want to.
Yeah, okay.
Yellow.
I'm working inferiorly, completely inferiorly.
Yellow.
Okay.
My idea is actually to get that blood supply before I do anything.
Right.
Can you see the tumor so beautifully there? Very nicely. Yeah.
Yes, well seen.
Okay, I'm going to take off all this bone. Of course, as madam says, the laser lacrimal duct will be seen somewhere here, right? I'm not yet gone there. So what is this? This is actually the inferior turbinate. That's the inferior turbinate. But the first step in a modified Denkers would be to cut the inferior turbinate. Here we couldn't even because there was no space at all.
Dr. Jankiram, there's a question.
Yep.
They want to know what is the setting of the coablator.
9.5.
9.5. Okay.
Always any tumor I have at 9.5. Okay, Blexley, let me remove all the debris and then I go for the drilling of the posterior wall. Now the tumor is here. This Blexley is not.
The second ready.
Yeah.
Don't put it back. Give it to.
Okay. So there was one question. I think many people ask this. If you cut the NLD, do you face epiphora? This is something which, believe me, in our cases, we have faced now. I've done more than 400 JNAs. We have faced at least 5 cases of epiphora. 5 cases I had to do DCR, and hey, the suction is not working.
Suction open.
5 cases I had to do a DCR, and all of them were revised by me only. The patient came after a few years because of fibrosis, and I had to do dacrocystorhinostomy. So the problem actually, when you use heat, when you use lasers, if you use coablators, incidence of fibrosis is high, 100%. Okay, now give me a. Okay, now I'm just going to go inside. So this is the posterior wall. Give me a cobblator. I'm just using coblation just to take off all that without causing much bleeding. So here we are. Of course, I will show you the nasolacrimal duct for sure. And see, one thing I'll tell you is, even if you accidentally cobblate the nasolacrimal duct, don't get scared. You do a DCR. That's it. So all of you would definitely be conversant in doing a DCR. If you can't do a DCR, don't do a JNA first of all. So you should be knowing how to do a DCR. So basically, sometimes what happens is you don't find the anatomy, the tumor is so big, all that. Then later you can do the DCR and open up the sac. Of course, let us see what this whole tumor is pressing on the lateral wall. You can see that very clearly. Okay. All right. Can you give me the... Okay, something about the osteotomies. So basically, I want to tell you also what complications we have faced. It's not that, everything is rosy. When you do a high osteotomy, for example, when you're doing it very high, what happens is that there is a puckering of the ala. This is something which we have noticed. And that is especially when we tackle the cavernous sinus and superior orbital fissure. What happens is there is a puckering of the ala, and for that we have designed a prosthesis.
Debrider?
Not debrider. I don't want the debrider because it will start bleeding. Coblation. We have designed a prosthesis. Of course, I can show you what we have done for that. So basically, if you have a cosmetic deformity, give me cobblator. You have a cosmetic deformity.
Blue.
You ask your fax max surgeon, and they will give you beautiful prosthesis.
Dr. Jankiram,
Yeah.
there's one question from Dr. Milind Samangadkar from Kolhapur. He's actually addressed it to me about the 4-port of Gradu technique. Can I take
Then you can answer that better, madam.
So can I take a few minutes while I answer that?
Madam, please, madam.
Okay. So first of all, I'd like to tell you one thing, that Dr. Jankiram and I have had many discussions, and we have both, he's a good friend, and we have both agreed to disagree. And I believe that when there is disagreement between surgeons, that's when science grows. So, he's doing a brilliant job here. And, I'm sure that the surgery is going to go like a dream. But as far as I'm concerned, I am very concerned about the fact that removing the pyriform aperture in young boys, where the angiofibroma never adheres to the anterior facial skeleton, is something I would prefer not to do. Because, we never did an SMR in children under 16. So removing the pyriform aperture and a significant amount of the anterior facial skeleton, especially in large ANS going across to the major part of the infratemporal fossa parapharyngeal space, you need to remove a lot of the anterior facial skeleton to reach there. So I don't prefer to do that. What I do is, instead of opening up through the pyriform aperture, I keep the pyriform aperture intact. And I make one more port. So one port is the contralateral nostril with a posterior septectomy. The second port is the ipsilateral nostril where the tumor is. And then the third port is in the canine fossa. So you keep the pyriform aperture intact, but you make a wide opening in the canine fossa. Enough for one instrument like a forceps or a cobblator, and the endoscope to be able to go through that canine fossa. And the fourth is an opening in the buccogingival sulcus through which the assistant can put a finger. So the ports 1, 2, and 3 you use for instrumentation and the scope, and the fourth one you use only for the finger. I found that it's very easy to get very good access laterally with these 4 ports. And the other important thing is, one, because we don't touch the nasolacrimal system, we don't touch the pyriform aperture. And another one thing is, you see, in Dr. Jankiram's hands, this is excellent. But you see what happens is, your instruments are still going coaxial. They're still going parallel to each other. But if you do a 4-port technique, your instrument in the nostril and the canine fossa can come at a wide angle from each other, from separate angles. So the control that you can get with those instruments is higher. It's like how laparoscopy, you get instruments coming in at a wide angle so that you can work comfortably. In a 4-port, that is what you can do. You can come with the instruments almost with, 180 degrees separation between the two instruments. So these are the reasons why I prefer a 4-port. And I've seen long term, like Dr. Jankiram said, that you can get epiphora, you can get a dry congested eye. I've seen cases where patients have come after 5-6 years with flattening of the face and unequal development of the mid-face, asymmetric development of the mid-face in these patients. So this is my way of doing it. It's there, the article is in there, is in the iJohns, you can have a look at it. But I'd like to say one thing, and I want you to remember, there are many ways to skin a cat. There are many ways for doing the same surgery, and experts will tell you different ways, and you have to choose whichever one works well in your hand. And what works very well in my hand is the 4-port with minimum morbidity. Okay. I hope that answers your question, Dr. Milind.
Very well said, madam. Actually, I really admire madam's technique. Actually, you see, more important than that, see how innovative. I like innovative people who actually follow new paths. They create paths, and that is what I like in madam. And of course, see, basically, we're all students of madam. So of course, but what works better in our hand, we just follow, that's all. So
Yes,
you
I
can
agree.
follow what works good in your hand, that's all. But
Right,
I
right.
love innovators. I love people who think out of the box, and that technique was designed by madam. So that is very important. You should understand that. Give me cat spot. That technique was published and designed by madam. So that is something unique, right? So there's no point in copying anybody. I think that is where science grows, and I love the way actually we think, our brains think. See that? Now what I'm trying to do is I'm opening up the periosteum. Now, what is the level of opening? So that's a roof. You can see that's a roof. So I have to go till here to open it. And that's the lateral part of the periosteum. So now what I'm going to do is to take that roof here, but you should understand that you will be very close to the infraorbital nerve. That's the roof. If you take it here, you'll be very close to the infraorbital nerve. That's very, very important. So these are some nuances which you should remember. I'm sure the IMAX is, see, IMAX never comes down. Please understand, it comes here above. If you draw a center of the maxillary sinus, it comes up, it doesn't come down. Only one branch comes down. What branch is that? Yes, posterior superior alveolar artery comes down. Apart from that, pharyngeal artery comes just posterior to it. Apart from that, if you that's actually, see, what did I take it? So that's actually the orbital plate of the palatine bone. See all that. So everything you have to actually experience as you do what you're removing. Even a small piece of bone you remove, you name that piece and drill. So these are all the the technicalities, the beauty of the surgery. So now I'm now going to see again and again. I say, unless you have a good exposure, see how many instruments are inside. See Shilpi, see me, and none of the instruments are crossing over. No, have it. None of the instruments. That is because I have Shilpi, I can do it. Or else I am seriously telling you, it's going to be, my life is going to be like,
miserable
without have four-handed.
So, Dr.
So yeah,
I'd like to say,
I'm very proud that the ladies now are into a JNA surgery, like Madam Anaga, Madam Shilpi. I'm so happy about that, because And now she's finding it difficult to show because it's a very narrow space which you're operating. I've taken off the orbital process. See, this area I drill only if the inferior orbital fissure is involved. So these are all nuances of surgery. Now I take my coblation, and what I'm going to do is to actually completely devascularize the tumor very shortly now. Okay, ready? Huh? Keep clips
So
ready.
one thing which Dr. Jankiram said very clearly is that angiofibroma surgery is a team surgery. So it is very important to create a team. And I'd like to take this opportunity to deeply acknowledge with gratitude the immense contribution of Dr. Anagha Joshi and Dr. Kshitij Shah towards the development of this surgery.
Yeah, I think Madam has closely associated with Dr. Anagha Madam and Kshitij Shah. And I've been seeing that team right from the beginning, and they're doing a unique work in India. So proud. And now what I'm going to do, see, sometimes what happens is that fat comes out and disturbs my anatomy. So there was an article by Karao about this fat, about the vascularization of this flap. I think there's an article published by him. So what you do is just do like this. See that? So the fat comes out, do like this and comes out. It comes out. So there's a lot of fat. Believe me, there's a lot of fat. So what does this fat signify? It signifies that you're lateral to the tumor. You're definitely lateral to the tumor. The problem is, what actually is the problem with this fat? It mars the view of the branches of the IMAX. So I don't hesitate to take this out. So if you had seen my videos, my book, most of it, I would be taking all this out to get a very good anatomy. See that? This is the movement I do with my debrider. This is the movement I do with my debrider. You see that?
Yeah, very well seen. Very well seen.
Okay, some people actually use the coblation on this fat. Yes, you can do that also. This block, please. Just so, but the problem is, I want to see that artery right end on my view. Unless I am convinced that, see, we have had one patient, I think Shilpi knows about it, where we actually coblated the vessel. And after 15 days, the patient came with massive bleeding from the IMAX. So to me, I think unless I see that properly clip or coblate, she always says, hey, be careful about that case. So we learn by our mistakes. And I have had my own share of complications, mistakes, and I learned by my mistakes. So that was a long time back. And from then onwards, I make it a point you keep the debrider, direct it downwards. Don't irrigate. Direct it downwards. Don't direct it upwards. Because the IMAX, as I told you, comes upwards. The only branch which comes downward is there are two branches. Medially is the descending palatine. Laterally is the posterior superior alveolar. Apart from that, you will not find any branch. See, it's eating up all the fat. You can see that. And what you will see ultimately now is the lateral pterygoid muscle and the temporalis muscle. You will see that very shortly now. No. So when you pull it out, please understand that an artery doesn't come out. It's only this fat is vascularized fat. Please understand that's why there's a little bleeding. So that is the article which Dr. Soma and Dr. Soma from Singapore and Professor Karao published. It's vascularized fat. See that? You can see that little veins over there. So in fact, this fat has been used to close 10 canal leak.
Italy.
Huh?
Italy.
Yeah, the people. No. This is by Pittsburgh, not Italy. The Varese group didn't do that. Okay, having taken off all this fat, now I will show you the anatomy. I'm very happy about that. Now I will be showing you. See that? Can you see that now?
Yes, it's very well seen.
Yeah, that is the advantage. So I mean, in JNA, I understand that you have to be super conservative, but sometimes when you face post-operative complications, you learn from it actually. So to me, I think I need to see that vessel. I need to be very convinced that I'm seeing the IMAX. I need to see where it is, and only then, yeah, now give me the coblation. Now I'm going for four-handed. That's it. So now it becomes very simple now. That was vascularized fat, which I removed. Now see here, blue. They don't press too much.
Also, what you can see is that the artery can be stretched because it has a lot of redundancy.
That's right. Hey, don't press too much water. It's giving too much water. ज़्यादा पानी आ रहा है. कौन प्रेस कर रहा है? Is it? और भी फैट है थोड़ा. See how much of fat is still there, huh? That coblation also eats a little fat, but I take it to the debrider. It takes a long time if the coblation eats and it gets blocked also. Give me the debrider now. So I am very clear that I will remove that fat, see the pterygoids, lateral pterygoid muscle and the temporalis. Hey, don't do that. Yeah, put. When I'm doing inside, you should not put it like that when I'm doing inside. Yeah. So unless I see the lateral pterygoid muscle, and see now, I'm seeing, can you see the muscle now? Can you all see the muscle? So that's the muscle.
Well seen, yes.
Yeah,
and
see
you can
that.
see
Now,
the artery in that.
You can stretch it. Can you see the stretch?
Yes, you can see the artery.
Can you see the stretch? As madam said, you can see the stretch. You can stretch it actually. So that stretch can actually give you a beautiful view of the artery. See that? I'm going to show you that very shortly. How nicely you can see. Yeah. I know that's the artery.
I think I heard something falling down.
Is it? Wow, what a beauty.
ये जो है ना,
Can you see the artery going inside very beautifully there? All of you? I'm close up
Very well
now.
seen, very well seen. I'm
Yeah. Now give me the cobblator. Cobblator, please. Cobblator do bhai. Kya ho raha hai? So if I do that, major part of the tumor is over now. After that, it's just, see, my dear neurosurgeon, this is the coronal plane. You have to learn also the coronal plane if you want to be a skull-based surgeon. So there's a neurosurgeon from one of our hospitals in Hyderabad, the Olive Hospital, where we are starting. And he has come and we're going to work together. Young neurosurgeon. So you can see here. So you can see the artery there. I'm going to coblate it now. Yeah, you can see the artery very clearly now. All of you, see how nicely it's seen.
So there was also a lateral branch as well, which you have coblated, right? Along with this one, which is seen now.
Now you see this fork type, one here and one here. Can you see that artery here and here?
Yes.
Can you see that?
Yes.
Now just look at this fork. Now I'm going to the MRI now and correlating it for you. 1 second. Just see that fork. Wait, I'll show you that. Show me the MRI. Now this is what I feel you have to read the MRI like this. You see here. This is the fork. Hey guys.
No, we're waiting for the external camera. We're waiting for the.
Just see how precise your MRI has to be read in your brain. It's just a matter of, that's what I always say. Kassam says the 4D of a surgeon. See here, this is the fork. See that? See this fork here. Can you see here?
Yes, we can see that. If you can
And-
use a pointer, it would be better.
Pointer, see, pointer kuduma, pointer kudu. This is the, I'll use this. See here, what has happened is the IMAX is coming like this, okay, like this. So that cut is showing here like this, see here, this is the cut here, see here. It is cutting like this, cornel is cutting like this.
Correct.
Then it is coming up a little, and then you see that is the exact, like the external cavity and internal cavity, like that it's separating into the sphenoparotid and the DPA. And then the next cut is showing like this. You get my point or not? It's
Yes.
like this and then like this. So you have to imagine that. So I can either ligate it here, I can ligate it here, I can ligate it here. These are individual branches. This is a single branch. This is a main trunk. So this is all JNA surgery is about. If you can get this 3D anatomy, I think you're mastered JNA. That's it. So basically, you're trying to get that 4D out of a 3D. This is what Kasam keeps informing us. And that's exactly what I learned from him as well. So here is that you can see that that's the artery.
Yes.
I'm going to show you, I'm going to trace that artery behind for you. Sorry, Shilpi. Sorry, Shilpi. Yeah. So that's the artery. You can see that very clearly here, all of you.
Yeah, very
See that?
clearly seen.
Very
Very
clearly.
seen.
Give me blue. No, blue. Shall I? You want me to? Yeah, clip it, but it's going behind, my dear friend. Now, where is this artery going behind? This is not the main trunk. Please understand, this is not the main trunk. The main trunk is behind. This is what I want to tell you. See here. Now, see that. Now, can you see that? It's going behind. I'm now trying to cobblate all that entering. This is all entry into the tumor. Here is where the bonds really helps, as madam also told. See, that's the muscle. Can you see the lateral pterygoid muscle, all of you?
Yes, it's seen.
So the juniors should know that the IMAX comes between the two heads of the muscle.
Do you always coblate? Ever do you take clips?
Actually, I do a clipping there. I can clip it. I'll show you but
No, the coblate is working very well. Not a problem.
come again, please. What?
The coblate is doing very well with it.
Combination is working very well.
Yeah, ma'am. So, madam, you're happy, madam? Any comments? I need your comments. You're the dawn of JNA.
No, I think it's going brilliantly. Very nice. And you're showing the
Thank you.
anatomy very well.
Thank you, ma'am. So you see that protrusion of the JNA came out.
Yeah, we can see the lateral border of that. Yes.
When you're using clips.
Yeah, can you go down? See here. See this one. See this one artery. This here. Just below my coblation here. See, this one. DPA. See that lumen also cut. Can you see? Shilpi, wait, man. So beautifully seen. Hey, I'll show you the ball probe. Give the ball probe. See how the DPA is like a small. It is hiding. It is showing that, my God, I will not show Janakram. See here. See this one.
So
See, that's the lumen here.
Yeah. You can see.
This one. This. Yeah, see that. Clearly seen lumen. Yeah,
Okay,
these are all.
okay.
See the
Can you show
DPA
it
going
one more
inside
time?
here.
Can you show it
See
one
here.
more time?
Beautifully seen. Wow.
Yes.
Yeah, bipolar. So what you do now is, coblation. What you do now is you coblate the DPA and you go behind the DPA. See here, this is the DPA. See here, this is the DPA. Now what I'm seeing here, I'm using the yellow. And what am I going to do now? I'm just going to trace the little fat always is a problem. Now, Okay, now let us assume that you have bleeding now. What will you do? What will you do when you have bleeding? Nothing. You just do nothing. You just have to keep a pack. That's all. Go to another area. Debrider. Okay, that is the advice I give to most of the juniors. They become scared of the bleeder. Don't get scared. They say even the aorta can be stopped by compression. So we need pressure. That's the most important thing you have to do. So don't get scared of any bleeding. You just need pressure. Pressure, weight. See that now. See that. Now you've taken the fat out. See how nicely you're able to.
Dr. Jankiram, one question.
Yeah.
When you're using the debrider to remove the fat, has it ever happened that the artery has come in the debrider and got cut?
Generally, what happens, madam, when you do that, see, when you I'll show you that movement. See, this is the movement. The movement is important. No, I'm not showing them. Just show. The movement, what happens, you see, open the debrider blade first. Point number one, open it. This is open, right? Wait. Hey, put the suction, man. Put the suction. I want to show them. Because most of them, they use the debrider directly. This is not the way I use the debrider. You see here, I keep the debrider like this. And then see here, I pull it like this, like an elevator. See here, the artery never comes. Only the fat and the fibrous band comes. Artery never comes into the suction.
Okay.
So what I do like this. I never go and debride there. So like that I do, and then I pull. See if there is fat, see what happens? The fat will come out. And then I debride. More fat comes out. See, again I debride. See, more fat comes out. Then again I debride. It's like that. So the artery never comes inside the debrider. See, and I'm seeing what I'm debriding. Hey, go up. Show me up.
Yeah, that's seen well.
Huh?
So you get the fat to come to the debrider rather than put the debrider
Yeah,
on
exactly. Exactly. I don't go and see. I should not debride like this. I pull like this and get it out. I pull like this, get it out. And now you debride. And you're seeing exactly what you're debriding. So that is the idea. I hope I'm clear.
Yeah, no, it's clear. It's clear.
Now I think I'm done, almost done with this DNA. There's nothing big in this DNA now. I just want to blue.
Dr. Jankiram. Hello.
Yeah, yes, madam.
Yes, when you're using clips for the maxillary artery, what is the size of the clip and what instrument do you use for clipping?
Madam, I will show you. 1 second. We have the Carl Stores Liga clip. Show me, no? Show me the clip. Madam, now I think there is also another surgical company, Indian surgical company, which is manufacturing very, very cheap, and you can use that also. That's also very good. I am using that also now. I'll show that right now. Okay, so inferior dissection is super. Now I'm going for the okay, now what I will do, why is this bonds is gone like this? Okay, now what I'm going to do now is actually going to get that tumor back. Give me. Now almost done. Why? Leave. You black sleep, big black sleep. Almost done with the tumor. Let's see. Okay.
All pack out.
All packs out. Come out, Shilpi. बहुत बड़ा ट्यूमर है. So the advantage of doing a denker in a case of a tumor coming to the vestibule is you can push that into the denker's cavity. Okay? Can you see that clearly?
Yes, yes, seen, yes.
This is the advantage. See, still I have not gone to the nasolacrimal duct at all. See, that's the middle turbinate. Can you see here? That is the uncinate process. So here is the nasolacrimal duct here.
Correct,
Okay.
correct.
Now give me a coagulation. Now I might do what is called the principle of segmental resection. Principle of segmental resection. So I don't want this whole. Oh, hold, my dear friends. You hold, no. This is the one going towards the dura. But this one is more of, hemorrhagic. Towards the dura, it's all hemorrhagic, according to the MRIs. No, you. Now I'm just going to start my
So what you're doing is you're resecting the infratemporal bit separately, right?
No, this is nasal part.
Yeah, no, but you're segmentally dissecting between the infratemporal part and the nasal part.
Yes.
Yeah.
Best instrument to do this is unipolar. Polarado.
That's what we use quite often. We use a ballpoint monopolar.
Yeah,
That
Colorado.
also works very well. But this is also what I'm saying is that it's not getting blocked at all. One of the
that is what,
disadvantages is that it can get blocked continuously, constantly. But your wand is really working very well.
No, the bonds is.
There's one query. What wand exactly are you using?
This is a bonds normal evac 70 only.
Okay.
Not the skull base one and all.
Okay.
See, not even one time it has got blocked. So far,
yes.
If you look at the suction port, it is very big compared to the Smith Nephew. And the power of the bond is 3 times the power. It's like a Chinese jet plane.
Okay.
Now give me one. Let me.
There's one more question. They want to know which company coablator you're using.
Bonds.
Oh,
See here.
yeah. Okay.
Wait. Hey, warm saline. Give me a pack. So if you have intratumoral bleeding, it's very difficult for you to control. So there is no point in just, cobbling. Just pack. That's it. Just pack. That's the best way. Intratumoral bleeding, you have to pack. Just pack. That's it. You pack, boss. You pack. Now just pack it a little bit and just wait. That's it. So all these are small intratumoral vessels. Even though we have ligated the main vessel, you might have blood supply from, some different vessels. That's okay, no problem. But actually, if I use the unipolar diathermy, it would this bleeding would not be so much, 100%. Now you see what I'm trying to do is again and again I say, don't get scared of bleeding. Bleeding is one thing. Many young surgeons, they get scared of. The only thing you have to do is pack weight, boss. That is the only mantra of any surgery which bleeds, cavernous sinus, whether. So whatever bleeding you see is just pack weight. That's it. So if you do that, 100% you will conquer that tumor. Give me coagulation. See, it stopped completely.
Yeah. And as Dr. Jankiram said, there can be other blood supply. So it can be ascending pharyngeal, it can be contralateral maxillary artery, it can be the Vidian artery. These are the ones primarily for extracranial tumors that can bleed. And you see, it always responds, and JNM responds to packing. So you can, as you can see, he's doing it very well. He's compressing with the pack and at the same time continuing the surgery. So that can be done. But remember that these other vessels also can be a significant contribution to the tumor. Dr. Jankiram, there's a couple of questions. Can you take them?
Madam, what, madam?
There are couple of
questions. Please.
Okay, so one of the questions is, do you use a DCR stent? I think post-operatively if you have epiphora.
What is the question?
Do you use DCR stent?
DCR stent? No. See, that's the first part of the tumor. This tumor cannot be removed fully. Please understand, it's coming till the vestibule, and if you are trying to remove it in one piece, believe me, it's next to insanity. If it is coming out till the vestibule, it's very difficult. It's very difficult for us to remove it as one piece. So that is going to be our, see that, that's going to be the region of the, go inside, Shilpi, of the skull base. That's the skull base, and dura is dehiscent there. You can see that.
Yeah.
So all your instruments are directed downwards.
There is another question, and that is what is the importance of dissecting and clipping the internal maxillary artery before you start dissecting the tumor? I think you said that very clearly, that you get the main blood supply of the tumor first, and then you do the dissection of the tumor. Am I right? Is that what you would say?
I'm not able to hear what she's saying.
You first get the blood supply, then you go for the tumor.
That's exactly what we are doing, right?
Yeah, this is Dr. Praveen Bhosle from Pune who's asking that.
We have not clipped it, but we have coagulated and separated it. So anyway, we've got blood control.
Okay, give me a pack again. So what I'm trying to do now is to get that part from the skull base. So one more pack. So these are all packs, pack weight, and then keep dissecting. That's it. See, there is one mantra in skull base surgery. This again I learned from my guru, Kasam. What is that mantra? The mantra is, a good surgeon should actually know in which stage he has to go in fourth gear and which stage he has to go in first gear. This also I learned from Professor D. Cruz of when I worked in Tata Memorial. Those words keep ringing in my ears. There are some surgeons who will waste a lot of time in actually, coagulating it and things like that. This is not the stage. That's not vital structure at all. There is no vital structure here. It is only intratumoral bleed. So what you do is just pack, keep carrying on. So this is fourth gear surgery. First gear surgery comes when you're going to the carotid. So when you are near the carotid, you know there are vital structures behind. When you have nerves behind, that is where you go on for first gear surgery. Now I'm going to show you that we have packed it here, of course, and I'm not going to remove this pack now.
Dr.
So,
Jankiram?
yeah.
Yeah, there's a question. How are you, like, what is the arrangement between you and your assistant? Who is holding the scope? Who is?
You can see that.
An
You can see
external
that now.
picture of how the 4 hands are being used.
Oh, cobbler, quick. Come on. This is another.
So
can you
that
show the
question we
external
will
camera,
answer
please?
later on, after a little while. Before he finishes, we'll ask him to show the thing, the way they're standing. But at the moment, let him continue with the surgery. Okay, they're showing the external camera. Can you see Dr. Jankiram? And his assistant is at the head end on his left-hand side. And she's holding the telescope to give him exposure and correct vision. And he's using both his hands through the nostril. Dr. Jankiram, do you ever do a posterior septectomy?
I've not yet done it.
But do you do
I've
it?
not yet done it.
Do you do
I would
it
do it.
otherwise?
I would do it, but then till now I didn't do it. Yes, I will do it.
Okay.
I will do it when I come to the nasopharynx. Yeah.
Right.
No, elevator. Right. I've cut the middle turbinate now with my coblation itself. Yeah. Now that's the middle turbinate which I cut here. This one here. Okay. Yeah, bhai.
So there is always attachment of the tumor to the middle turbinate. It
Yeah,
may
I've
not,
cut that.
it doesn't usually attach to the inferior turbinate, but the middle turbinate, it is always densely attached. And to the superior turbinate, it's usually a very flimsy adherence.
Give me a Takahashi.
So primary
Takahashi, please.
angiofibromas have a very predictable way of adherence. So just as we say predictable spread, even predictable adherence. So it never adheres to the inferior turbinate. It always adheres to the posterior end of the middle turbinate. Very familiar adherence to the superior turbinate. Very dense adhesions in the nasopharynx and the lateral nasal wall. Anterior to the eustachian tube and posterior, but never onto the eustachian tube. So the dense adhesions in the roof of the posterior.
Suction block, quick.
So these are the ways the tumor will adhere if it's a primary tumor.
Takahashi.
Posterior end of the septum.
Keep irrigating, man. Keep irrigating. Warm saline, please. Warm saline. No, don't. Yeah. So this is just going into the nasopharynx now. Give me a pack now. Give me a pack, long pack. Long pack, please. Unless, as madam said, there are 2 other blood supplies, like for example, the median artery or maybe the ascending pharyngeal. It's very unlikely for such a tumor to gain blood supply from the internal carotid artery. So because I will show you the wall was intact. So contralateral is okay, that we may get it, but I don't think internal carotid artery is supplying. So that way we are definitely sure about it. So I'm just packing again. So basically, again and again, I say, keep packing. The same principle applies to any skull-based tumor, which bleeds, whether hemangiopericytoma, whatever, just keep packing. And this pack, believe me, works magic. It works magic, actually. Okay, right. Now I'm going now to the infratemporal fossa. Suction, please. Suction. This is a very, very big tumor, and we are not embolizing the tumor. So naturally, we will definitely have blood loss. It's not that we will not have blood loss. We will have blood loss. I warned the anesthetist also about it. So that's the middle turbinate there, which has been cut. Give me a debrider now. Debrider. Now I'm going to go for the bulla and the ethmoids. That's the bulla and the ethmoids now. See that? That's the bulla. You can see the pus, which was also seen in the MRI.
Yes, well seen. Can you see the sphenoid component? We can see the sphenoid open now, and we can see the sphenoid component. And one thing just for the audience, that usually almost always the JNA will, the angiofibroma will go through the floor of the sphenoid, not through its anterior wall or normal.
Can you see that?
Ostium.
Other
Yes,
side,
very well seen.
I kept that gauze piece. You can see that. See that? Can you see
Yes,
that?
well seen,
The
well
gauze
seen.
piece.
Yes, the one you kept right at the beginning of the surgery.
Yes, that's right. Yeah. So that's the sphenoid component. Lot of see that all that is coming down now. That's the sphenoid component, very clearly seen there. You can see here that I'm inside the sphenoid sinus now.
Yes.
You can see the dura dehiscent there. Okay, right. Now give me a pack. Now I will place a pack along the dura. So basically placing packs, going around, this is all JNA about. The JNA is not a difficult surgery. In my opinion, if you're not scared of, bleeding, then I think JNA is just yet another surgery. Okay, give me a scissors. Let me cut off the.
Cut the back.
Cut. Quick. Yeah. So how many packs inside, my dear friend? Scissors, quick.
Yeah.
Scissors, please. Okay, here we are. That is the middle turbinate. Okay. Jane is here. The middle turbinate. I might take around half an hour from now, madam. Just half an hour.
That's
Do we
fine.
have time for one more case, or we don't have time?
No, we have time. We definitely have time till 6:30.
What's the time now?
It's 5 o'clock.
Oh, 5 o'clock. Okay, good. Okay, now that is the infratemporal fossa part. Okay, correct.
You see how
Give me
he's
the
applying a
coblations.
controlled traction to rotate the tumor out of the infratemporal fossa.
Can you go here, please? Elevator. Elevator, please. Elevator. Now I use my elevator for that.
Another thing which works well here for this traction is also a curved suction. That also works well.
Hey, you're giving mine now. You've broken mine. Okay. Mine is only for septal correction. Please. Give me a powerful one, man. Go inside. Silpi, you can't do assisting also, man. Believe me, these guys should learn. Yeah. Go inside.
sometimes at this point you can see the maxillary nerve sometimes. Am I right, Dr. Jankiram?
Madam, I can't hear you, but
I said sometimes when you are doing this retraction, you can see the maxillary nerve.
Maxillary nerve, you see.
Oh, yeah, maxillary. Yeah, but I'm still down. I am not yet gone up.
You're
That
not
is,
gone up as yet. Yes.
yeah, if I go here, I'll see the maxillary now. I'm just down. I will show the maxillary now. So that's along the lateral recess. That's along the lateral recess.
Yes.
Hmm? I'm inside sphenoid sinus. Yeah. What? You're asking me why?
You have to do posterior septum.
Pack, please. Okay, that's a lateral recess. Now let us dissect the V2. Give irrigation, please. Irrigation.
Akshan.
Okay, now what I'm going to do is sort of, as I told you, there's so much of fluid voids. Did you see the MRI?
Yes,
There's
yes.
full of, intratumoral, so much of vessels. And I expected this bleeding. I've told the anesthetist to reserve 3 bottles of blood completely. So that's a pterygoid wedge here.
Yes.
So this I expected before. So it was not new to me. This tumor would definitely bleed. There's no doubt about it.
This tumor was not in the
this
pterygoid
back-
fossa, right?
Not yet. So I'm going to show you. Can you show me this? Can you show me this MRI? Just show me the MRI. I'll tell you why this is actually bleeding so much. Usually JNAs have 2 components, as we all know. One is vascular component, second is fibrous component. See this area.
Yes, we can see. We can see. Yeah.
See this area. This is like, it's damn vascular. You can see so much of fluid void. Can you see everywhere? More than a salt and pepper appearance. You can see all that big vessels. They're all small, not small vessels. They're all big vessels intratumoral. So even if I've ligated this vessel, you have so many vessels which are actually, they're all neovascularization. Maybe some unnamed vessels which are coming inside from branches of the external carotid. So, but I mean, this is why I expected a lot of bleeding in this tumor. This is a very vascular tumor. And so the idea is you have to tell your anesthetist that you have to reserve at least 3 pints of blood. Yeah, ready?
He doesn't know other background.
So this is a bleeding which I expect. Madam, please. Yeah. I expected out of this tumor, and I would not have escaped from this bleeding at all. There is no way I would have escaped. Now I'm going to just get the why are you standing like this? Oh.
Dr. Jankiram, I know just one question. You can answer it whenever you have time.
Yeah.
There's a question from Mumbai, Dr. Kaustubh. He wants to know, are you using any instrument to retract the anterior nares?
No.
No, yeah. That's because you got wide access. So you don't need to retract the anterior nares. Yeah.
Yeah, that's right. I'm not using any instrument for the anterior nares. Yeah. Now, I think I will now go in for a posterior septectomy. Ablation. What I tried to do was to reduce that posterior septectomy a little. That's why I delayed it, or else I would have done early and created a big septal perforation. So, because the tumor was, yeah. There are two reasons why I'm doing this posterior septectomy. Number one is the posterior end of the septum can give, it can get attached to the posterior end of the septum. That is the first point. Second
Yes.
point is, if you want to have bilateral access of the nasopharynx, then the posterior septectomy helps you a lot. Apart from that, if the patient had a cavernous sinus involvement, then I would have done like the pituitary approach. I would have come far anterior in my posterior septectomy. So this is something which I want to highlight. I don't want to do a very huge posterior septectomy for a tumor which does not involve the cavernous sinus. I hope I'm clear.
Yes, it's very clear. So when it's involving the cavernous sinus, you need good cross-court access. That means you have to have an angulation which will allow you to work comfortably in the cavernous sinus, even from the opposite nostril. That is why he's saying, and then that time you need a septectomy which is
Elevator.
significantly large. You obviously stay away from the cartilage in the septum,
Give me another
but
one.
a large part
me
of
to
the
septum
bony
correction.
septum needs to be removed.
Take it and keep it somewhere else. So yeah, exactly. So that is the point. So this is actually to suppose you have a JNA attached to the septum, or to get a direct access into the nasopharynx. That's why I'm, yeah. No, Blackesley. You should know what instrument next, please. Thank you. So that's it. So what I'm trying to do is to go this side and have a look at what is happening here. Okay. Let me check. Suction. Okay, here we are. Let me go down and see if the nasopharynx. See that there is definitely an attachment there. You can see, all of you can see that. See, it's attached here. It's all attached here. So I have to take this out. Oblator. Hold, please. Now I'm just going to take off the other side. No, this one. No. Okay. Go this side. So go this side. So I'll just take it from there. Where is it? Where I go from this side?
So you see he's accessing the nasopharynx with a posterior septectomy.
Absolutely. So now that you see that the posterior septectomy, the most important thing is see the posterior end of the septum here. You have to see the posterior end of the septum here. Can you see that now? Yeah, very nicely seen. Can you see that, please?
Yes, seen. Yes, seen.
See that venous blood. This is not new bleeding. This is actually the intratumoral one. You should be careful about the eustachian tube. See how beautifully Shilpi is showing me that area in that small, narrow. That's why I'm able to do 400. That's it. I've separated it from the posterior septum. You can see, can you see the eustachian tube orifice there
Yes.
very clearly, please?
Yes, it's very well seen. And this is what I was saying, that it never attaches to the eustachian tube itself. It attaches
Yeah.
behind, even to the fossa of Rosenmuller, but never on the eustachian tube itself.
Absolutely, absolutely. So here we are. So I'm now done with almost the nasopharynx part. Then now let me check whether I am having less bleeding now. See, all these areas, for example, the septum, these are the areas you can actually get small. No, actually. You can get some small feeding vessels. We are trying to cut off all these feeding vessels. That's it. That's the idea of all these. Wherever it's attached, it will just gain its blood supply. So we are trying to cut off as much of that. So despite that, you see that it's still a little bit of bleeding is there. So let's see. Now hold, man. Now, yeah, suction. Yeah. Now I'm going cross coat. Let's see. So this is what is called a controlled traction. I'm using a Lux forceps now.
So this controlled traction is something that, you have to know exactly, one, how much pull to apply so that you don't tear the tumor, and in which direction to apply it. Because it's not necessary that the tumor will mobilize only in the direction in which you're pulling. Sometimes there's a vectorial force and the tumor will move in a different direction from which you're pulling. So over some experience, you get to know which way to pull on the tumor.
I think you have beautifully described that in the sinus of Morgagni, the pterygoid fossa.
Yes.
The direction of pull also, I think you have described it.
Yes, yes.
Am I right?
Yes, yes. Yeah, in the classification, I mentioned that. Yes.
Yeah. All this comes out of experience, pure experience. You do more and more cases and then you study the cases, you know exactly how you do the traction, from which direction you do the traction, all that.
Right.
So these are all. So now I have got the tumor out of the sphenoid sinus into the nasopharynx. Can you see the sphenoid, the cella here completely?
Yes, cella is seen. The part of the paraclaval, little bit of the paraclaval carotid is seen.
Yeah. Now what I will try to do now is, again, that's the dura here. I've just protected the dura. Now what I'm going to do now is to try to push this JNA down. The areas I have not removed are from the pterygoid fossa. Suction, pack, please.
Pack, long pack.
Long pack, please. So, did you see that almost the whole, not the whole, most of it has come down?
Yes.
Give me a pack. Now, see, whenever you displace a JNA from a particular area, this is something which I think all surgeons should know in JNA surgery. Whenever you displace it from a particular area, keep a gauze piece. So, the JNA, what happens, it tends to go back to that area. Because, give me a black sleeve. Now, tends to go back. So what you do is you just fill that area with I just want to see. No, very quickly. Now I'm just trying to search for the V2. Wait, suction. Now is the area, because one thing I want to tell you is that if the inferior orbital fissure is not involved by the tumor, it's very unlikely that you will damage the V2. This is something which I want to inform most of my JNA newcomers. So if you have inferior orbital fissure involvement, then your V2 can get damaged. Go closer. See here, I'm just opening the Blackesley and doing that. I'm not trying to hold anything and pull it. Okay, cob later. Cobblator,
you-
cobblator.
See how beautifully he is retracting and dissecting the tumor, and in which direction it's being done. So very well seen, very well seen.
That's a vessel. See the vessel. Can you see that?
Yes,
Sphenoparallel.
see.
Now, let me give a irrigation, man. Give a irrigation now. Now the thing is, the tumor is out, but the tongue depressor, tongue depressor. Okay, here we are. Suction. Yeah, Shilpi. So as Madam says, JNA is a teamwork. It's a teamwork. It's not a one-man show. I think a person who thinks it's a one-man show is mistaken. You need a good team. You need a good assistant. You need a good, staff nurse. And in case there's an emergency, there should be somebody who can actually, the anesthetist. The whole thing is actually a teamwork. So this Lux has been designed by me. It's a modification of the original Lux forceps. So this is, see that tumor, see that. Oh,
Yeah.
my-
Yes, beautifully seen, beautifully seen. Very nice.
it's actually a big tumor, very big
Yeah,
tumor.
yeah.
Okay, oh, sorry. It's like a cricket ball. Okay, right. Now, see, I always say my surgery starts now. This is what I always say. Whenever I see the diaphragma descending, I say the surgery starts then in pituitary. The same in JNA. Once you remove, give me a Blexley now. Once you remove the bigger part of the JNA, your surgery starts then, because the main problem doesn't come because of the big component of the tumor. It comes because of the small components of the tumor. So this is something which I think all the residents should understand and follow. So what is the what are the small components of the tumor? This is what, see, that's the dura here. Can you see the dura, all
Yes.
of you here?
Yeah, very well
Okay,
seen.
now go inside. See how much of, see that erosion of the carotid. Can you see here?
Yes,
The
you
bone
can
of the
see
carotid is
erosion,
eroded.
yes.
That's the sella here. This is the clivus here.
You can
Now
see.
we will go on to see the anatomy. Oh, the
Yeah, you can see the carotid there, yes.
carotid is naked. Oh my
Yes,
God.
yes, you can see
Uyyo.
how it's pulsating. Yeah,
My
beautifully seen. Great job, great job.
Give me a surgical. You have a Doppler?
I think there's also a, just look at the clivus also. I feel that there is some.
Yeah, there was a
Section is
little
there.
erosion, but that came out in the.
Yeah, no,
See,
no,
that
I'm
is the
thinking that there's a
buccopharyngeal
vessel
fascia.
there also in the clivus. Could it be the basilar? Just check below the pituitary sella.
This one, this one.
In the
This is the
clivus,
carotid.
in the clivus, below the pituitary.
1 second. First, let me show for the sake
Yes.
of juniors.
Yeah.
Just for the sake of juniors, just see, this is the optic here. So
Yes,
this is the dura.
beautifully seen. Yes, beautifully seen.
So you're getting a arterial sound. That's the anterior circulation. This is the anterior circulation. The A2. It's the A2.
We
Now
can't hear
this
the
is the
sound.
carotid. This is the carotid.
We can't hear the sound.
You can't hear the sound?
No.
Get closer. Come closer.
Maybe they can put a mic.
Mike, I know. I'm seeing that. Can you bring that closer to me? Can you hear?
We'll take your word for it.
Can you hear? You can't hear, ma'am?
No, we can't hear. I know exactly what you're saying, but and how it sounds, but I don't think it's heard over here.
Now?
No, I think it's something to do with the mic that we need.
Can you hear me?
I can hear you.
Then, I don't know.
Mic is this side.
Oh, this side. Okay, okay. Now, keep it this side. Doppler. This side. Keep it, bro. You hold it. 1 second. Show you. Now, I'm going to show you. I'm going to show the circulation. See here. That's the carotid artery. This is the clinoidal carotid. Wait. Here. Okay, here we are.
Yes.
Can you hear? Can you hear, ma'am?
No, Dr. Jankiram, we can't hear.
That's the anterior circulation.
Okay.
That's again the carotid.
Yeah, it's beautifully demonstrated. I just wish we could hear it, the Doppler. We can't hear the Doppler.
It's okay. No problem. Now, I'm going to show you a very important part of the tumor now. That's the carotid. That's the carotid. Now, what is this? Now, I'm going to remove all this with the coblation. I'm going to remove all this. I'm going to show you what.
Not with the Doppler.
Give me the. So I'm going to remove that and show you the anatomy of the coronal plane. I want to tell the juniors something. Whenever the carotid is exposed. Hello, can you hear me, ma'am?
Yes,
Hello?
we can hear you.
Whenever the carotid is exposed, try not to use the debrider, number one, and try to use the cobblator in an inferior direction. Don't use it in a like this. If it slips, it will hit the carotid.
Yes.
This is the buccopharyngeal fascia. The pharyngobasilar, the buccopharyngeal fascia, all that in the nasopharynx. So I'm just removing that. Okay, that's it. Having done that now, what I'm going to do now is to show you the anatomy post-surgery. Now you can see here. Now, what have we done here? I have not shown you some important anatomy now. Number one is the nasolacrimal duct. I have not shown you the nasolacrimal duct. I'm going to show you the nasolacrimal duct now. Give me a pack now. That's carotid. Yeah. So I will trace all the anatomy because anyways, we have to get the nasolacrimal duct very clear of disease and also coblation or whatever. So I have to revise my excision of the nasolacrimal duct. Give me a pack. So what are the things you'll have to see? That's over the carotid artery. So I'm just safeguarding my carotids. No, give me one more surgery, sir. See, that's another carotid here. That is the basilar artery. Can you see the basilar artery here?
Yes.
That's the basilar artery.
Below the pituitary cell. Yeah, it's very well seen. Yeah.
Here.
Yes, very well seen. This is the point that I was discussing earlier. That at the clivus, the erosion of the basilar could also be seen. Very beautifully seen. Very beautifully seen.
Carotid. This is again the carotid. That's the anterior circulation. So all the four are seen now. Now we'll have to.
If you can show them the OCRs also, because on the left hand side the optic nerve is well seen. If you can explain to them about the OCR.
I will do that, madam. I will start with the nasolacrimal duct and I'll demonstrate all the. Give me a pack. All the anatomy after a JNA. What you have to see. When do you say a JNA surgery is complete? So I will try to do that. Of course, I should not do it in front of you. You are a don, but I just want to show you.
No, I am also learning a lot.
Madam, don't be humble, madam. Please, you are very humble. You are the don of JNA. We respect you. Oh, cut. Okay, ready. Now, come on, Shilpi, let's start. Now, this is where I'm going to start with coblation first. Now, the first thing which I think Dr. Anaga, I don't know who asked this question. Where is the nasolacrimal duct? That question was asked to me. Am I right?
Yes.
Who asked that question?
There was a question on DCR from the delegates, and Dr. Anaga did ask about the nasolacrimal duct.
Okay,
Yes.
okay. Now I'm going to show you the nasolacrimal duct. Drill.
Punch.
No, drill.
Punch it.
Why, man?
Two anteriors for the scope.
No, kuch nahi hoga. Now, the first thing I want to show is the DCR, the nasolacrimal duct. Always, whenever you are doing a JNA, see that your nasolacrimal duct is not affected. I have seen in my own cases nasolacrimal duct being stenosed. So I don't want that to happen in any of your cases. Learn from others' mistakes. Ready. Now here we are. I'm going now to drill that area.
1 minute.
Ready? See, that is the middle turbinate. You can see here, that's the middle turbinate. Can you see the middle turbinate here? If that is the middle turbinate, this will be the nasolacrimal duct.
Yes.
So the middle turbinate is a very good landmark for the
NLD, yes.
That's the drill.
So the first landmark which I want to show you. No. Shilpi, no. Why are you showing this way? Okay, right. Give me irrigation. Now that is the first landmark which I want to show you. Give me. See here, what has happened here. Can you see that? There's a little, give me a ball probe. There's a little coblation which has hit on the, see here. This is the maxilla.
Yeah, that's seen now.
Okay, now I'm going to remove this bone, and once I remove that bone, you will expose the nasolacrimal duct. See, that means we have gone inferiorly. We have not gone superiorly towards the nasolacrimal duct. Okay, I'm going to show you that. So these are the checklists. Whenever you finish your JNA, okay. Now I have uncapped the nasolacrimal duct suction. Now you see here, that is the nasolacrimal duct. Sunny kudra. Okay. Okay, now suction.
Drill will fall down.
Press the area of the nasolacrimal duct, my dear friend. This is the maxillary sinus. Yeah. Can you see the nasolacrimal duct, all of you?
Yes,
Now
we could
give
see
me
the movement. If you can hold the camera steady, yes, it's seen well.
Give me a, no,
Movement is
scissors,
seen.
please. Now see that, this one, the projection. I'm going to cut it. Hey, Nanda, Thalida, Silpi. Okay, now I'm going to press the region of the nasolacrimal duct. Can you see?
Yes, we can see.
Tears coming out, all of you?
Yes,
This is tears of joy.
I agree.
Sorry, that was on the lighter note. Now, should I retain this mucosa? Yes, I can, because I don't want to create too much of raw surface. Let me retain it. Now, let me go here, inspect the infratemporal fossa. So this inspection is very, very, very important because you don't want any residual tumor here. Now, what is it that you will inspect? Now you see here, this is the level of the V2. Can you see here? This bulge. This is the optic here. Can you see the optic here?
Yes,
Optic
well
nerve.
seen.
This
Well
is the
seen.
optic, this is the superior orbital fissure, this is the V2. So the V2 should come here somewhere. Now I'm going to uncap for the V2. Elevator. Hold this and then she will do that, please. Yeah. Give. Yeah.
Out होता है ना, दोनों elevator देते हैं, वो अपने आप push करते हैं.
See here. Now this is the V2 here. This is the V2 here. Come out. Now I'm going to, this is the mucosa from the floor roof of the maxillary sinus, right? Yes or
Yes.
no?
Yes, yes.
Now you see, I told you, if you don't have an involvement of the inferior orbital fissure, then you will not have, see the V2 there. Can you see the V2 here
Yes, the
going there?
V2 is seen. Yes, it's seen very
Clearly
well.
seen?
Clearly
So
seen.
if you don't have an involvement of the inferior orbital fissure, then it's very unlikely that you will damage the V2.
Yes, and also one more point for everyone that V2 is a very important landmark because just above that is the superior orbital fissure. And so if you dissect, of course, if it's going into the orbit, you will dissect above the V2. But if it is not going into the orbit, then you stay below the V2 because otherwise you can go into the superior orbital fissure and damage the muscles. When the tumor goes into the orbit, it pushes the muscles. So you will see the tumor first and then the muscles. Whereas if there's no tumor in the orbit, the muscle will be directly there.
Now, the next landmark which you should always see is the median nerve. Unless you see the median nerve, you have not completed the JNA. This is very blekkasly kudungadenda. Now you see, I'm removing this. You can see here that this is the carotid artery. See here, this is the carotid artery here. Can you see the carotid? Go closer, go closer. Can you see the carotid artery here?
Yes, seen.
See the nerve here. See the nerve here. I'm holding this nerve. Can you see the nerve here?
Yeah.
This is the median nerve. That's a paraclavial carotid, and this is the median nerve. Can you see here nerve here, please? That is the median nerve. You can see that very clearly. I've actually gone far distal. This is the nasopharynx. This is the median nerve. What, my dear friend?
Very far from the patient.
Then come closer. Sorry, my dear friend. Can you all see the median now? All of you see that? See that? It is in my suction now.
Okay, where's the pterygoid base, Dr.
This is the, see that this is the pterygoid base. See here, this is the pterygoid base. We have,
right. Yeah.
Okay, it's all eroded. Now I'm going to inspect the pterygoid fossa. Now I'm going to inspect the pterygoid fossa. Now, how do I inspect it? Now give me the coblation. See the medial pterygoid plate. Can you see the medial pterygoid plate here?
Yes, seen. You can see the lateral one also.
See the lateral, the medial, this is the pterygoid fossa. Do you agree, madam?
Yes, absolutely. And you can see
what is this muscle?
it.
What is this muscle? This muscle is the tensor lever palatine muscle.
Tensor palatine, yes.
Now, I'm just going to put some coblation there just to see if I have left behind any kind of tumor. Yeah, on blue, not yellow. So here you can have bleeding from the veins, venous bleeding you can have. See that's can you all see the muscle? All of you?
Yes.
So when actually I was pulling that tumor, it has come out of the pterygoid fossa here. That is what the madam has described. How to pull. When you see the median now is beautifully seen here, going towards the carotid artery. Shilpi says, don't touch, don't touch. Now, anybody, can you give a prize to the audience if they say what this is? If they say this structure which is here, I'll straight away give a big prize. Not only PGs should answer.
Okay, only PGs.
This structure here. This structure here. You can see that's the carotid artery. I'm giving you a clue. That is the lateral carotid. And you're seeing a structure here. What is that? Okay, I don't think there's an answer. Maybe there are no PGs. That's the reason. So this is the fibrocartilaginous ring from the eustachian tube.
Yes, that's the
fans-
torus. The torus.
Yes, which fans over the carotid here. So it protects the lateral carotid. So that's the answer to that. So I think I've inspected every small area, and I'm very confident that I've removed the tumor completely. And let's see what is the blood loss which we have faced. We'll ask the anesthetist.
Dr. Jankiram, two more questions.
Yeah.
One is from a place called Sirisilla. And Dr. Kandakuri is asking this. When do you prefer embolization?
From Sirisilla, they are asking for.
Sirisilla. Sirisilla means? Oh, okay, okay, right. Oh, what is the question?
The question from Dr. Kandukuri is that when do you prefer embolization?
Embolization, madam, we generally don't do embolization at all. The only instance we embolize is maybe when the internal carotid artery branch is involved, and that's where we coil after a BOT. So
Okay.
basically, we have stopped embolizing for ACS system at all, completely.
Okay. And
Now, I'm going to show
this is
the
one more
anatomy.
question.
You asked for the anatomy. I'll
Yes.
just demonstrate anatomy
Yeah,
now.
yeah.
Now you saw the median, you have seen the pterygoid fossa. So this is the planum.
Yes.
The planar dura. This is the planar dura. You can see here, this is the optic nerve. The optic nerve, this is the tuberculum cellae.
Correct.
This is actually the carotid artery going inside. That's the MOCR.
That's the
which has been-
paraclinidal, yeah.
Yes,
Yeah.
that's the clinoidal carotid. And this is actually the sella, the clivus, the paraclival carotid is here. This is actually the carotid. Carotid here and a little widened sella. This is the V2 here. If that's the optic nerve, this is the superior orbital fissure. That's the optic strut, otherwise called the LOCR.
Right.
Lateral opticocarotid recess is here. You can see that this is the lateral opticocarotid recess. This is the carotid here. Superior orbital fissure, maxillary strut. This is the V2, lateral recess, median nerve. I showed you that. This is the median
Yes.
nerve. So I think this is the anatomy, complete anatomy of the whole sphenoid sinus. So I think with this, we have
Wonderfully
completed
done, wonderfully seen, Dr. Jankiram.
all
Very
your
well
blessings,
seen.
madam.
Very well demonstrated. One more question, which I can
Yeah.
answer for you, and that is they want to know what JNA classification you follow. Dr. Jankiram has published his own classification, which is very ideal because it also demonstrates through the classification how
Hey,
to
Banu.
what steps of surgery. So he uses his own classification, and I also use my own classification, which is the angiofibrotic grid. But there are a lot of classifications. Dr. Jankiram, would you like to say something about your classification?
Yeah, I think if you have can you change to external camera, because this is a very hot topic which has been debated, I think, in so many forums across the globe. I have been facing this. Basically, why do you need a classification? This is something which I want to tell you. When you have, first of all, how do you make a classification? You can make a classification only if you have bulk of cases. You can't do it with 5 surgeries you do. You cannot make a classification. Only people having at least 100, 150 cases can make a classification. So if you look at many classifications which have been proposed, they have done it with 40 cases, 30 cases, 50 cases, like that. Many tumors. If you look at it, first of all, I see the number, n number. So number one, this is what I want to tell you. If you have numbers, then you can classify, or else you cannot classify. Number two, if you have tumors extending from small, very small till large, then only you will know how this tumor is spreading, growth of tumor, areas involved, all this you will know. So you should have the spectrum also, the complete spectrum. Number two. Number three, what is the use of a classification? Use of classification is to simplify your surgery. That's all. See, for example, if you're having glomus tumor C1 or C2, it is going to tell how complicated the surgery is going to be, how we are going to prognosticate the result. It is as simple as that. Any classification for inverted papilloma cross classification A, B, C, D means you know it is intracranial, extracranial. Okay. Now, that is the use of a classification. Number one, to operate. Number two is to prognosticate. Well, in India, please understand that Indians, whoever is watching around the world, I want to tell you that in India, we have the maximum number of JNAs. So, every center has got a particular technique with which they operate. It is not that it is wrong. Basically, you have to take a post-op MRI and show you, or a CT show that it is completely cleared of disease. Ultimately, patient wants clearance of disease. So, if that particular center wants to use a particular nomenclature to talk in a similar language, then they want to form a classification. That is how I formed a classification. Dr. Bradu formed a classification. Dr. Bradu, madam, formed a classification because number one is the number of cases which she sees. Number two is the spectrum of cases she sees. And she wanted a common language for the classification. I always say, I don't care whether you follow the classification or not, boss. In Germany, whether you follow Andrew, whatever you do, you show me the final result. You show me the video. Now, ultimately, you should have a post-operatively free CT scan. This is what ultimately classifications are, just to help you to make your surgery simpler and to prognosticate the disease. It is as simple as that. There is no politics in a classification. I think Dr. Bradu madam's classification is fantastic because of the insight it gives. In fact, I have learned a lot that inferior orbital fissure, widening, then till touching, so many things. Moving your forceps when the pterygoid fossa is involved from above, from sideways. See, unless you are enjoying that surgery and getting orgasms during the surgery, you cannot understand the classification. Believe me. So, if people say the bakwas hai, this is not good, that's not, because they have not understood the surgery. This is what I feel. And we are not bothered whether X, Y, or Z are following it. We are not bothered. We have published it. Publication means they have accepted what we have told. Number one. Number two is we want to give good results for this patient. That is why we are using the classification. It is as simple as that. There is nothing like you follow only, sorry to tell you, it is not Indianizing or, be Indian by nothing like that. Whatever is good, whether it is, basically, let me tell you one thing. Most of the classifications are in the pre-endoscopic era. Radkowski's classification, you take your fish classification. I am asking you one simple question. How can you, with an endoscope, follow a person who has not done it during the pre-endoscopic era? This is utter nonsense to me. Now it has changed. So we need new classifications. That is why we have brought in new classification with respect to endoscopic dealing, or, for example, you have a push-pull or a four-port technique. You have new classifications only then. So please understand. So if PJ Ormal says that the frontal cells, I give a new classification, and if you say, no, it's not good, you have to follow Frederick Kuhn, that is wrong, because he wants to deal it with a particular area in a particular way. So he has formed that classification. That's it. It's up to you whether you want to follow it or not. But the ultimate thing is you have to open the frontal recess. That's it. That is the aim. And it should not stenoze later. Am I right, madam?
Absolutely. I agree completely with you. And I would also like to say this, that Indianization is a good thing, because Indianization is in specifics where the Indian experience is much, much larger than I would say even the international exposure. So,
madam, I'm asking you a small question. If a person staying in one country who sees only one JNA per year, or maybe one, how can I classify rhinoscleroma? I am asking you one question. In our country, rhinoscleroma is very rare. I am confident that a person who sees a lot of rhinoscleromas can classify it better. Rhinosporidiosis, the state which sees the maximum, can classify it better. It is that way. Ubiquitous tumor, yes, you can AFRS. Okay, you follow whatever classification you want. But JNA is a specific disease where the maximum seen only in India. So it is but natural that we will form classifications and the world should follow it, because we are seeing the maximum. It's as simple as that.
Yes, I agree with you. In fact, one thing that we are changing now is that there was a time when we would do hundreds of cases and they would not be documented. And then we would be following textbooks of people who had done 10 cases because they were publishing and they were writing. Now in India, a lot of people are writing, publishing, and there's a lot of original thought coming. And so I think time in India has come. I believe.
Madam, I'm asking you another question. If you talk about post-COVID mucormycosis, and I see a classification from any part of the world, America or Europe or whatever, you think I'll believe it? Maybe I'll see it. I'll add a pinch of salt and just neglect it. And your chapter on orbit, which you have written for our mucormycosis book, that is an authentic chapter. What I mean to say is, this comes out of pure experience, documentation, analysis. So it's up to the world to follow it or not. It's not our botheration. We are leaving behind legacies, and maybe at one time, maybe after a decade, they will recognize it. Oh, okay, this is better. This is better. Maybe sometime they'll recognize it.
You made your point very, 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 very clearly. Dr. Jankiram, excellent surgery, very beautifully demonstrated, especially all the anatomy at the end. And one more point I'd like to say is that if it's done completely and if it's done correctly, at the end of the surgery, there will be no bleeding and you will be able to document each anatomical part separately. If that is what you're able to do at the end of the surgery, then it is almost 99% that you have got the whole tumor out. So should we go along with the, should we go along with the next case?
Yeah. What is the time now?
It is 5:45.
Madam, what we are going to do is we are just going to continue. You just ask the audience whether they want to have, or maybe they can go home and have a look. You can close it from the auditorium point of view.
No,
it is up to Alchem.
We'll carry on for some time. Definitely, you can definitely show the second case, and then we'll take a call on the third case.
Madam, actually, this one is only a single theater in this hospital.
Okay.
So we'll have to extubate this case and then put the next case. It will take at least half an hour for us to bring that next case.
Okay, so what we can do is, in the meanwhile, we can address any questions which are there from the audience.
You can actually go on to the dais and maybe do some answering questions and things like that. We can do that.
Okay.
Huh? No. You can open the forum for question answers.
So I will, for a short while, we will close the theater for a short while, and then I'll open it up again. Okay?
Sure, ma'am. Thank you very much, ma'am.
Thank you. We're looking forward to the next case.
Thank you, ma'am.
All the audience is here. Don't worry. Everyone is here. No one's going home.
Madam, I talk even to one person, madam. I don't I don't see the crowd.
Yeah. So we have that in common. Talking to one person. Yeah. Okay. Okay, we'll have a tea break, and then there's some snacks and tea which is organized.
Recording
so
stopped.
Tea break, or do you have actually
Recording
we'll give 5
in progress.
Minutes. Is there any, because it is going to be at least 15-20 minutes minimum before we have the next case. So are there any questions anyone has about this surgery or about the coming surgeries, the extensive nasal polyposis or the CSF leak? Any questions? Anyone? Okay. So then we'll have a tea break. Yeah. Please break for tea, and then you can come back. Okay, there are some questions. Are the other centers still active? Okay, so I'll just go over some of the questions which came up about the panel discussion.
Stopped.
And I'll ask Dr. Anagha and Dr. Kshitij also to answer any questions. So
Recording in progress.
one of the questions is in the panel is post-operative protocol to prevent recurrence in nasal polyposis. Dr. Shankar from Bangalore wants to know. The question is post-operative protocol to prevent recurrence in polyposis. Dr. Kshitij, would you like to take that question?
Sure. So thank you for the question. The protocol that we would follow, so again, it would just mention a couple of points that are important intraoperatively. And, when you finish surgery for a polyposis, and we very often compare this to how a church or a chapel looks like, you need to make sure that you have the lamina papyracea and the skull base in the middle turbinate nicely skeletonized, and if possible, leave it mucosalized. The allergic mucin has to be cleared completely. So the aim of surgery for polyposis is to ensure that you clear the polyposis, open up the sinus cavities, clear all the allergic mucin, including flushing it, and if there's fungal debris, clear that too. That in itself will reduce the chance of a post-op polypoidal reaction or recurrence. Secondly, you would have to follow a stringent follow-up protocol in terms of even endoscopic clearance. I would typically start topical steroid spray after the 5th post-op day, when initially the crust and the blood clots have cleared up. How long to give topical steroids would again depend upon the allergic tendency the patient has. So giving anti-allergics as antihistamines if required with Montelukast and topical steroids is something which is going to help you reduce recurrences, provided the cavity has been well skeletonized or osterized, so as to speak. Typically would follow up the patients regularly for 3 to 6 months, and then tell the patient to come at least once in 3 months, so that even in the OPD with a headlight you can actually look into the cavity quite clear. Tell the patient don't wait till the nose gets completely blocked, because by then the polyps have grown aggressively, and the initial symptoms to look out for me are a post-nasal discharge, because when the patient starts having a little cold and a PN drip, that's when is the right time to even give a short course of oral steroids if required. That would be my protocol.
Right, thank you so much. The other thing is that in a CSF leak with diffuse bleeding intraoperatively, how to identify the leak and management of scenario. So I'll take this question. So actually, if there's diffuse bleeding, it is actually easier to identify the leak, because you get a, hello Amita, you get a nice washout sign. So when the blood is, there's a diffuse ooze, you'll see that the CSF is washing out the area, and therefore from that it's very easy, comparatively easy to identify the CSF leak. However, if there's too much bleeding, then you have to do, one thing is you have to pack patties or gauze piece or whatever you are preferring, and keep it there for at least 10 minutes, I would say, so that all the bleeding stops. You can even use pure adrenaline patties, 1 or 2 over there, and wait for the diffuse bleeding to stop, and then look for the CSF leak. And another way, there are a whole lot of ways in which you can try and, entice the CSF leak, and that incite the CSF leak. So you can, you can do a Valsalva, you can give a head low, and of course, if you put a lumbar drain because you're expecting a large leak, then you have to keep the lumbar drain closed. It is only after you identified the leak, taken the fat, fascia, so you can still see the leak at the end of it all, then you open the drain while closing the defect. Another important point to remember is what happens is you find the leak, and then you go to take the fascia and fat, and by the time you come back, that leak has stopped because of a lot of CSF flowing out, and then finding that leak is difficult. So before you go to take the fat and fascia, find some bony landmark around it, so you know this is exactly where the leak was. So this is one way of making sure that you get to the right site. And like management of scenario is that when you're repairing the leak, if there's bleeding, try and stop it first before repairing. And if it is there, then make sure that you use targeted suction so that you don't suck on the repair as you're going in and out. So you take the suction to the particular place where you want to suck off the blood and then open the suction so that you don't disturb the repair as you're going in and out. Some amount of diffuse bleeding is good because that means you've created a lot of raw area, and therefore adhesions will take place well and the defect will close properly. Now I have a question for Dr. Anagha. What is the best approach to sphenoid sinus? This is Dr. Imtiaz from Kargil.
If you're not getting, so the standard approach is how you would go from the anterior ethmoids to the posterior ethmoids and then go into the sphenoid. But if it is difficult to approach the sphenoid through the lateral approach, the best approach to identify the sphenoid correctly would be the medial approach. So that, as Dr. Kirtane sir mentioned, to look for the sphenoid ostium and then identify the sphenoid from there. But sometimes it is very difficult to get the medial approach because the middle turbinate may be bulky. It's okay. The middle, okay. So the middle turbinate would be bulky, and it may be difficult to approach the sphenoid sinus medially. So then in that case, the intermediate approach would be a very convenient approach where you would go from the between the middle turbinate and the superior turbinate, you go into the sphenoethmoidal recess and then approach the sphenoid ostium from that region. So that would be the most ideal approach, I would say, because it will prevent, it will give you a straight head-on to the sphenoid sinus as well as give a wider approach to that area.
Thank you. Just to tell you which the next surgery is. So the next surgery is a standard surgery which all of you do in your own clinics and in hospitals, no matter whether it's a small center or a large center, and that is extensive nasal polyposis. So Dr. Jankiram will be showing you steps of how to remove the polyps with minimum chance of complication. So that is the next surgery. In fact, I had requested him to take this surgery first, but he said that the angiofibroma had some medical issues and therefore they wanted to take that first. So now we'll have extensive nasal polyposis, and if time permits, then we will be showing a repair of a CSF leak. So that is the way it is planned. So the next surgery is nasal polyposis. So there's a
the roof
question,
of the
tips
ethmoid
and
sinus
tricks to identify
is higher
cells
than the
along
level of the
skull
cribriform
base
plate.
and remove all
And
cells.
it actually
This is
goes
Dr.
higher
Rohan
than
from
the
Mumbai.
axilla.
So the tips and tricks are first to remember that the ethmoid fovea or the roof of the ethmoid sinus is higher than the level of the cribriform plate. And it actually goes higher than the axilla of the middle turbinate. So your skull base is little higher. Second thing is most of the skull base is formed by the frontal bone, and therefore is very, very thick and unlikely to be damaged along the superior lateral aspect of the skull base. It's medially where the middle turbinate is attached that you get the lateral lamella of the cribriform plate, and that may be thin, and therefore you can get a leak from there. I just want to know, are the other centers also listening in? Audiovisual? Hello, audiovisual. Are the other centers also listening to this question answer session? Right, thank you. So the first thing is that direct your instruments along the skull base superior laterally. Second thing is, a good thing is to first find the sphenoid sinus before clearing the skull base completely, because the roof of the sphenoid sinus is the lowest part of the skull base. And then using that as a landmark, you can gradually go anteriorly and go higher as the skull base goes higher. Third thing is you must sound. See, there will be many septae along the skull base. So you must sound each septa so that you know how deep that septa is before removing it. And you can use a through cut. Dr. Kirtane, I think, uses a curette. So you can use various, or you can use a debrider. But remember that always sound it so that you know how deep that septa is before you remove it. So direct instruments posterolaterally, find the roof of the sphenoid sinus, sound the septae so that you can remove them one by one. And the skull base, with experience, you'll realize that the skull base looks a little different. It is a little more whitish compared to the rest of the mucosa, which looks slightly pinkish. And look at the CT scans very well, so you know whether there's an onode. So it's not that you open into an onode and think you're in the sphenoid sinus. So these landmarks have to be kept in mind. Is there anything else you would like to add, Dr. Anaga or Dr. Kshitij?
I do use a curved maxillary suction. Again, it's ball tipped, so that's safer, and that can be used to sound as well as curette at the same go. I think the most important point you said is first open the sphenoid or the posterior most cell that you want, because that's the lowest area of the skull base, and then come anteriorly. Very often when people try to find the skull base anteriorly first is when they start getting flustered and they're not sure how high to go. So if you go behind, you'll find it and then come anteriorly. That really works.
Also, I think that ideally you should open the frontal sinus by the intact bulla technique, which I can mention now since we have time. See, the posterior wall of the frontal recess is the anterior wall of the bulla. And we know that the frontal sinus will always open in the frontal recess. So any cell opening behind the the anterior wall of the bulla cannot be the frontal sinus. So you can use the anterior wall of the bulla as a landmark which you can extrapolate. So anything which opens anterior to the anterior wall of the bulla is either a frontal sinus or a frontal cell. So that's why, so that you don't get lost along the base skull, that is why an intact bulla technique. And it's not actually because that's the main reason. The secondary reason is to protect the anti-ethmoidal artery, because if the bulla doesn't go to the skull base and there's a suprabullar recess, you are not protecting the anti-ethmoidal artery. So mainly so that you don't mistake the frontal sinus for a suprabullar recess or a supraorbital cell, you must maintain the bulla intact. And so another important thing is for the skull base, especially for the anti-ethmoidal artery, because most people are worried about damaging the anti-ethmoidal artery. So when you find the frontal sinus and you open the frontal sinus, only then should you start clearing all the skull base. You know, do the rest of the surgery, because what happens is endoscopically there will be the frontal sinus opening, then there'll be a little space behind it, and then will be the anti-ethmoidal artery. And the anti-ethmoidal artery also is at a junction where the vertical skull base, which is the posterior wall of the frontal sinus, becomes horizontal for the cribriform plate. So that landmark will be there, and then you can protect the anti-ethmoidal artery while you're doing that. So these are the various ways in which you can clear the skull base without any major complications. Yes, so Dr. Anaga Joshi reminded me that the position of the head is very important. So when you're operating on anterior posterior ethmoid sphenoid, the skull base your instruments should go parallel to the skull base and not against, up to the skull base. And that is done by keeping the head semi-flexed, which means that the orbitomeatal line, that means between the lateral canthus and the external auditory meatus top, the roof, that line, it's called Reed's baseline, should be perpendicular to the plane of the operating table. When you are doing the frontal sinus surgery specifically, that is the time when you will extend the head, and so that it's easier to see the frontal recess, and you can use the 0-degree endoscope and instruments for a little longer. But after you've found the frontal sinus and you've dissected in the frontal recess, then you flex the head again while you go on for the anterior and posterior ethmoids and all. So it has to be along the base skull, parallel to it, not against the base skull. Okay, so someone has asked how to hold the endoscope and distance to maintain from working area. That will take up while the surgery is going on because it is easier to demonstrate at that point. Yes, and so we've managed to cover all the questions that have been asked so far except that one question. If there are any more questions, please keep them coming. We'd be happy to answer them. Now, another point is about tomorrow's program. So tomorrow's program is completely online. The link has been shared with everyone. Anyone who doesn't have the link can get in touch with, you can get in touch with me directly, or you can get in touch with the Alchem people who are there in your local area, and you can get the program. So the program begins tomorrow at 10:30. And 10:30 to 11:30, I will be taking a lecture on osteology of the paranasal sinuses and skull base. And after that, at 11:30, Professor Reda Kamel, who has been the head of department of ENT in the University of Cairo, and is an excellent teacher. Beautifully, he explains things very simply. He will be doing a review of the entire anatomy which is involved in FES surgery, as well as the anatomy which is involved in extended advanced skull base surgery. So I think he may have, either he will have cadaver dissection, or he may have a mixture of cadaver dissection and surgeries where the anatomy is seen very well. So he'll begin with taking only the FES anatomy, and then he'll continue with the advanced skull base anatomy. And I don't think that you should miss it. He has written a beautiful book for Karl Storz, if you can get your hands on it, very simply explaining the concepts. So that is the program for tomorrow, starting at 10:30. I'll just recheck. Yeah, so tomorrow we are starting at 10:30. And from 11:30 onwards till maybe 1:30, we will have the session by Professor Reda Kamel. Yes. So please log in tomorrow as well for the online session. So when they're ready, they'll let us know. So there's a question, tricks to protect dehiscent carotid and optic nerve in extensive polyps. So the first thing is read the CT scan well. You must have bony cuts, both coronal and axial. Because, for example, this JNA case, the dehiscence of the carotid would be made out much better in axials rather than coronals. So definitely axial bony cuts and coronal bony cuts and sagittal are the ideal three views that you need in bony cuts to make sure you understand where the optic nerve, where the carotid is. The second thing is that polyps will never erode the dura. So all these structures are protected by dura. So it's not like the optic nerve will lie bare in the without any dural covering. Of course, I have one of the most extensive polyps I've seen is where both optic nerves and the chiasma and the optic tracts were seen within the sphenoid cavity. So I have seen one case like that. Very often the optic nerve will be dehiscent, but this was, even the optic tracts were seen within that expanded sphenoid cavity. So no powered instruments inside the sphenoid sinus if there is dehiscence. Ideally, no powered instruments at all inside the sphenoid, but definitely if there are dehiscences, definitely not there. Also important that if you see an isolated polyp in the region of where the carotid is, be very certain to do an MRI, because you can have a carotid aneurysm over there and think that in CT scan it will look like a polyp, unless it's a contrast enhanced CT scan. So in the plain CT scans that we do for polyps, carotid aneurysms, rare cases, will actually look like polyps in the sphenoid sinus. So that you have to be careful about. If you decongest properly, you will be able to see the anatomy of the sphenoid clearly. So you need to put patties inside the sphenoethmoidal recess, and once when you open the sphenoid, first put patties in the sphenoid sinus so that the polyps shrink, and then you can see the anatomy of the sphenoid sinus well, in which case there's no problem with the optic nerve or carotid. Anything else you'd like to add, Dr. Anagatsushi? Yeah, so the thing about if there's an onodi cell, that's actually where the optic nerve is most at risk, because the advancing instruments will actually come directly the optic nerve will come in the direct path of your instruments. In the sphenoid sinus, it will be tangential to your instruments, but in the onodi cell, it will be against you. It means your forceps can actually go and touch the optic nerve. So onodi cells have to be made very clearly seen, and I've not often, but I've seen quite a few onodi cells where the carotid is also in the onodi. So it's not just the optic nerve, but even the carotid siphon is sometimes in the onodi cell. Yes, the reason why these things happen, dehiscent optic nerves and carotids in polyposis, is especially in AFRS. And there's a lot of debris. So in that case, if you're going where there are very critical areas, it's better, instead of trying to pull out the debris, to wash it out. So if you wash it out, it is safer, and you'll be able to get a better safety margin. Okay. So that covers that. In the case of extensive polyposis, role of IV steroids. I don't use IV steroids for extensive nasal polyposis. I would use oral steroids. If I'm using prednisolone, then 1 milligram per kilogram body weight is the dose I will start with, and I'll usually taper over 10 days. And I give steroids, IV steroids, oral steroids 1 week after an extensive FES for about week 10 days. And then very rarely, if there's a lot of recurrence and the patient doesn't follow up and comes again with a lot of polyps, then at that time. But I don't use IV steroids. Dr. Joshi, would you like to have anything?
I follow the same thing. I do not use IV steroids, but start the patient on oral steroids 1 week prior to the surgery. Of course, taking care that the patient is not overtly hypertensive and diabetic. And so that this will cause the polyps to regress, and it will be easier to handle the polyps during surgery, and there will be lesser bleeding intraoperatively. Yes, there is the danger that the patient may feel asymptomatic and may not revert back to you.
Yeah, so IV steroids have a role in vision loss, definitely. Sphenoid mucoseals, anything, traumatic optic nerve injury. We've seen a few JNAs with vision loss. So definitely where there is vision loss, I have had one young JNA where he had bilateral, presented with bilateral vision decreased bilateral vision. We've had some JNAs present with diabetes insipidus, so meningitis, but these are rare experiences. But yes, anything to do with vision, high dose steroids, IV for at least 3 to 5 days. And by high dose, I mean 1 gram of methyl prednisolone per day. So there's a question about use of flutamide in pre-surgical preparation of angiofibroma to reduce vascularity. I don't use it, and we'll ask Dr. Jankiram whether he uses it, but I don't use it. Unlike Dr. Jankiram, I think when you begin angiofibroma surgery, it's better to embolize the tumor. Once you know how to control bleeding. So, Dr. Jankiram showed an excellent surgery, but you can see that at all times he had control of the bleeding. with packs or whatever, but that requires a certain degree of skill before you can manage it. So in the interest of not having to stop the surgery because you can't control the bleeding, or more importantly, in the interest that you can get around every bit of the tumor under vision, I would suggest, at least in the initial part of your learning curve with angiofibromas, embolize the tumors. I know that there is, I work both in the public health system as well as in the private corporate health system. And I know that, embolization costs money. And actually in the initial years, probably the radiologist is making more money than you are as a surgeon. But, it will build your confidence. It will make you then more and more confident about continuing the surgeries. And then, of course, you'll get a name and then you can charge more than the radiologist. Okay. Of course, one disadvantage of angiofibroma on a lighter note is usually they come from lower socioeconomic strata. So I always say that if it was disease of the rich, then I would be driving a Mercedes. But that is not the case with angiofibromas. And so I don't have a Mercedes. Okay. I think we've covered all the points in this. About the showing the instruments and the endoscope, I'll ask Dr. Jankiram to demonstrate while the surgery is going on. Okay, so we take a break before we start. Any more questions? Okay, there are more questions. Let's take those. Okay, so there's a question by Dr. Cherry Anikumar Roy from Pune. Signs of recurrence in JNA. So this is one point where, again, I may have some difference of opinion. And that is that when JNAs recur, see, a JNA is not like a malignancy. It doesn't recur from the mucosa. So having, very often we say that if you have a wide endoscopic access, then you can look for recurrence. That's not true, because that wide endoscopic access will just show you the mucosa. The healed mucosa over what was the sinus, maxillary sinus, and the pterygoid base and all. Recurrent JNAs occur in the submucosal plane, and they don't necessarily, in fact, it's very large recurrences which will then present in the nasal cavity. Usually the path of least resistance is from the pterygopalatine fossa through the orbit into the brain. And when you have very large tumors which have recurred also, there may be nothing in the nose to show for it. So therefore, monitoring recurrence with endoscopic is not actually monitoring. Monitoring means having to do an contrast enhanced CT scan at least at every monitoring. And if that is negative, then you say that there's no recurrence. So my follow-up protocol is that at the end of the surgery, I write expected prognosis. So if I feel the expected prognosis is good, no recurrence expected, then in that case, I follow the patient up every year. And every year, we will do a contrast enhanced CT scan. So we don't send the patient home to his town, wherever he's come from, until we have a post-operative CT scan contrast to show that the entire tumor is out. So unless that is done and that shows complete clearance, we don't send the patient back to wherever he's come from. And if on post-operative it's clear, then we go and have 1 yearly follow-ups where the patient will follow up for a contrast enhanced CT scan. And yes, you may do an endoscopy also just to see how the nose looks, but primarily for the CT scan. And then at the end of 4 years, so all patients of angiofibroma follow up with us, whether in my private or in Sion Hospital, every year for 4 years before. And sometimes, if I have seen one recurrence after 6 years. Till this 5th year, there was absolutely nothing. But at least for 4 years, they will follow up before we discharge them from care. And usually at the 4th year, we do not only a CT scan, but we do an MRI. So these are the way we follow up. Signs of recurrence is a contrast enhancing tissue in the area that you have operated. And so definitely that is the only sign. And remember, like I said, there may be nothing in the nasal cavity and you may have a large intranasal component, I mean intraorbital or infratemporal or intracranial component. So Dr. Kshitij is saying that, you know, Anna, yes, one very important point is that you must do skull-based drilling in every case. In every case, you need to drill the skull base. And we have seen a significant decrease in recurrence. In fact, in all these years, from in the last 24 years that we have been doing endoscopic JNA, we have seen a total of 7 recurrences. And of these, 6 were in the pre-drilling, skull-based drilling era. And we have seen after we started doing skull-based drilling, although the number of cases was exponentially higher, we've seen only 1 case of recurrence. So the internationally accepted rate of recurrence in JNA is about 20%, and our rate of recurrence is about 5%. This is from data over a number of years. Okay, the questions are coming in thick and fast. I'm going to give this over to Dr. Joshi. Dr. Sunil Kumar Sharma from Ahmedabad. He wants to ask this question.
How many anterior ethmoidal artery bleed lead to orbital hematoma and vision loss in your opinion? So I think there's no statistics for that. Basically, if your artery retracts into the orbit and if you do not act immediately, it will give rise to vision loss. Any orbital compression lasting for more than 90 minutes will cause vision loss, and that is, it will decrease the, it will have impact on the optic nerve. So you have to act immediately. If you feel during surgery, the artery, as we discussed during the panel discussion, if the artery has retracted from your view and it's now bleeding into the orbit, you remove the drapes, look for any signs of orbital hematoma, orbital proptosis. And I think we have there was an excellent discussion during the panel as to what you would do if there's orbital hematoma. So acting immediately is the answer to that. And suppose in case you have missed it during surgery and post-operatively in the ward, you realize that the patient is having orbital hematoma and there was history of the anterior ethmoidal artery bleeding, you have to act immediately, take the patient to the operation theater and decompress the orbit immediately. If it's getting delayed, then yeah, if it's if you get a call from the ward that the patient is having proptosis, you have to guide, or if you're present, fine, you guide your resident that you have to remove the packs immediately so as to decrease the compression on the orbit, give orbital massage, take an call for an emergency ophthalmological evaluation, check for the pupils, and shift the patient to the operation theater. If you think it's your shifting to the operation theater and your surgical intervention is getting delayed, then as we mentioned, you can even do a lateral canthotomy at the bedside of the patient in the ward, if it really comes to that stage. Is there any other question? Does use of monopolar cautery cause vision loss? See, as we mentioned, the anterior ethmoidal artery has to be tackled with a bipolar cautery because it tends to get retracted. If you use a monopolar cautery, and the artery is at the skull base, as Madam mentioned, that the artery lies very in close proximity to the, if the dura is closely adherent to the anterior skull base, and that will cause a CSF leak. But a retraction of the artery into the orbit can cause vision loss if your noctacting immediately and if there is orbital hematoma. In post-op, in extensive polyposis, how long to use intranasal steroids? Yes, if the patient has a tendency, I mean, if you are doing IG levels, say the IG levels are high, there is extensive polyposis, you may instruct the patient that he may have to use intranasal steroid lifelong if the need be. And douches or saline nasal washes. Anything you want to add to that?
Yeah. So intranasal steroids, you can do use a spray, or you can do douching with Budocort respules. Various people use various things. In the post-operative period, I would use 500 ml or one bottle, which comes with the pre-prepared sachets, with about 4 ampules of Budocort in the beginning. 1 week post-op after surgery, and so 1 week post-op we do an endoscopic clearance of all the clots and all, and then for about 3 weeks I would give with Budocort 4 ampules in that one thing, and then you can go on either with the spray or with douches, but with 1 ampule in the commercially available preparation. Of course, if a lot of my patients in Sion Hospital are not able to afford it, then we would do the standard water boiled and cooled to lukewarm in a glass. You put 1 small level teaspoon of salt and 1 pinch of khane ka soda, which is baking soda. So I don't bake much, so I don't know, but I think yes, baking soda, and then you also add that respule and do it like that. About monopolar, very standard thing. If you use the monopolar away from the skull base and away from the orbit, you can't get vision loss. And you can use the monopolar extensively, but the mucosa regenerates. So in a angiopharma surgery, we use the monopolar quite extensively, but there's no question of problem with healing. Even the ciliary beat also comes back. I've got videos to show that as proof. But so there's no problem with using a monopolar away from the orbit and the skull base. Orbit and skull base, you need to absolutely mandatorily use a bipolar. In road traffic accidents with fracture, bone, impingement of the optic nerve, does decompression hamper blood supply? No, I think decompression will actually help with the blood supply, because what happens is when you take out the bone from the optic nerve, the edema will also settle. And actually what is happening is it's not just the bone, but there's also a hematoma within the optic sheath. There's edema of the nerve, and therefore there's strangulation of the nerve. So removing this will actually help in decompression. And in improving the blood supply. So I think there are still more questions coming in. Yes, someone is asking about transcutaneous orbital endoscopy. From where is this question? Okay, so transcutaneous orbital endoscopy we actually published in the International Ophthalmic Journal called the Orbit. At that time it was one of the, well actually not one of the things, we did a large amount of research. At that time Dr. Rahul Modi was with us in Sion Hospital, and he helped with our research as well. And we at that time didn't find any other paper on transcutaneous orbital endoscopy. In fact, I was in a panel with Professor Castelnuovo in the same panel, and at that time he had just begun to do it in cadavers. So we have done it, we did it the first time around for a lateral orbital abscess with vision loss in a young girl, and we had done it transcutaneous, and it had worked very well. The way you do transcutaneous orbital endoscopy is you make a small incision in the lid crease, superolateral. This is transcutaneous orbital endoscopy is for lesions which are lateral to the optic nerve, which cannot be managed transnasally endoscopically. So you make a small incision here, and then you hug the bone of the roof of the orbit and lift up the orbital periosteum till you get to the retrobulbar area or lateral to the optic nerve. And at that point where you will actually on sagittal sections measure the distance from the orbital rim to whatever abscess, tumor, whatever you're dealt with, various other pathologies after that, hematomas, abscesses, tumors. So you measure that distance from the orbital rim, and at that distance, endoscopically, you cut the orbital periosteum, and then you will be directly on the lesion, and you will be able to do whatever is required. We always have an oculoplastic surgeon with us. Not an regular ophthalmic surgeon, because most of them deal with the cataract and the retina, and their confidence levels with oculoplastic procedures is less. So it's better to have an oculoplastic surgeon. If you don't have, you can have an ophthalmic surgeon, which helps us as to how much you can retract the eyeball. So pressure on the eyeball on the globe is what the ophthalmic surgeon will help you with. But the actual endoscopy in the orbit and the surgery in the orbit is, well, we've done it mostly the ENT doing the surgery, and occasionally the oculoplastic surgeon also working with us. It depends on what kind of quotient of, what kind of equation you have, and the experience of your oculoplastic surgeon, and how much you work together as a team. So that is about transcutaneous orbital endoscopy. I didn't mention that when you make that incision and then the endoscope is in the orbit. So unlike oculoplastic surgeons who retract and use a headlight, we retract the eyeball and put an endoscope into the orbit. And it's done on endoscopic control, watching the camera screen, I mean the monitor. So we've finished so far with the questions. I'll just find out how far they've got, how far Dr. Jankiram has got with organizing the next surgery. So Dr. Jankiram has relocated to Hyderabad, as he told you during the thing. And I think he is working in, at the moment, from where he is demonstrating, they have only one table. So therefore this delay and interruption, please bear with us. Okay, one more thing that we can talk about is surgery for extensive nasal polyposis. Dr. Jankiram will be showing you exactly how he does it. One way in which I do it is a little different from regular FES. I call it stepping stone surgery. So stepping stone surgery means, I'll give you an analogy. See, suppose there's a river that you want, or a stream you want to cross. Then you can wade across it, right? So that is like regular FES. That means you do an uncinectomy, open the maxillary sinus, ostium, bulla, etc., etc., etc. Okay, but now assume that that stream has a lot of crocodiles in it. Okay, then you can't do that. So you need another approach. So what approach we do? We'll find stepping stone. So you don't put your feet in the water at all. You step on one stone, then you find the next stone and step on it, and then the next one and get across the stream. So revision surgery or very extensive nasal polyposis where landmarks are not visible, you don't see the landmarks, all you can see is polyps coming all the way up to the vestibule. And in revision surgery, the landmarks have been removed. Then in that case, to do a routine FES, which is what experts will do because they know where what landmarks will be or not be and how to manage. But for someone who is in the early years of endoscopy, this thing, in all this mass of polyps, where do I find the uncinate? Where do I find the middle turbinate? They themselves will be polypoidal. How do I operate without getting into the orbit by mistake? Because there are polyps and the next thing I know, there is fat. Find one landmark, which is not traditional landmarks, not the traditional landmark FES. You find one landmark, then using that landmark, you find the second landmark.
They
then
wanted
using
to
that,
talk
you find
about
the third
respect.
one.
Oh. No.
Dr. Jankiram, are you ready?
Madam, we are almost ready. Can we start just describing the scan, some talk about CSF rhinorrhea?
Yes, yes.
Okay.
You can
Okay,
start
madam.
straight away.
So this patient is a very, 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 very interesting
Dr.
case.
Jankiram, you're taking the CSF rhinorrhea first, is it?
Yeah.
Okay.
The reason is we will do the polyp after this in case we have time. So this is a very, very interesting case. This patient is a female who is not very obese. What happened was she was actually going for a test for COVID. So RT-PCR was done, following which she developed a leak.
Interesting.
That's why I said very, 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 very. Have you heard this kind of history?
We have come across CSF leaks because of RT insertion, Riles tube insertion, but this is something unique.
Okay, so yeah, so now new indications can be included for etiology, etiopathogenesis, RT-PCR testing. So actually what has happened is they have taken it in this position. They have taken a extended position and they have gone there and straight away entered into the cribriform plate. So that is the history which the patient gives me. And following which she developed a leak. And of course, we will read the scan later. We will discuss about CSF rhinorrhea. CSF rhinorrhea, for the sake of postgraduates, fat, female 40 or 50. And it usually the site is cribriform plate. And that is the commonest site. And idiopathic. And we have Omaya classification, traumatic, non-traumatic. In that you have idiopathic as one of the main causes. And I think we can answer questions, right? Before we start. We can have a discussion rather than...
Maybe you can show us the CT scan. We can...
Okay. Okay, so we will show the scan now. So you can see here that the patient is having a watery nasal discharge from the left nasal cavity. If you look at the scan here, the scan you can see here, this is the frontal sinus, So this is the frontal sinus, left side, right side. You can see this is a CT cystino. So what is the best investigation of choice? In our practice, at least in my practice, I do a CT cystino. That is to me a very, very important investigation. If the patient refuses a CT cystino, then I go in for a HRCT with MRI. So MRI is cystino. MRI cystino, there are two varieties of MRI cystinos. Number one, heavily T2 weighted MRI is otherwise called MRI cystino. Usually what happens is some people, or in our center at least, we never give gadolinium. It stays in the brain for in the CSF for 24 hours. And there are some complications reported. So our radiologist, he says, sorry, boss, we'll do a heavily T2 weighted MRI. This is done with iohexol or metrizoamide. We can see this is the frontal sinus. You can see here some cells. Of course, we are not interested in all this. We are not going to open the frontal in case we are dealing with a cribriform leak. Now, what is it that you have to see in a CSF leak? Hey, can you give me better scans? This one, more cuts. Okay. Now, the first thing you have to do is you have to confirm whether it is CSF. And for that, here in Hyderabad, we do beta trace, and we get it in the same evening. In fact, now also we've got another case where we are doing it in the, got the result? No. Beta trace positive. So we do a beta trace, and that is the best investigation. Then if it is proven that it is CSF, we'll have to identify the site of the leak. For the site of the leak, we should also know the size of the defect, the site of the defect. To locate any defect, we need 3 axes. If you want to locate Banu, we have to have 3 axes: the x-axis, the y-axis, and the z-axis. X is like this, so he is 1 feet away from the door. He is, that is x-axis. Of course, he is on the floor because it is y-axis, and he is 2 feet away from me. That is z-axis. Same way, you need to locate all the 3 axes in a CSF leak. What are the landmarks? For example, like this, there is a door. Like that, what is the landmark? In a nose. There are 2 important landmarks. In ethmoid, there are 2 important landmarks. The first is the middle turbinate. The middle turbinate decides the x-axis. So if it is lateral to the middle turbinate, then it is a foveal defect. If it is medial to the middle turbinate, between the middle turbinate and the septum, it's a cribriform defect. This is the first thing you have to see in a scan. Now, this is the x-axis. The y-axis is always constant because it's in the skull base. There is no y-axis. The z-axis is depicted by the anterior ethmoidal artery. Whether it is anterior to the anterior ethmoidal artery, at the level of the anterior ethmoidal artery, or posterior to the anterior ethmoidal artery. If you can make these 3 in a case of a ethmoid defect, then you have fixed the leak. It is bullseye shooting. Now let us see here. So the first thing you have to look for is the middle turbinate. This is not the right scan. This is not a good scan, boss. Of course, this is nicely depicted, but then I want to show them the landmarks. This is without metrosomite. So you can see here, I'm just giving you an example. So this is the middle turbinate here. This is the middle turbinate. Look whether the leak is medial to the middle turbinate or lateral to the middle turbinate. So this is number 1. So look at the anterior ethmoidal artery. This is the anterior ethmoidal artery. So whether it is anterior to the anterior ethmoidal artery or posterior to the anterior ethmoidal artery or at the level of the anterior ethmoidal artery. So here the leak here is, you can see here very clearly. This is the leak. Very, very clearly seen. See, this is the infundibulum. This is the infundibulum. Right at the level of the infundibulum means it is at the anterior to the anterior ethmoidal artery. That means that swab has gone right across the cribriform plate. See, it is difficult to damage the fovea with a cotton. That means he should have been a weightlifter. So to damage a fovea, it's a thick bone. Cribriform plate is the thinnest bone. So he would have punctured it at the level of the cribriform plate, gone inside, and he would have created a leak. So this is the commonest, sort of theory which we can speculate. So at the level of the infundibulum, that means at the level of the maxillary os, if I go up, if I go medial to the middle turbinate, I should find the leak. This is all I have to do for this case. So don't complicate yourself. Don't do a Hadad flap for a case of a cribriform leak. I have seen many people, that's a clear-cut overkill. I want to tell you some very important factors. When do you call a leak a high flow leak or a low flow leak. Very, very clear. See, if you have two cisterns open, if you have two cisterns open, it's a high flow leak straight away. What is the meaning of a cistern? For we say cistern. Many people, juniors, may not know what is a cistern. Any space below the brain is a cistern. Any space below the level of the brain, that part is called that part cistern. For example, pons of the brain. Before the pons, there is a space. It's prepontine cistern. Below the optic chiasm, there is a space. It's subchiasmatic cistern. Above the chiasm, there is a space. It's suprachiasmatic cistern. Now, this one is subfrontal cistern. Below the frontal lobe, it is a subfrontal cistern. Subfrontal cistern. Hey, can I have some? Subfrontal cistern is a very low pressure cistern. Please understand. You should understand this basically. Unless the patient has real BAH, it's a very low pressure cistern. So you can ask me, is there any cistern which is really high pressure? Yes. There are two areas, two cisterns which are really high pressure cisterns. Number one is the posterior fossa. Anything coming from the posterior fossa is high pressure. Why? Because you have the tentorium above and it's a small space. So there's no place for the brain to expand. So it's restricted. So any posterior fossa leak is a high flow leak. So if you want to do a posterior fossa leak, like a clival leak, it's really a challenging thing. Number two, if a ventricle is open, straight away it's high flow. So lateral ventricle, third ventricle, whatever, fourth ventricle open, high flow leak. So these are the things you have to keep in mind. Or if suprachiasmatic and subchiasmatic, so suprasellar and subfrontal, these are all open, then it becomes a high flow. Apart from that, if you, some people judge like this. I opened that leak, sir. There was a fast flowing of CSF. So it's a high flow leak. It may be, but mostly it's not. So usually, whenever the patient with, are you with me, sir? I don't know if they are with me.
We are listening to you.
Okay. So basically, you always do an MRI for a case of CSF leak. You always do a MRI. MRI is inevitable. You should do a T2 weighted MRI. The reason is to rule out BIH. Why? Number one, ask whenever the patient comes, the first thing I ask them is, are you having headache? First thing I will ask, are you having headache? Second question I will ask, do you have tinnitus? The second commonest cause for tinnitus is BIH. So pulsatile tinnitus, common cause, BIH. Number three, if the patient with CSF leak comes, ask for blurring of vision. Blurring of vision, another important symptom in BIH. Then the patient can have some gait problems or sixth nerve palsy, sometimes even seventh nerve palsy. I've seen one patient with seventh nerve palsy with BIH. So these are the things you will have to ask the patient. Do you have tinnitus? Do you have headache? Do you have blurring of vision? Do you have giddiness? Do you have alteration of gait? Do you have had double vision? Why there is a mouth angulation problem? So these are the things you should ask in a case of BIH. Okay, if the patient has got a, for example, a middle fossa leak. Let us take a Stenberg canal leak. Or for example, a lateral sphenoid wall leak. There are two different entities. Stenberg canal leak is different from lateral sphenoid wall leak. So if you have that, you see whether it is connected with a arachnoid cyst. Usually nowadays, we always look for arachnoid granulations, arachnoid cysts, which are extending. These cysts become high pressure leaks. So these are the things we'll have to routinely get trained in. And if you look at, see, you should know what is modified Dante's criteria. So the moment a person comes with CSF, first thing you should think about is VAH, modified Dante's criteria. It should all come into your kitty. Then what you should do, you should always look for MRI, look for flattening of the optic disc, then tortuosity of the optic nerve, and then empty cella, then look for dilatation of the Meckel's cave, slit-like ventricles, all that you should look for. And then you will know that you're dealing with a BIH or a non-BIH. Non-BIH is pretty simple. Surgery is pretty simple. You don't need vascularized pedicle flaps for all CSF leaks. This is very, 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 very important. Many people think that only vascularized pedicle flaps are useful. No, it is not. It's a clear-cut overkill. There are two reasons why we use vascularized pedicle flaps. Number one, you classify the leaks. We are writing a book on CSF leak. I think it's getting released. Professor Aldo Stamm is co-authoring me, and it will be ready by the end of. So 2 books this year we are releasing. One is mucormycosis, one chapter written by Professor Renuka Bradu Madam. Fantastic chapter on orbit. So another is, of course, so many authors have authored it. Now, what was I telling? CSF leak. Yeah. So CSF leaks, if you look at it, many neurosurgeons argue that it should be done transcranially. I am telling you honestly, there is zero indication for transcranial repair unless only 2 conditions there is indication for transcranial repair. Number 1, tumor. If there is a tumor, do transcranial repair. Number 2, multiple comminuted fractures. These are the only 2 indications. And if you don't have these 2, any leak, any size can be repaired endoscopically. I have seen many patients, I'm telling you, at least 3 patients I've seen in the past 3-4 years. Patient got operated for CSF rhinorrhea, idiopathic. Patient operated, reoperated, 3 times operated for CSF rhinorrhea. One doctor's advised, 4th time I'll operate. What will you look for? What will you look for if the patient comes and says, I've operated 3 times for CSF rhinorrhea? Number 1, you look for BIH. Okay, but BIH also the doctor would have looked, no, 2nd time at least they would have looked, 3rd time at least they would have looked, some doctor. Look for lateral sinus thrombosis. Remember this, I have seen 3 cases now. All 3 missed diagnosis, missed. These are all googlies in CSF rhinorrheas. So the spot on in OPD I diagnosed, I think, who was there? My residents were there. I said, take a venogram. It was a MRV. MRV is taken. Clear-cut lateral sinus thrombosis was there. And a patient was sent for stenting. Why I'm telling this is, that is one googly. Second, patient again and again comes with CSF rhinorrhea, CSF rhinorrhea, CSF rhinorrhea. 3 times operated. What is the thing you have to think of? Think of paradoxical CSF rhinorrhea. So this also I have seen missed many times. Put the endoscope in the ear first before you see the nose, and you will clearly see SOM. If you see bubbles, cartwheel appearance, you see fluid, think of posterior fossa leak, and then take HRCT which covers the posterior fossa. You will not miss the leak. And to repair that is a different ball game. You cannot do it transnasal. So these are, I think we are ready, right? We are ready. I was just dragging the time, just giving some, of course, all this you can read in the theory. I'm just going to start the case. Any questions, madam? Who is moderating, please?
Any questions from the audience? I think you can go ahead, sir. If there are any questions, you can ask me.
Right. I'm going to wash up. My mic is on. Mic is on.
We
Boss.
can hear you. We can hear you.
Okay. Madam is there or she's left?
She's here, just gone, right? At present, she's not here, but she's here.
Okay. So here we are. So CSF rhinorrhea, wonderful topic. Fantastic topic. So many nuances involved. Okay, put off the lights a little bit. Let's start. Okay, we are now seeing the left nasal cavity. Okay. Now you can see that this is the inferior turbinate, the middle turbinate. You can see a septal body. Now just try to see whether it's a bony septal body or a cartilaginous one, which can be. So the patient is actually a Punjabi patient and I'm being assisted by a Punjabi doctor. That's nice. 2 Punjabi doctors. Okay. Ready? Shall we start? Okay, so left side. Okay, so give me a suction. There's some. Give me an elevator. So the first step which I would like to do in this case is lateralization. Not this, it's very short. This side, okay. Lateralization of the inferior turbinate. So this is the first step in my surgery. You have coblation, right? You have coblation? Not there. नहीं यार, please यार, coblation चाहिए यार. No, give new. Okay, so I have lateralized it. Now what I do is I try to inspect. See that I'm already seeing some glistening thing there. Can you see that?
Yes, we can see.
Yeah, so almost got it. So believe me, this is a 15 minutes case. Nothing big about it at all. So I'm going to show you. Yeah. Many people, what they do, coblation. Many people, what they do is they immediately go and cut off the middle turbinate. I don't know what the middle turbinate did to them in the last birth. They are very angry with the middle turbinate in CSF rhinorrhea. They go and first cut it. To me, I think middle turbinate, you don't have to cut at all. In fact, it's good if you don't cut. I'll tell you the reason. Now, a blue man, blue. New one. Yeah.
This lateralization you routinely do, or just because this was too medialized? You have
basically I start every case with lateralization only. This is my first step as a protocol. I do that because I get more space, and more importantly, if you see that polyp case next when I operate, I will show you the real philosophy behind it. Of course, Stamberger was against it when I used to present. He used to say, "Hey, Janikram, you're on the wrong foot." But somehow I liked it. I like this step. He said mucociliary bead will be altered. I have not seen that. Anyway, elevator. Now you see what I have to do is the next step is I start from behind. And I gently start lateralizing the middle turbinate. See what I'm seeing here? Superior turbinate. Can you see the superior turbinate? Now, what I will do is I know the leak is seen at the level of the anterior most end. So I have to lateralize it anteriorly. Nicely anteriorly. That's a superior turbinate. I'm lateralizing. Can you see the superior turbinate, all of you? All of you?
See.
See that, see that. What is it? What is this?
Yes.
See the sine K here. Can you see the sine K?
Yes, yes, yes. Very well seen.
Clearly sine K seen. See the sine K. Wow, see the leak. Can you see the leak?
Yes, yes.
Boss, can you all see the leak? So what has happened? That gauze piece or something like that, they went and created a sine K here and perforated here. Very, very, very. In fact, that roadmap of this one also procedure I can read, horoscope like thing. Can you see the defect, my dear friends? Very clear.
Yes.
Very, very clear. That's all. What is their big deal in this? See, don't use Haddad flap. Don't dissect the ethmoids. You don't need to. Why you want to dissect the ethmoids in this case? You don't need to dissect the ethmoid. Hey, why are you putting on my face? Now, see here. This is all. Hey, I don't think I need, man. Can you see the CS of rhinorrhea?
Yes, we can see that small pouch.
Small. This is called pseudo meningocele. Okay, what is the meaning of pseudo meningocele? Many people keep telling pseudo meningocele. Pseudo meningocele. What is pseudo meningocele? Why are they saying pseudo meningocele? Huh? What? What? See, that is that. See here. This is the defect. Okay, it is because a true meningocele should get all the three layers of the brain. That is the dura, the arachnoid, and the pia. What happens here? There is a defect in the skull. There is a small defect in the skull, through which slowly what happens is that, see, dura is a tough layer. Please understand, it cannot be like this. It's not like a very thin, pearly, this one. So this is actually the arachnoid pouching out. It is not the real dura. Dura is a tough layer. So it is actually the arachnoid which is pouching out, and the dura and the bone have gone. There is, so if you have seen that pseudo meningocele, the arachnoid will come. If you actually cauterize it, you will see that the dura is on, there will be a clear opening of the dura. So you can actually undermine the dura, do an inlay, onlay, all that stuff. So this is actually the arachnoid pouching, and you can see very clearly that this is the pseudo meningocele. Now you can ask me, why are you operating on a cramped place? This is a cramped place. You can very well resect the middle turbinate and do. Believe me, I need to have the cramped place. I need to have this cramped place. Why? Because this will act as a stent for me. And the healing is not only by the layers, which I'm going to put, it is by the middle turbinate. That is what I always tell. Now, I'm not going to take any fat fascia. Give me infiltration. Give me infiltration quickly. Yeah. So what I will do is I will take free mucosal graft. I will take. Hey, bipolar hai, coagulation hai. Do. Infiltration do. So any doubts?
No, beautifully seen.
Shichichar is there?
Right now, no, but he's somewhere around. Just gone for a cup of coffee.
I agree with her. You put it on her. So what? This is Asirvadam. Okay, now what I'm going to do is I'm going to harvest. Some more. Yeah, she gave me in a bad step and I didn't see and broke it. Knife. So I'm going to take a free mucosal graft here. Ready.
Dr. Janakiram, would you take the same graph if it was a spontaneous leak? Or would you do something different?
Same.
Okay.
Any cribriform, this is what I would have done.
Okay.
Whether it's spontaneous, whether it's traumatic, doesn't matter. This is exactly what I do for any of my cribriform leaks. It depends on the site and also the size. If this is around 1 or 1.5 millimeters in size, which is classic. There are three kinds of defects. One is small, second is medium, third is large. Small are classified from 1 to 4 millimeters. This is small only. And second is medium. Medium is, suction please. See how Shilpi is assisting me. This is brilliant assisting. See, medium is 5 to 1.5 centimeters. And large is anything above 1.5 is large. That's it. Okay.
And if it was a high pressure leak?
High pressure is a different ball game. If it is going to be BIH, first of all, I get a neurosurgeon. All patients of CSF leak, we get neurosurgical opinion. Number one. And they see the MRI, the fundus. These two are the main criteria. Of course, there are very few patients in which we have done manometric studies. So, but in a few patients which we did, it came out to be more than 30. So, average around 45 we have seen. The pressure more than 45 in fact. So, anything around 15 will be normal. Keep this. So, give me the coblation now. Coblation. So anything around 15 will be normal. So we see there's a small problem in this measurement of the manometric test, because if it's leaking, no, we may not. Hey, we may not get an accurate measure. Hey, suction illa suction. We may not get an accurate measurement of the pressure. So that is a little fallacy about the suction. By doing this, I don't pack this side nose at all. So the patient goes out. Okay.
We have to just prevent any corresponding injury. To
Absolutely. So you should not remove the mucoperichondrium on this aspect of the other side. Of course, the leak is too posterior, too high for it. So we will not do anything there. Okay, now that I've got my graft material, suction. Hey, this coblation is a little bad. Can you make that all right? Merosil ready, eh? Merosil. Okay, so I'm almost ready to close this defect now. The first step I do is actually, so I want this narrowness. Many people say, why do you keep it narrow? I'm telling you, I need this narrowness because I think I've heard Professor Keetane also, sir, also telling that, what is this? Why? I didn't ask for Merosil. No, I didn't ask. I said bipolar. So here, I have heard him say that Sinike actually closes the leak more than all your. So I'm just marking this area. This will be my posterior limit and this will be my anterior limit. So see that from here to here, everything else will be cauterized. Hey, next case ready, yeah? Why? Now, can you see here that that is the leak site? You can see that. Can you see that very clearly?
Yes, yes, we are seeing that.
That's the leak site now.
Yes, very
See
well
that?
seen.
Now I'm going very close to the leak site.
Mhm.
Surgical ready. Now what I'm doing now, look at me very carefully. I don't use my coblation over that area. I use bipolar. Bipolar. Why? Why do I use bipolar? Because I have faced one case of failure because coblation works at a very low temperature, whereas diathermy works at 400 degrees. And I need intense fibrosis. Wait. I use the Kasam, not this. ये कितना है यार? कितनी? नहीं आ रहा है। नहीं।
So you're
Can you see
cauterizing the
that? Can you
pouch?
see that?
Yes.
Nothing. I call it the chicken fatting. That is just put lot of heat on that. See, always if you ask the neurosurgeons, no, they say the bipolar itself will cause closure of the CSF leak. Many of the cellular defects, small cellular defects, we keep bipolar, and that closes the CSF leak. Give me surgical, please. So that's the side of the leak. Give me coblation, bipolar again. So some people say, hey, I didn't see that CSF leaking. You don't have to see that CSF leaking. You just have to, definitely that's the area of the leak. Honestly, I've never had a single failure of this. Many people also say, have you had failures? I've never had a single failure of this, except when I used coblation in one case. One case failed. We have definitely a very large series of such cases. And we have never had any failures, except for one case. Now, what you do is just pack with Surgicel. This is a Surgicel. Before Surgicel, what I'm going to do is to keep the free mucosal graft. Hey. So it seems to be sort of very easy, right? Is there any different way in which you do, Dr. Kanaga, madam? Hey,
I think I would expose the bony defect because we are not seeing the bony defect here.
But why do you want to see that?
I would pack the.
What's the idea?
I would pack it.
You will do a dumbbell fat?
Fat globule.
You will put a dumbbell fat?
Yes.
Madam, this is exactly what we have written in our book. See, there are some defects in which you have to do, and see what you're telling is what is called the interlay technique. So there are three techniques of closure for the sake of juniors. Number one is onlay. Onlays over the nasal side. So onlay is done on most of the cases of small defects and cribriform leaks. You do onlay grafting. You do inlay graftings for large and medium size. Inlay means inside. That is inside the dura. And between the dura and the bone is interlay. And that is done for most of the cases of medium sized leaks. So here onlay is more than enough.
Even for
Yeah.
a spontaneous leak, you would do an onlay graft?
Of course. It depends on number. See, the primary criteria, bipolar, is the size of the defect and also the pressure of the defect. If it is going to be a low pressure defect,
Normally, the
Then-
spontaneous leaks have a little high pressure defect. So there is a spontaneous flow
no,
of waste at high-
basically, madam, I think the word high pressure, what does it mean actually? What does a high pressure leak mean? No, give me a Surgicel. What do you mean by high pressure? See, basic frontal cistern is a very low pressure cistern. What is the meaning of a high pressure?
Yeah, I think you explained that wonderfully in just prior to the surgery.
What?
You explained the basis of high pressure and low pressure leaks.
Yes,
just
there are
prior to the surgery.
only two areas where we call it high pressure. One is posterior fossa. Second is opening the ventricles. Third is when there is BAH, you have definite high pressure. Number fourth is two cisterns. This is the definition for high pressure. Please, I am evidence-based. I'm not talking about my own terminologies. Give me bipolar. So if you're talking about this kind of leaks, even if you have idiopathic, whatever be the cause, a basic frontal cistern, a single cistern, hey, don't put too much of water. A single cistern with a low pressure, it's a low pressure cistern. So it's a low pressure cistern. How can you have high pressure in a, whether it's idiopathic? See, basically what happens in idiopathic, a fat female of 40, there is slow erosion, maybe vitamin D3 deficiency or something like that, erosion of the bone. And not necessary that you have a high pressure to cause it. It is not necessary. So he might have deficiency of the bone, anything like that. So pressure, high pressure, if you say if it is more than 20 centimeters of water, only then you can call it a high pressure leak. That is meaning of high pressure, or else there is nothing like high pressure. Scientifically, you cannot, elevator. You cannot explain a high pressure without doing a manometric test. That is the right way. Now you see what I did. I'm using this as a stent. This is used as a stent, completely locking that area. Completely locking that area. There is no way this will fail. There is no, because the middle turbinate is used as a stent. If I cut the middle turbinate, believe me, I'm not going to have this kind of stenting. Now give me the Merocil. See here, how I'm going to show this, how I'm cutting the Merocil. Hold, scissors. See how I'm going to cut it. This is very important again. This is again, see here. I take half the Merocil and then I cut it like this. See, this is how I cut it. And then what I do, I keep it upside down and I introduce it right inside the middle meatus. Elevator, you have to press it, Shilpi. We have traditionally been telling high pressure without actually defining what we are talking. Now, yeah, push. Push karo yaar, push karo. Push karo yaar. Karo. Acha. और भी थोड़ा. हाँ, बढ़िया. Thank you. नहीं. अरे यार, बहुत बढ़िया. Now, see, I didn't use fibrin glue. I didn't use fibrin glue. Fibrin glue again is a placebo. I use it sometimes when there is a sort of a patient where I mean, like fibrin glue has been studied extensively as a placebo. The idea is to keep this pack for 1 week. That's it. It'll stent it so tightly, and that adhesions will form that there's no way this patient is going to leak. And I believe on the middle turbinate for that. The middle turbinate. That is why I always say, don't cut the middle turbinate. There cannot be a... See, I keep telling, unless there is a concha... I think Vivek Sashindran once, he presented one case where he had a leak through a concha bullosa. That is an indication for cutting. Or if you have a leak lateral and medial to the middle turbinate, where you want to join the leak, you cut the middle turbinate. Or else there is no indication for cutting the middle turbinate, according to me. If it is lateral, go lateral and dissect and close it. If it is medial, go medial and dissect and close it. Why we want to cut the middle turbinate? So can you see that we have completely stented the middle turbinate there, all of you?
Yes, it's wonderfully seen.
So to me, I think this will definitely solve her problem. This is for sure. I can give you the follow-up status of this patient. So any questions, any doubts regarding this? I am ready to answer.
Great, a wonderful demonstration. Are there any questions?
Madam, with regards to the Stenberg canal leak, Madam?
Yes.
With respect to the Stenberg canal leak, we also did a study. I think we have published, I'm not sure. 36 patients we studied. We did free facial ADA with dumbbell fat in one section of patients, I think around 12 patients or something. And we did cross-court Haddad. Now we are doing what is called Haddad transposition. I've done already 4 cases of Haddad transposition. The paper is given by Pittsburgh. You can refer. We have just recently also done one case. 4 cases we already done of Haddad transposition. Means, what does Haddad transposition mean? You can do a ipsilateral Haddad for a Stenberg canal or a cavernous sinus tumor. How? Take the Haddad. Okay. Usually what we do is stop the nasoseptal flap till the level of the pterygosphenoid synchondrosis and the pharyngeal nerve, right? What I do is, I just elevate it till the sphenopalatine foramen. I do a medial maxillectomy, remove the orbital process of the palatine bone. And what I do is, I completely delineate the sphenopalatine artery going into the flap, going completely into the flap. And then I trace that artery towards the IMAX. And that Haddad is attached only to the sphenopalatine artery from the IMAX. And we take that flap and put it into the maxillary sinus. What will happen? Behind you will see the pterygoid wedge. From there you start drilling the pterygoid wedge, go to the cavernous sinus, do the cavernous sinus surgery. Ipsilateral Haddad flap itself can be used for reconstruction. So this is a new concept. Again, we are going to publish it after a few cases, but we have already done 4 cases of Haddad flap transposition. It has already been published by Pittsburgh. You can go and refer that paper. Now, what I mean to say is, Haddad flaps versus free flaps in Stenberg canal leak, we never found any difference in results. Results were the same. So it is not what was the prognosticating factor in such cases? It was only locating the defect and circumscribing the edges of the defect, bony defect, not the material used. So this is something which I want to insist. And if some people are fanatic about using nasoseptal flaps for Stenberg canal leak or cribriform leak, I think it's a clear overkill. It can be used for high flow leaks, yes, but you have to prove it's a high flow leak. You have to prove that it's a high flow leak. Then you use it. I agree. Am I able to convey that point, madam?
Yes, absolutely.
So what is the proof that it is a high flow leak? Number 1, MRI. MRI evidence of BIH, high flow, no question. Number 2, big leak, 2 cisterns open, high flow, straight away. Number 3, ventricle open, high flow. Number 4, big arachnoid cyst communicating with any any defect size, high flow. Then posterior fossa defect, high flow. Apart from this, I don't qualify anything unless you prove it by manometry showing that there is a pressure of 30 centimeters of water. I wouldn't accept it as a high flow.
Right.
And if it's a high flow, treatment is not hard flap or anything. Whatever you do, it will fail. You have to do a bypass procedure. It is as simple as that. You have to do a bypass. In the sense, you either do a lumbar drain or you have to do a thecoperitoneal. So unless you do, the brain will just push away all whatever you keep. If it's going to be a high flow, real high flow, none of your materials are going to stay there. It'll just cough out everything. We have seen that in cranios. Any number of cranios you have operated, we try to do, if you don't do a bypass, if the ventricle is open or high flow leaks, it will just cough out all your repairs. So it doesn't mean that just because you have kept some, maybe we are consoled by saying we do an inlay cartilage, everything. Oh, it doesn't matter. You do for a low flow leak, I think, onlay grafting. Small size, onlay. Mid size, go for interlay. And large size, go for all the 3 layers. And navel septal flap for sure. Anything more than 1.5 centimeter. This is my formula.
This is one question. When you talk about bypass, are you saying temporary by just a lumbar puncture or a permanent bypass procedure?
It depends. It depends. For example, we take the call depending upon the type of repair, the site of leak. For example, for a clivus, I am having a big clival leak. I'm doing a temporopalatal flap or a pericranial flap. It's a case of clival cardoma. I expect that the dura will crumble still further after radiation. I'm unsure because this patient can actually go in for a leak later. I would do a permanent bypass. So it all depends. If I left behind residual tumor in a cranio, I expect that the patient will get a radiotherapy later. I would definitely go in for a thecoperitoneal. Believe me, thecoperitoneal, every week we do 1 or 2 cases for high pressure leaks. This is norm in Royal Pearl. And lumbar puncture and drainage for 5 days, we do for example, I've opened the suprasellar cistern. And if the suprasellar cistern, we found CSF leaks. And my repair is quite good, but I'm a little scared. I don't want to take chances. Then that's the time when I go in for a 5-day lumbar drain. This is what I do. And that call, I sometimes dictate over my neurosurgeon. Sometimes the neurosurgeon says, let us go in for. So the call is taken by both of us. It's not a unilateral call. We take it in synchrony. But honestly speaking, if we don't do a bypass for a high flow leak, anything you do, it's going to come out. That's it.
Okay. And what is the amount of CSF that is drained for the lumbar puncture?
It depends. 30 cc we drain. So either it's going to be, it's all dictated by my neurosurgeon, but usually around 30 cc is what we drain.
Okay. Any more questions?
We go till 100. Hey, careful.
So there's a question. What is the, on which day would you do a shunting surgery?
Same day. Same day. Always same day. We don't make the patient leak again and do the shunt. So if I plan for that, I close the leak, the neurosurgeon comes in, or he stays back and then he does the shunt and goes out. That's it.
Okay.
See, I have a case now where I'll tell you some very good scenarios. Very good scenarios. I have a case right now, which I'm going to operate day after tomorrow. The patient presented with history of CSF rhinorrhea. Okay. This was repeated CSF rhinorias. I couldn't collect the CSF because whenever she came, she never had a leak, active leak. So there was no proof that it was CSF, even though she gave a history of CSF. We took a CT and an MRI. Both CT and MRI showed no defect in the skull base. Now, the patient now has been admitted with meningitis. Okay. Now, the scenario is like this. How do we proceed? So this is where I always say, I have to put the patient under GA and give intrathecal fluorescein with some amount of ringer lactate, and I will check whether the fluorescein is coming out to the nose. This also we do. This is an indication for examination under GA to see the site of the defect. We never go in unless we know where the defect is. We should know where the defect is, or else there is no role for number one, there is no role for number one, tablet Diamox for as a treatment protocol for CSF rhinorrhea. There is no role for CSF diversion in a case of idiopathic CSF leaks. There is no role for postponing your repair intraoperatively for CSF rhinorrhea. There is no role for any sort of diversion techniques as a treatment protocol for CSF rhinorrheas. These are all standard things which we follow. We will, if you have a post-traumatic leak, then we wait for a week. And that too, we'll assess the amount of CSF which comes, or the fracture line impinging. If it is impinging, again, we don't wait for more than 3 days. It's a horizontal, vertical fracture which is causing a ball valve, increasing pneumocephalus, straight away surgery 3 days later, or maybe even earlier. Or if the patient is having increasing amount of CSF on days to come, go ahead with surgery. Don't wait. So these are the protocols we follow.
Okay, right. 1 minute.
I'd just like to add one thing here, Dr. Jha.
Madam is there, huh? Madam?
Yeah, I'm here. I've been
I didn't hear you at all, madam. Madam said that you left. That's why I was talking emphatically.
No, I didn't leave. I just went out for a cup of coffee. I've been here. I watched the entire surgery. Very well done. Very well.
Thank you.
Just one thing I want to say, and that is, Sion Hospital is a big trauma care center. And so we see a lot of traumatic CSF leaks. And, the classical training is that, you wait, some people say 10 days, 15 days, 3 weeks. And if it is decreasing leak, wait. One thing I want to say is I've seen very often that a traumatic CSF rhinorrhea may stop. And then the patient comes back with meningitis. And that time, if there are multiple fractures, you don't know which fracture has been leaking. So it is very important that at the time that the patient is leaking, you must do a CT cysternography, or if for whatever reason they say the brain is too inflamed, don't do CT, at least do a CT bony cuts, very fine cuts, 0.5 or less, and do a T2 weighted MRI and document the leak. If you must document the leak in a traumatic, you may decide to wait and see, especially if the leak is stopping, but that at the time of the leak, you must document it, because subsequently, if the patient comes back with a meningitis and no leak, then you don't know what to pack.
Yeah, fully agree. But in that scenario, if the patient comes back with meningitis, I would definitely treat meningitis as the neurosurgeon would do. And then I would do a fluorescein, intrathecal fluorescein. This is my absolute indication. Absolute indication for fluorescein to me is multiple leaks, because that will pinpoint and tell where the site of the leak is.
Absolutely.
And this is our protocol.
Absolutely. How do you dilute the fluorescein? How much?
Point, that is for the sake of juniors. Point, it's all, you can easily remember, 0.2 cc of 5% fluorescein. So 2 into 5 is 10. 0.2 cc, 5% into 5 into 2, 10. Diluted over 10 ml of CSF, given over a period of 10 minutes. As simple as this. 0.2, 5, 10, 10. Only these numbers you have to remember. 0.2 cc of 5% fluorescein given over, diluted over 10 ml of CSF, given over a period of 10 minutes. But get a separate consent. I had a very, very recent case in Hyderabad. Very, very, very tricky case. Patient was operated for a tumor. Patient had was all right for 7 days. I kept a Hadad flap. And then what happened was, on the 9th day, he started leaking. The repair, I saw my video again and again. Repair was fantastic. I had done a very good repair, multi-layer, Duragen, Duraplast. I used all the possible plastic materials. But the patient had intractable cough. Now, when I did the endoscopy, the patient was developing a higher TLC and CRP was rising and procalcitonin was rising. He was not developing meningitis as such. I was very sure that Shilpi was very sure the patient is going in for meningitis later. I went to the patient, I told them, boss, in this scenario, you have to give me consent for fluorescein. And luckily, he gave me consent. With that fluorescein, only we could make out the leak. Or else 100% we could not have made out the leak, because post-operatively, everything looks sort of, fully packed here and there. It's very difficult for us to make out the leak. So what has happened is the Haddad had moved a little bit due to the cough at one particular point, and that was slightly oozing. So immediately we just recycled the Haddad and we kept it. Patient was fine. Why I'm telling is we should all have fluorescein and also the filter, the green filter,
the blue
of the
filter.
stores. Yeah, blue filter for diagnosing difficult case of CSF rhinorrhea.
Yeah, absolutely. Absolutely.
So thank you very much, madam. Are we seeing the next case also, or?
Well, we have a number of people still at the center over here. So I think we will show the next case. Let me just see what the time is and let me just check with the Alchem people. Give me a minute.
Next case, the interesting case of bilateral nasal polyposis. And that is the bread and butter, that is the usual case for juniors. So definitely I can, actually madam wanted to do that case first. Madam told you do that case first, but unfortunately that first boy actually had a big bleeding episode. And so we had to shift him and then we had to rush him to the surgery first. So, yeah.
Will you be taking few questions?
Huh? Oh, okay. Madam, yes, madam.
Will you be taking few questions? For
Questions
CSF?
now? Yeah, of course.
So
The problem, there is a small problem, madam. You announce, I should not announce. Hi, come. Swapnal is from KM Hospital, Bombay. What? Patient has taken food.
Oh.
Lucky you told, boss. Patient should not aspirate. Sorry, madam. Patient suddenly took food because he was angry. I think he was posted last. Yes, madam. I can take questions now.
Yes.
Any questions?
So there is a question from Dr. Ramasubramaniam from Chennai.
Yes.
He's asking, is there any role of PRP in CSF repair instead of glue or along with glue? Any
Madam,
role of PRP?
Again and again, I say only one thing, madam. This is what I think Professor Karau taught me. It is not the number of layers, the number of materials you use. It is how well you locate the leak and define the leak. This is the simplest teaching I've got from my seniors. I think the same was told by Professor Kirtane sir also to me when I learned from him. And I think Professor Renuka Bradu madam also would teach the same thing. You put PRP, you put tissue glue, whatever. But if you are not able to locate the site of the leak, you put the foveal leak in this case of a cribriform, naturally you will have a failure. Right. So I didn't use either tissue glue or PRP. Use whatever you want. But the thing is, locate the leak. That is more important.
I agree completely, Dr. Jankiram, because I feel that, I've compared before using tissue glue, the cases we did, and after using tissue glue, and I didn't find any difference. So like you said, it is a placebo. I believe very much that in slightly bigger defects, 5 millimeters and more, you must find the bony rim completely.
100%.
Completely.
100% agree. See, that is a place where we think about interlay or inlay or dumble or gasket seal, whatever you want. But that is the place you look for the dural edges. This is not the place. When you do this, what happens is you widen the leak. I've seen people, by doing all that, a 1 millimeter or 2 millimeter leak is transformed into a 1 centimeter leak. And you see in the scan very clearly, this is 1 millimeter leak. Where is that sagittal cut? You have the sagittal cut. This is a 1 millimeter leak. And in this, you want to define the bone margins and create. And I have seen some people using a lot of, curating and going inside, curating, make that 1 millimeter into a 7 millimeter, 8 millimeter leak. I think that is not the right thing. Yeah, I just also want to tell something regarding the snoring. I think we thank ResMed for having sponsored. So they have brought some machines here. So they wanted me to talk about this. ResMed, I think they have some very good CPAP machines and also some beautiful which can be connected to the telephone also. I'm sure all of you would be knowing about it. And we are also using a lot of this. I'm not trying to propagate. Thanks for that sponsor, which they did for this workshop with respect to the wands and things like that, because most of the patients were free of cost. So, yeah. So, ResMed, thank you. So, I can take questions, madam.
There's one more question which Dr. Cherry Roy has asked from Pune. And he's saying, what is the maximum size of skull-based defect operated endoscopically?
You mean by me or by evidence-based literature?
I think both by you and what you think on evidence.
I seriously have not gone into, if I want to quote evidence-based literature, I have not seen like that. In that angle, I've never seen. But in my book, I've shown there is one section of people in Arunachal Pradesh. I have operated on 3 of their tribes. In that, what happened was the whole brain was completely below the level of the middle turbinate, right from the frontal sinus till the level of the planum. And that was I have documents of that. I'm going to write. I mean, you can see that in the book which is going to come. And that's what, so the distance between the frontal sinus and the planum is around 6 to 7 centimeters. From the orbit to orbit will be around 4 to 5 centimeters. So we have operated on 7 centimeter by 4. Of course, we do anterior craniofacial resection, right? Anterior craniofacial resection is even anterior to the frontal sinus. We go half of the frontal sinus, we go right till the planum. So all that can be repaired endoscopically. So everything endoscopic. You don't need to see. I'll tell you what. When do you need to do a transcranial? Why do you need to do a transcranial? When you have vascularized pedicle flaps and you have now beautiful med pores. See, Medtronic has got beautiful med pores and they are self-integratable and you can beautifully fix it inside and completely repair the leak. What the neurosurgeons are going to do? They're going to lift the brain, they're going to retract the frontal lobe, they're going to cut off the olfaction, and they're going to do that. We're doing that very simply without any incision from the nose. I can't understand a single indication for a transcranial approach. I can't understand. Even if there is multiple leaks, I will carpet the whole skull base. That's it. I use the Janus flap. There are so many flaps now. Karau-Haddad flap, you have Janus flap, you have pericranial flaps. We can do an endoscopic pericranial. Not an issue at all. So basically, if you have the right technique to close a CSF leak, I can't see any reason why we involve transcranial approaches for CSF rhinorrhea, because it's ultimately going to leak to the nose. And we know exactly the anatomy of the nose from the orbit to the orbit, from the frontal sinus till the level of the tuberculum or maybe even the clivus. So what's the big deal? We can repair any size. There is no, see, size is not the criteria. It is the pressure which is the criteria. If you ask BP versus pulse, we always talk about FES, BP versus pulse. Pulse is more important, something like that. It's the same in CSF leak. It's not the size, it's the pressure. It is the high pressure which will cause a lot of problems. If you have high pressure leaks, then is coming the real post-operative problems.
Yeah, very well said. I'd like to add a little bit of my own experience. I have also seen leaks. I've seen a tumor done by a neurosurgeon, esthesioneuroblastoma, where he has taken a pericranial flap, and that got infected and shed completely, and the whole frontal lobes had come into the nose all the way below the level of the middle turbinate. And the septum had also gone, because he had, from above, he had eroded, removed the septum also. So there was no, Haddad nasoseptal flap to be taken. And so I did a multi-level repair, but I used the cartilage and the bone of the septum to, buttress the fat that I'd put first. And then I had to put a fascia because I didn't get a nasoseptal flap. At that time, it had done very well. So I agree with you that a large defect, always an endoscopic repair, definitely first, and sometimes even a second chance if it is a recurrence. So very few leaks now are being closed by the neurosurgeons. I just have to say, Dr. Kirtane has sent a message. He said that he has been watching your surgery and that he has enjoyed watching it, and he's a little disappointed that the third case is not there. We are also...
Sir, thank you very much. Actually, whatever you taught only we are doing, sir. What new we are doing, whatever you have, we call that Guru Dakshina, the Guru Pichai. You have put, and we have received like that, we are giving it. That's all. We are transferring the knowledge which you transferred to us. Only one thing I want to tell all the juniors, only one thing I tell all my residents. Please understand, if you want to be a fantastic skull-base repair surgeon, then you should be able to do dural knots. Please learn this. There is something which is called the dural knot.
Nitinol sutures you're talking
Yes,
about.
the dural knots. The dural knots. You can actually put the fascia lata and then get the edges of the dura and suture that endoscopically. You can suture that endoscopically. We do that routinely nowadays. If the sella is open, we open the sella like a flap. We close it with a suture. Everything is sutured. So I think if we have another maybe symposium, I'll show if you have a big leak, you have to be able to suture that. You should see Castelnuovo doing it. Believe me, that is divine. You will not find a single layer where there'll be a little CSF oozing here, there. Once you do, there are 3 layers of fascia lata he does, inlay, interlay, and onlay. And he sutures that. Maybe around 15 sutures he'll put. And after that, that was around many years back, I saw him, and then I started practicing. Needs a lot of practice. But then if you want to become a fantastic reconstructive surgeon, you have to do intranasal sutures along the skull base. And if you do that, you are many steps ahead of many reconstructive surgeons. So this is my honest appeal to the youngsters.
Right.
I can show you some sutures. Have you seen dural sutures? I'm not asking you, the juniors there.
No, they haven't seen. They haven't seen.
Would you like to see? Would you like to say it now?
Yes, you can.
Okay, get me proline, 10 proline. 10 proline, please. 10 proline.
So while we are waiting for the 10 proline, there's one more question. What is the role of omalizumab in extensive panpolyposis?
Yeah, that's a good question, actually. Now, see, there are various studies, in fact, studying the interleukin pathways. And we all know that interleukin 7, interleukin 5, interleukin 25 now, IL-25 is the target interleukin for most of the treatment protocols involved in nasal polyposis. And the best for nasal polyposis is dupilumab. So there's no doubt about it. There are many research articles. I personally have used it when I practice in Kuwait. So dupilumab is good. But speaking very honestly, the cost involved, number 2 is the injections which we give. And number 3 is, we do it only for recurrent cases. There's some patients who really recur very badly. Even though you do a good job, you're frustrated. It's called recurrent polypoidal rhinosinuropathy. You see, old Stamberger book edition, he would have given a separate description of chronic polypoidal rhinosinuropathy. This is a separate entity. Whatever you do, it's going to come back. So this is the cases I reserve for dupilumab. And omalizumab for CRS, yes, but I have not had any personal experience on that because CRS responds very well to other modalities of treatment as well. But dupilumab is very good, very promising. IL-25 targets. Okay, now let us see how we start with this. I just want to demonstrate. Give me a suture. Okay, now. So can you all see this? Can you all see this?
Stitch your hand.
No, don't worry. So, so that's the dura. This is the nose. And of course, I use a 3-0 or 4-0 or 5-0. And that's the dura. I take a dural stitch here, right? I take a dural stitch here and then it comes out like this, right? Right? Comes out like this, right? Out of the nose. And then what you do, see carefully what I do. So this is how you hold it. Okay. This, I think, is called also the Pittsburgh stitch. I'm not sure about the name, whether it's been published. I don't know. So hold it like this. See here now. Then rotate it once. My dear friends, you should do this as an exercise when you're doing it in the medical college. Rotate it twice, okay? And then pass the suture through these two. And then move your left hand. Move your left hand. And then go closer, my dear friend. See how the stitch goes? Can you see that? Sorry.
Yes.
Can you see that? So
Yes,
that's the dural stitch. And I want all of you to practice this regularly because this will come in very, very handy when you have the dura exposed. And again, I teach you this because this is one of the most, I'm sorry, she is Yashoda Hospital owner. I can't do this to you. She's my fellow. I'll ask you to come here. Okay. Come here. I'm going to show you this. Can you hold your hand? Not like that. Don't worry. I'm not going to punch you, man. Hold it this way. Yeah. Okay, Anandi. Now, hey, focus it again. See, this is what you have taken. Again, see here. This is outside the nose. This is the nostril. Right. Hold it this way. Hold it this way. One rotation. Second rotation. And then move it through both and then move your left hand. Hey, focus, huh?
Yeah.
See that knot.
Yes, beautifully seen.
So that's it. So if you know how to do this, I think, believe me, you will be ultimate in reconstructive surgery. In fact, we now had our microvascular surgeon and we tried this. Actually, we tried this with a free flap to reconstruct a clival defect. But honestly, he was struggling because he was not used to this. So we are now going on to the cadaver labs, myself and my plastic surgeon, and trying to do something on this to evolve on to free flap repairs in reconstructive options and clival tumors, because we do a lot of skull base. So that will be the next generation of reconstruction. So you will be seeing that very soon. Maybe I will bring him one day and we will do that. So that will be the next generation, free flap repairs.
So there's one, I think now one last question that I have. It's from Dr. Ramasubramaniam from Chennai.
Yep.
And his thing is use of PRP. I assume he means platelet rich. Okay.
We answered that question. Right?
Yeah, you answered it. Yes. Okay. That's about it. So, Dr. Jankiram, thank you so much.
It's an honor, madam.
Absolute veritable feast of surgical cases, and for sharing so generously your knowledge and your experience with everyone.
Madam, what you gave, I'm giving. That's all. Nothing new. All thanks to people, teachers like you, who have taught us the next generation, and we are actually giving it to the others. That's all. Nothing. Yeah.
No, well, I don't know what I gave you, but I definitely learned quite a bit today, and it was a great pleasure. So once again, thank you so much. Thank you for honoring my request, and wish you all the best.
Thank you, madam.
Please
Thanks
can
a
we
lot.
have a large round of applause across the country for you.
Thank you, madam. Thank you. It's a big honor to operate in front of gurus like Dr. Kitne sir, you, and then many, many big stalwarts. Thank you.
Thank you. Just a word about tomorrow's program. It's online, starts at 10:30 with a lecture by me on osteology of the paranasal sinuses and skull base, and then dissection by dissection plus. Just a word about tomorrow's program. It's online, starts at 10:30 with a lecture by me on osteology of the paranasal sinuses and skull base, and then dissection by dissection plus surgical video, I think, session of all the anatomy seen on first FES and then in skull base surgery. So that is from 11:30.
Convey my best wishes and regards to another great professor, Professor Rida Kamal.
Yes.
My very close friend, and of course your brother, and he has come and, I went to his house and he, great hospitality he showed. Convey my best regards to him. Thank you very much.
Right. Thank you so much. Yes, I will convey it. Yes. So we break for today. There's dinner arranged by Alchem, and as we come to the end of today's live sessions, once again, I'd like to thank Alchem for helping us organize this session at a short notice. I was worried that we would not have any audience because of such a short notice and so much of confusion in doing this. But I'm happy to know that all the centers were full and that people waited till the end. Right. So thank you once again, Alchem team.
चालू हो रहा है। Hello. So good evening, all respected doctors and esteemed dignitaries. I am Pranat Purohit on behalf of Alchem Laboratories. Would like to thank Dr. Renuka Brado, Scientific Course Director, Switch CV ADEPT IRIS, for designing such an excellent academic module for this August event and helping us in coordination with all the faculty members. I would like to thank Dr. Milind Kirtaneshwar for guiding us in making this event successful and contributing his expert opinion during the panel discussion. I would like to thank our operating faculty, Dr. Janki Ram, for demonstrating the surgical techniques for extensive sinonasal polyposis. I would like to thank Dr. Samir Bhargava, Dr. Gaurav Medikari, Dr. Anga Joshi, and Dr. Khitisa for making the panel discussion interesting and insightful. I would like to thank each and every delegate for taking time out from their busy schedule to attend this scientific feast and making Switch CV ADEPT IRIS successful. I would like to thank our PMT members, Mr. Vivek, Mr. Nitesh, Mr. Kedar, and Mr. Sashi for their excellent coordination to ensure successful execution of this event. Last but not the least, I would like to thank all the field colleagues who has put their best efforts to make this program a mega success. Once again, my sincere gratitude to all the faculty members, panelists, and esteemed delegates for being a part of Switch CV ADEPT IRIS, and I look forward for mutually beneficial relationship in times to come. Before I conclude today's session, I would like to invite you for tomorrow's session, which already Madam has briefed. That will start tomorrow at 10:30 a.m. and you can access the same with the same link provided. Tomorrow we'll start with the academic session by Dr. Renuka Brado, followed by a cadaveric dissection by Dr. Reda Kamel from Egypt. So thank you very much, all of you, and have a wonderful evening ahead. Thank you very much. Have a nice time. Good day.
I request everyone to please proceed towards the dinner, and even the counters are open for. Thank you.